Yeah, okay. हेलो डियर स्टूडेंट्स, कैसे हो आप सभी लोग? वेरी वार्म वेलकम टू ऑल ऑफ यू एट आवर ब्यूटीफुल प्लेटफॉर्म Cerebellum Academy. Yes, we are going to do one conceptual brainstorming integrated session for anatomy. It will be not useful for the anatomy, but it will be also useful for all the other 18 subjects. So just please inform me that everything is okay, audio, video, everything is okay. Sorry for little delay due to the technical settings. So we are going to do one beautiful session with the proper three-dimensional orientation. Yes, we will see each and every muscle, nerve, artery. Please inform me that everything is okay. Yes, yes. So I'm having the chat box. Yes. So here I can see. Yes, thank you everybody. Thank you. Yes, Farhad is here. Osama is here. Yes, Ankit is here. Yes, yes, yes. Thank you. So my all the respected teachers are also here. Thank you so much, sir. Thank you. Yes, Ankit is here. Subhash is here. Alok is here. Yes. So can we start? Yes, there is the one question by the hot chalk. So yes, we had celebrated the chocolate day yesterday. So here hot chalk is also. This session will be 4 to 5 hours. So maintain your stamina, maintain your energy, and yes, with the fun, with the very interesting way, we will create the our proper concept. Agree, everybody? So before that, yes, next pattern is coming. And you are looking that anatomy question, they are earlier asked 15, 20, 10, but nowadays they are saying, yes, now the anatomy is having the less weightage. What I want to inform you, try to understand each and every question in your NEET or INICET or any kind of the question pattern. It starts from the anatomy. Okay? If your anatomy is weak, then each and every subject is weak. Okay? So we are going to start. Yes, this is the bullet train anatomy, Osama. So I want to inform you that it is rapid revision. Agree, everybody? It is the rapid revision. So we will not stop. Focus, concentrate over the screen. Keep open your ear. Yes, active. Keep active your brain. Fine. Whatever I'm writing here, whatever the notes, it will be provided in the PDF form. So don't worry to write down. Agree, everybody? Fine. Okay, so Osama is saying for the shairi. So can we start with the shairi? Okay. So this is dedicated for the anatomy. कोई तुमसे पूछे कौन है एनाटॉमी तो कह देना कोई खास नहीं, एक दोस्त कच्चा पक्का सा, एक झूठ है आधा सच्चा सा, कभी हंसने का कभी रोने का, बस एक बहाना अच्छा सा, राहों का ऐसा साथी है, नीट पीजी का ऐसा साथी है, INICET का ऐसा साथी है, जो दूर नहीं और पास नहीं, कोई तुमसे पूछे कौन है एनाटॉमी तो कह देना कोई खास नहीं. Yes, definitely it is not special, but remember it is very special. So everybody, hope you all are ready. So thank you very much. We are going to start from the very basics. First, what I want to tell you, whenever you are starting the anatomy, remember you have to start from the basics. Few basic concepts I am going to tell you. Yes, before that I want to remember my all the respected teachers who given the knowledge to us. We are not so talented. We are getting the knowledge from our teacher. We are making the creativity and we are passing this knowledge to next generation. And it will be your responsibility to share the knowledge. My humble request to all of you that we all teachers are also the student. Agree, beta? So we are learning from our seniors, our friends, and we are sharing that knowledge to all of you. I also want to request you, share this knowledge to your friends and your juniors. Remember, creativity is contagious. Pass it on. Fine? Agree? So, now, what I want to tell you, one more thing. I fear not the man who has practiced 10,000 kick once, but I fear the man who has practiced one kick 10,000 times. Getting the point? Practice gives perfection. Agree, everybody? So we are going to start this on the points. See here. First I want to tell you anatomy. What is the anatomy? Remember, always I start from this point. Ana. Ana means to see. And Tommy means remember cutting. Agree, everybody? So what is the anatomy? Anatomy means, yes, you have to cut and observe. You have to cut and observe. Integration, yes, means dissection is anatomy. Yes, remember, you have to see the similar kind of the word, that is autopsy. This autopsy word is also formed by the auto plus C. Yes, this is your forensic medicine and toxicology integration. Agree everybody? We are starting from the very basics. Fine? Yes, everybody, hello, hello. Fine? Yes, Osama is here. Doctors on board. Thank you, beta. Thank you. Shri, hello, beta. So, getting the point? Yes, auto C. This is the anatomy. We have to cut and we have to observe. हम खुद की बॉडी को कट करते हैं और ऑब्जर्व करते हैं. We cannot cut our own body. So what we will do? We will cut the dead body, which is cadaver. So remember, in our first MBBS, we give proper respect to the cadaver. This cadaver is first teacher for all of us. Getting the point? Yes, cadaver is God for medical students. Fine? So give proper respect to the cadaver. We are going to cut the cadaver and we are going to observe. Agree everybody? Fine? Now try to understand. We are going to look one beautiful concept. Yes, catch it. Suppose I am going to tell you all the boundaries, fossa, yes, roof, floor, this all the things in a single concept. Try to understand. We are cutting the arm transverse section. So how it will appear? Yes, sir, it will appear rounded. Always I start from these basic points. So all the different kind of the fossa, popliteal fossa, femoral triangle, cubital fossa, all the roof boundaries from one single thing. This is what our magical anatomy. Agree? So when you are cutting the arm, the outermost layer, sir, it will be skin. Done? Now try to understand just below the skin. Yes, you will get that there is our layer of the fat. Yes, sir, there is a layer of the fat. This layer of the fat is known as, everybody tell me. Yes, sir, this is fascia. It is above, that's why you will say superficial fascia. Agree? Now, just below the superficial fascia, you will get the layer of the collagen. Sir, this is our deep fascia. Agree, beta? Yes, sir, it is our deep fascia. Agree, everybody? Now you are cutting the arm. The first layer, ratana nahi hai. Look at your hand. What is the first layer? Yes, skin, superficial fascia, then deep fascia. Femoral triangle, you are doing dissection. Femoral surgery, you are doing. Inguinal hernia surgery, you are doing. What you will get? Skin is the first, then superficial fascia, then a deep fascia. Getting the point? So try to understand the innermost structure. Definitely, it will be our bone, and bone is giving the attachment to the our different kind of the muscles. Agree? Agree everybody? Yes, sir. These are our muscles. Simple diagrammatic presentation. First session is basic concept. If your basic concepts are strong, then definitely you will crack each and every point in anatomy, medicine, surgery, ENT, ophthalmology. Okay. Now catch this point. What are the different layers in our body? So deep fascia. Then you can see the muscle, and then you can see the bone. So remember this concept. There are the 5 layers in the body. What are the 5 layers? Yes. 1, 2, 3, 4, 5. Now try to catch this point. This deep fascia is sending the partition to the bone. Yes, it is intermuscular septa. So every part of the body is divided into the compartment. Arm is divided into the anterior compartment, posterior compartment. One thing I want to tell you, every compartment is having their own, yes, vein, their own artery, and their own nerve. Agree everybody? Yes. So every compartment, each compartment is having their own vein, their own artery, and their own nerve. Getting the point? Fine. It is totally, yes, I want to tell you everybody, keep patience. If your general will be weak, you cannot touch the radio, you cannot understand the surgery medicine. If your basic concept are strong, from basics to the top level in this 4-5 hour session, definitely we will crack. So keep patience. If you are having the patience, you can definitely understand. Otherwise, remember, you can do, but your concept will get problematic. So what I want to tell you, every compartment is having their own, yes, vein, artery, and nerve. What I want to tell you, there are the 639 muscles in the body. Getting the point? Yes. And sure, there is one question. This particular muscle is supplied by the which nerve? Remember, every compartment is having their own nerve. So the nerve of the particular compartment, it is supplying our muscle, it is supplying the joint, and it is supplying the skin also. So one simple law. This law is known as our Hilton law. Remember, there are the 639 muscle. Damn sure, one question from the muscle. This particular muscle is supplied by which nerve? There will be any kind of a clinical scenario where you will need this knowledge. So how you will know? This is the one magic, this is one concept. Remember, the nerve of a particular compartment, it will supply all the muscles of that compartment. It will supply the skin over that compartment, and it will supply the joint also. Example, in the arm, entry compartment, posterior compartment. In entry compartment, sir, there is the musculocutaneous nerve. So this musculocutaneous nerve, it is supplying all the muscles of the entry compartment of the arm. Yes, what are the different muscles? I will tell you with the proper three-dimensional orientation. Try to understand. Yes, see here, this is our upper limb. Can you see this is the entry compartment? This particular muscle is having the two heads. So this is the biceps. The nerve in this entry compartment is musculocutaneous nerve, which had been asked in your NEET PG 2021 question. Yes, musculocutaneous nerve is coming, and it is nerve of the entry compartment. So it will supply all the muscles of the entry compartment. BBC. It will supply the biceps. Yes, sir. Then it will supply the brachialis muscle. Yes, sir. It will supply our coracobrachialis. We are going to see each and every muscle and all the important points. Agree, everybody? Fine. So now what I want to tell you, these are the different muscles which are getting the innervation by which nerve? The nerve of the entry compartment. Remember, Ganga river is flowing on the north side, and Krishna, Kaveri, Godavari, they are flowing on the south side. Remember, Ganga will supply only and only the north side states. Getting the point, beta? Fine. So what I want to tell you, जो नर्व जहां रहती है, जहां बहती है, उस कंपार्टमेंट को, वहां की सारी चीजों को सप्लाई करती है. सिंपल लॉ यू हैव टू रिमेंबर. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. सो इन द सिमिलर वे, आर यू गेटिंग द पॉइंट? दिस इज आवर हिल्टन लॉ. व्हाट यू हैव टू रिमेंबर? द नर्व ऑफ द एंट्री कंपार्टमेंट, सर, musculocutaneous nerve, so it will supply all the muscles of the entry compartment. Yes, the radial nerve is the nerve of the back of the arm, so radial nerve will supply all the muscles of the back of the arm. Triceps. Yes, in our forearm on the entry side there are the muscles. Yes, there are the different muscles. There is the median nerve and the ulnar nerve, so these are supplied by the median and ulnar nerve. On the back side there is the radial nerve, so all the muscles of the back of the forearm, it will be supplied by the radial nerve. This knowledge will be useful for your orthopedics and the medicine. Agree, everybody? Fine. So hope you all are getting the point. Yes, so all the respected teachers are here, so thank you very much for your blessings. So we are going to look for our more points. Yes, sir. When we are looking any part, roof is formed by, sir, upper structures are formed by, can you see? Skin, superficial fascia and the deep fascia. These are making the upper part of the body. So remember the question from your INICET, that was our, yes, cubital fossa. Remember, always roof are created by the skin, superficial fascia, deep fascia. Yes, always the questions are asked from the anatomical snub box. I will tell you. Fine. In orthopedics or related with the anatomy, yes, questions are asked from the anatomical snub box. If the question is asked, what is the roof of the anatomical snub box? Yes, you have to say, sir, skin, superficial fascia, deep fascia. अक्सर ऐसा कहा जाता है एनाटॉमी रटना पड़ता है. मैं आपको कह देता हूं एनाटॉमी बिल्कुल रटने की जरूरत नहीं है. यू हैव टू यूज योर कॉमन सेंस. यस, दिस ऑल आर विजिबल. Only one thing which you can carry in your exam hall, yes, cheating material, that is the anatomy. Your own body you are carrying in the exam hall. Okay, everybody getting the point? Fine. Yes, Sanjeev, thank you, beta. Fine, everybody. So what I want to tell you, these all are the different structures. Remember, any fossa, any part, either our cubital fossa, yes, femoral triangle, or anatomical snub box, popliteal fossa, all the spaces, all the fossa, all the things we are doing in a single flow chart. Remember, roof is always formed by, sir, skin, superficial fascia, deep fascia. At the depth, there is the muscle and the bone. Yes, boundaries will be created by. Can you see here? This is the keep patience, beta. Keep patience. Only one thing I want to tell you. This is the space. So you will see boundaries are created by the muscles. Yes, sir. Boundaries are created by the muscles. Yes. And what are the content? You can see, sir, vein, artery, nerve. So you will see there is a content vein, artery, nerve. Agree, everybody? Fine. So this was our first session. Fine. So we are going to look for our more thing. Transverse radial artery is roof. Yes, we will see, beta. We will see in our anatomical snub box part. Skin, superficial fascia, deep fascia. Yes, Kalpita at the superficial fascia, there are the structures, cutaneous nerve and vessels. So we will see cephalic vein is lying at the roof. We will see better. Okay, fine. So now we are going to look for the more thing. So everybody, with this basic concept, can you see what are the questions which are asked from the general anatomy and terminology? Are you ready? So we are going to talk regarding the question, our previous year question, NEET PG 2020, the type of the joint marked in the image below. So here is the marking. Can you tell me? Tell me, answer. A option, synadesmosis. B option, synorthosis. C option, synchondrosis. And D option, synovial joint. Can you see? Everything is syn. Yes. Now tell me. Yes, definitely beta. Again, I want to inform you to each and every student, please focus over the skin. Please focus what I am telling. Whatever the PDF, whatever the annotated file, everything will be shared in our platform. So don't worry for it. Okay, fine. So everybody, tell me what is the answer. This is our, yes, vertebral column, and here is rib. I am showing you, I am asking you with the three-dimensional pattern. Try to understand. Catch this point. Yes. You can see here, sir, this is our vertebral column, and here you can see the rib. So can you observe? Yes, this rib is articulating with the vertebra. Tell me. Yes, this rib is articulating with the vertebra. So what is the joint which is formed in between the rib and the vertebra? This is our costo means rib, and vertebra, costovertebral joint. Yes, remember this costovertebral joint, as well as, can you see? This our costotransverse joint. This is plain. Yes, synovial fluid is there. This is our synovial joint. What I want to tell you, this is our synovial joint. Try to understand. Discussion and analysis. One question sure from the joint. Important topic. One question damn sure from the joint. Directly or indirectly related with our orthopedics. Without joint knowledge, you cannot move single step in your ortho and medicine. Fine, everybody? Yes, very good. Answer is D. Answer is, so look here, many students, you are doing the mistake also, beta. Yes, answer is D, not the C, beta. This is our synovial. Agree everybody? Now we are looking for the next NEET PG 2019. Can you see? 2019, then it is the 2020. Can you tell me the movement at which joint permit a person to look right and left? Yes, it is very easy. Repeated question. Tell me. So answer. Yes, thank you, Dr. Anshul Sharma. Thank you, beta. Thank you. Yes, tell me, beta. Now, what is atlanto-occipital, atlanto-axial, C2, C3, or C3, C4? So definitely this rotatory movement right to left is done at our C1, C2 atlanto-axial. So remember again our three-dimensional orientation for all of you. See here. Can you see? This is our skull bone. Yes, sir. And here is the vertebra. Fine. So this is our first cervical vertebra, and here is the second cervical vertebra. So in between the atlas and axis, there is the atlanto-axial joint which provides the rotatory movement. Agree everybody? Yes, this is our axis, odontoid process. Integration with the forensic medicine. If there is a fracture of this part, it will damage to the medulla oblongata. There is a damage to the medulla oblongata in case of the hanging, and there is a death. So this is important. Yes, atlas is rotating around it. So there is a right to left movement. This is which kind of a joint? This is pivot joint. Agree everybody? Yes. So this is your question. Now see here another question from the general anatomy. What is the nerve supply of the structure marked in the image? This is INICET 2020-22, but this question had been repeated many times. So this is the direction of the muscle fiber. Yes. This question had been repeated in the 2018-19, either in INICET or the NEET PG. What is your answer? Radial nerve, yes. Median nerve, yes. Ulnar nerve, or musculocutaneous nerve. So tell me what is the answer, beta? Yes, tell me. Yes. See here, you can see these muscle fibers are unidirectional. Fine. Yes, we will see these muscle fibers are arising from this particular tendon. This particular tendon is going to our digits. So this is responsible for the flexion. Yes, sir, it is flexor. Going to the digits, that's a digitorum. And muscle is arising, so it is not the superficialis, it is the profundus. So definitely these muscle fibers which are having the unidirection, yes, single direction. These are Ascaris lumbricoid like muscle. These are our, yes, lumbricals. Getting the point? And it is related with the first finger, so definitely it is our first lumbrical. So later I will tell you, there is the फर्स्ट लुम्ब्राइकल, सेकंड लुम्ब्राइकल, थर्ड लुम्ब्राइकल, फोर्थ लुम्ब्राइकल. यहां से किसकी नदी जाती है सर? यहां से मीडियन नर्व की नदी जाती है. यहां से किसकी नदी जाती है सर? यहां से अल्नर नर्व की नदी जाती है. सो रिमेंबर द फर्स्ट एंड सेकंड लुम्ब्राइकल सप्लाइड बाय द मीडियन नर्व, third and fourth lumbrical they are supplied by the ulnar nerve. So answer is your yes, median nerve. Agree everybody? Yes, Anshul, you are right beta. Anamika, you are right. Very good answer. You all are very amazing. Yes, Divyanshu, Abhishek, Shalini, Ashutosh, very fine. Yes, Priya, very good beta, very good. Fine. Yes. Now we are going to see, these are our important questions. So we are going to look for the topic of the joint and direction of the muscle fiber. So try to understand what is the joint. You all are aware. Quick revision. Joint is the junction between the two bones. Yes, sir. So there is the our bone. Can you see? Yes, sir. There is our one bone, two bone. If these are connected with the fibrous connective tissue, then it is our fibrous joint. There are the three types of the fibrous joint. You can remember with the beautiful mnemonic, funny mnemonic, Sa, Su, G. Okay, so this is your funny mnemonic. Remember, fibrous joint is S for sutures, S for synadesmosis, G for gomphosis. No excuse, it is important. Fine. Then another joint. Yes, if there is the two bone, yes, two bones, and there is the our cartilage is filling the gap. So this is the cartilaginous joint. And last you have to remember, yes, two bones are there, but in between there is a synovial fluid. Then you will say this is the synovial joint. Agree everyone? If you are getting the point, just give me the thumbs up, just give me the fire, just give me the heart, any kind of the emoji you can say. Okay, fine. So try to understand fibrous joint. I am going to tell you the few basic concept. Yes, try to catch this point. See here, sir, if two joints, they are having the parallel surface together. Yes, sir. So this is our plain fibrous joint. So articulating surface is parallel together. Getting the point? But if the articulating surface, they are oblique in nature. So remember, this is our squamous. So do this one. Sir, there is a plain suture. Yes, fine. We are looking the sutures variety. Yes, if there is an oblique surface, then oblique suture. And if there is the our zigzag kind of the surface, and in between them there is fibrous connective tissue. Agree everybody? Fine. So this is our serrated suture. So simple. Plain suture, squamous suture. Yes, there is the serrated suture. And if you are observing, there is a tooth-like appearance. One bone is getting inserted into the other. Agree? So this is our dentate suture. And last you will see there is the our, yes, one bone is peg-like and other is socket-like. So this is the peg and socket joint. Agree? Everything is here. Plain suture, squamous suture. Diagram is also serrated suture, dentate suture. And last is our, yes, wedge and groove suture. Getting the point? Yes, this is the wedge and groove. Fine. Not your point. This is also known as the shin dialysis. I am showing you in the 3D what are the different example. Try to catch this point. See here, better look here. Can you see? The plain suture. Plain suture, articulating surfaces, they are plain. So this is our nose part. Here is the plain suture. Yes, questions are asked. You had seen in your previous year question. And can you see here? And in between the temporal bone and this is the parietal bone. So this is your squamous suture. Agree? Now, can you see? This is our two parietal bone. So in between the two parietal bone, there is a serrated suture. Agree? And this is the strongest suture, tooth-like. They are interlocking together. Dentate suture. And last, you can see the our side. See here, this one, shin dialysis. One bone is triangular and it is getting fit into the other bone. Yes, this is our nose, posterior nasal aperture. Agree? So this is our single bone, ENT MCQ, ENT integration. Sir, this is our vomer. And here is our sphenoid bone. So diagrammatically, can you compare with this? Yes, this is shin dialysis. Rostrum of the sphenoid. Sphenoid is getting inserted into the vomer. This is wedge and groove. Yes, getting the point? This is the wedge and groove. Peg and socket is different. We will see our gomphosis. Agree, beta? Fine. So, hope you all are getting the point. Look here, synadesmosis. This question had been asked many times. If there are two bones and in between there is the ligament. So this is the synadesmosis. Remember, this inferior tibiofibular joint, I am showing you the beautiful example. Look here with the proper three-dimensional orientation. Can you see? Sir, this is our radius. Remember this one. This had been asked in your NEET PG exam, INICT, then repeated in the FMG also. Can you see this is the radius? Here is the ulna. You can observe the ligament. Yes, two bones are interconnected with the ligament. This is the interosseous membrane. This is the synadesmosis. Yes, in your AIMS pattern, this question had been asked. Can you see this one? Look here. This is the question. This is the radius, tibia and the fibula, and it is connected with the your fibrous connective tissue ligament. This is again synadesmosis. Even the inferior tibiofibular joint, here is also the ligament. So these all are the synadesmosis. Are you getting the point, everybody? If you all are getting the point, just give me the thumbs up, just give me the fire. Yes, yes, yes. Yes, you have to remember the Sasuji. Okay, because Sasuji is very important. All the word will be depending on here. Okay. So celebrate the Valentine Day. Yes, remember your Sasuji also. SSG you have to remember. Fine. Now look here. Gomphosis. It is found in the gum. So easy. So teeth and gums. Remember this is the pegant socket. While the shin dialysis, it was our, yes, the shin dialysis joint is our wedge and groove suture. Okay, fine. Now we are looking the cartilaginous. Two bones. If they are filled with the cartilage, cartilaginous. Remember, if it is ossified later, then it is the primary cartilaginous. Getting the point? If it is ossified, then primary cartilaginous. But if it is not ossified, but in between there is a fibrous connective tissue, then it is secondary. So what you have to remember, the primary is also known as synchondrosis. याद रखना, sin का मतलब होता है fusion, chondro का मतलब cartilage. So there is the fusion of the cartilage due to the ossification. One thing you have to remember, our epiphyseal growth plate. For the orthopedics, it is very important. Between the epiphysis and the diaphysis, the joint is the primary cartilaginous. While the symphysis, no excuse, you can remember the mnemonic miss. Yes, all the midline joint, M for manubriosternal joint, I for intervertebral disc, S for symphysis pubis. This all are the secondary cartilaginous joint. Agree, everybody? Fine, fine. So hope you, yes, thank you, Anshuman, thank you. So hope you all are getting the point. Fine. So focus properly, and we are going to look at the three-dimensional orientation. Question beta सीधा यहीं से आएंगे. Joint topic is very important. Yes, look here. Can you see the midline joint, sir? This is our pelvic part. You can see this particular fibrocartilaginous plate. This is our secondary cartilaginous joint. Agree? It is midline. Now can you see there is a sacrum? Yes, sir. And here is the our coccyx. So in between the sacrum and the coccyx, yes, this is the sacrum and here is the coccyx. So sacrococcygeal, it is midline. Yes, it is secondary cartilaginous. Can you see there is the our vertebra. In between the vertebra there is a intervertebral disc. All the intervertebral discs, they are presenting the secondary cartilaginous joint. Yes, and also you will see the our xiphisternum manubriosternal joint. Okay, everybody. So this is all the points which you have to remember. Now look here, synovial joint. Yes, definitely the importance of the synovial joint. Remember the shoulder joint, hip joint. These are the questions which are going to ask in orthopedics. Synovial joint. You all know there is the plain synovial joint. When the articulating surface, it is parallel together. Yes, what are the different joint? Yes, mnemonic is the Picasso, the famous painter Pablo Picasso. So the patellofemoral, I for intercarpal and intertarsal, C for costovertebral and costotransverse. This question had been asked in your NEET PG. Getting the point? This question is asked. This question had been asked in your NEET PG. Also INICET. Costovertebral, costotransverse, these are your joint. Which kind of the joint? Sir, these are the plain synovial. While the acromioclavicular, superior tibiofibular, these all are the plain synovial. Yes, ball and socket joint. So you know the mnemonic SHIP, ship. So we are integrating with the pharma. Okay. So do you remember the mnemonic for the drugs which are getting metabolism with the our, yes, acetylation mechanism? Do you remember? Sulfonamide. Yes, sir. And in the similar way, tell me, be active. This is the hydralazine. Getting the point? I for isoniazide, P for procainamide. But here the classical example of the ball and socket, shit is your mnemonic. S for shoulder joint, H for hip joint. Sir, these are very easy. But remember, this is important. Incudostapedial joint, this is your ENT integration. Yes, and our talocalcaneonavicular joint, this was the question from the INICET AIMS. The talocalcaneonavicular joint, it is the classical example of our, remember, ball and socket joint. Agree, everybody? Fine. So I'm showing you that three-dimensional orientation, beautiful orientation for all of you. This question had been asked in your, yes, INICT. Can you see the foot bone? Yes, sir. We are enlarging, we are enlarging, we are enlarging. Can you see? This is the talus. Yes, sir. It is our talus bone. So this is head of the talus, which is making the ball. Yes, sir. It is the ball. This is the ends question. Okay. So what I want to tell you, it is getting attachment. It is articulating with the our navicular bone, and here is our largest bone of the foot. This is the calcaneum, and in between here there is the spring ligament. There is the spring ligament. Yes, calcaneo-navicular ligament. So there is the formation of the ball by the our navicular bone, calcaneal bone, and yes, remember there is our spring ligament. So this is making the ball. Here is the socket. Remember, this is our talo. Yes, sir. Calcaneo. Yes, sir. And here is the navicular. Talo-calcaneo-navicular joint. It is the ball and socket. This question had been asked in your INICT pattern. So what I want to tell you further. Yes. Remember our hinge joint. It is very important. You know, door acts like the hinge. हम दरवाजा खोलते हैं, मेहमान को बोलते हैं आइए. So what is your mnemonic? IE. Yes, IEA. IEA. I for interphalangeal joint. Yes, sir. E for elbow joint, only one movement like the door. Yes, A for ankle joint. Complete बेटा. इतना ही पढ़ना है, इसी को बार बार रिवीजन करना है. You have to remember the words of the Bruce Lee. Fine. You have to practice the same thing for the 10,000 times. Now, the saddle joint. When you are looking that there is the one joint, one bone is concavo-convex. Concavo-convex. Okay, so this is saddle variety. What are the different example? Picks you can remember. Yes, P for patellofemoral, I for incudomalleolar. So this is important. We are covering the ENT question. Yes, this is the ENT topic. The joint between incus and malleus. The question from the NEET PG. Yes, remember NEET PG 2020-22. The question had been asked about the our yes incus. We are integrating with the ENT. Yes, incudomalleolar joint. Yes, first carpometacarpal joint and sternoclavicular joint. This all are the saddle. Agree everybody? Definitely one question from the your joint topic. Okay, fine. Now look here. Yes, ellipsoid joint. कैसे याद करना है? See here, E for ellipsoid joint. Try to understand. There is the articulating surface which is elliptical. ये E है. Just push the E, you will get the M. Yes, it is making M. M for metacarpophalangeal joint. So just do this movement. Yes, it is just like the ball and socket, but it is not too much having the free mobility. Yes, it is having the restricted movement. M for metacarpal. Yes, E for you can see ellipsoid. Just push it. It is making the wrist. Remember, this wrist joint is our ellipsoid. Also the atlanto-occipital joint where yes movement is occurring. If you will say, sir, give me biryani party, I will tell no, I will not give the biryani party. Yes, this is no movement. This is no movement. Where this no movement occurring? Remember atlanto-axial joint. But where is the yes movement? You will say, sir, I will give biryani party to you. I will say yes. Getting the point? So do in your own body. This is important. Earlier there was a DNB pattern and this all the question had been frequently asked. So hope you all are getting the point. Yes, yes, yes. Tell me if you all are enjoying this session. So just give me your thumbs up. Just give me your every kind of pattern. And remember few points beta. जो बीत गया सो बात गई. जीवन में एक सितारा था, माना वह बेहद प्यारा था, वह टूट गया तो टूट गया. अंबर के आनन को देखो, टूटे कितने इसके तारे. लाइफ में कई लोग आते हैं, कई लोग चले जाते हैं. एंड डोंट वीप फॉर देम, डोंट मेक एनी काइंड ऑफ द प्रॉब्लम. ओके, व्हाट यू हैव टू रिमेंबर, यू हैव टू लाइव फॉर द टुडे. व्हाट वी आर डूइंग, वी आर स्टडीइंग. सो फोकस राइट नाउ. जो बीत गया सो बात गई. सो फोकस राइट नाउ, फोकस राइट नाउ. Okay, thank you. So whenever you are getting the bored, just tell me. We will do any kind of the shairi, we will do any kind of funny story related with our topic. So this is our ellipsoid joint. Now I told you the pivot joint. Whenever there is the rotatory movement, remember the C1, C2, the superior and inferior radioulnar joint. Remember supination, pronation. This is related with the pivot joint. And remember this middle radioulnar joint is our synodesmosis. I told you. Yes, see here one time. Again, I'm showing you. This one is your very hit question. Can you see? Beautiful. It will be useful for your orthopedics. This is radius. Here is the ulna. You can see the annular ligament. Within this annular ligament, the head of the radius rotates. Rotatory movement means which joint? Pivot joint. Agree everybody? Yes, 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 yes. So remember, rotatory movement is the pivot joint. So yes, you can see here. Fine. So at the inferior side also there is a one ligament within which the head of the ulnar rotates. Agree everybody? So whenever there is a rotatory movement, sir, this is our rotatory movement. Pivot joint is answer. Sir, there is a rotatory movement during the supination pronation, superior and inferior radio ulnar joint. These are the pivot joint. Agree everybody बेटा? सबको समझ में आ रहा है? Fine. So now we are getting the point further. Now try to understand our condylar joint. Remember the knee joint and temporomandibular joint, they are our bicondylar joint. It is not the hinge joint. Don't do mistake because they are the two condyles. So this is the knowledge about our this all the joint. Now the muscle fiber. Try to understand. These are the muscle fiber. If the muscle fibers they are parallel together, parallel muscle fasciculi. Yes, you can see the parallel muscle fasciculi. Yes, sometimes you will see the fibers are converging together. So this is your triangular muscle. Sometimes you will see, sir, there is the axis and the fibers are unidirectional. So this is your unipennate fiber. You can see here, sir, this is our axis, but fibers are in the both directions. So this is the bipennate. Can you see the multipennate fiber? Yes, sir. See here, this is another important basic concept. These are our different kind of the tendons. Agree, beta? Yes, sir. So here are our different kind of the tendinous intersection, and you are getting that muscle fibers are on the both sides. So this is the our multipennate. Agree? Yes, you are correct. Dr. Disha, you are correct. Temporalis is the triangular. Yes, you are right. And orbicular is where the muscle fibers are orbital. So such kind of the knowledge will be useful. Yes, different kind of the muscle fibers are there. You will see the circular muscle, orbital shape. You will see the convergent fiber like the pectoris major. So on the basis of the muscle fiber direction, you have to identify the cadaveric image. Agree everybody? Fine. So these are the our different points. Can you tell me one three-dimensional orientation? See here, tell me what kind of the fiber is here. This is the one question. Type the answer. Yes. Now, can you tell me what is the kind of the muscle fiber here? This is our pectoralis major. So tell me what are the different answer. Yes, yes, you are right. You are right. Fine. So remember, on the basis of this, you have to identify the direction of the muscle fiber. This will help you for the identification of the cadaveric image. Agree everybody? Fine. Now we are going to look. Yes, so we had completed our first session, basic concept. Again, revising for all of you, how the body is organized. Sir, body is organized from the skin, superficial fascia, deep fascia, then there is a muscle and there is a bone. Revision. Okay, practice gives perfection. So either the popliteal fossa or the femoral triangle or the abdominal surgery, everywhere in ortho, surgery, obs, gynae, this is your way. Yes, what are the different layers? Skin, superficial fascia, deep fascia, muscle and the bone. First session. Then we had seen for the Hilton law. Yes, जो नर्व जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. So all the muscles of that compartment will be innervated by that same nerve. Yes, sir. This was our first session. Second session, general anatomy. What are the important points? Joint you have to study and the direction of the muscle fiber you have to study. Fine. So now we are starting our gross anatomy part. Agree? So are you ready? After this basic concept, we are starting our systemic part. Fine. So the most of the question they are asked from the head, neck and the neuroanatomy. So first we are going to crack this portion. Agree? Agree? Fine. So the question. Tell me the answer. A patient presents with a drooping of the angle of mouth. Okay. And inability to blow. There is the no whistling activity. Which of the following nerve is injured? Definitely it is the case of the facial palsy. So you all are right. Answer is 7. Agree? So we are getting the point. This is your question from the NEET PG 2020-22. Question from the cranial nerve. One question sure from the joint. Yes, we are doing the forecast. भविष्यवाणी कर रहे हैं हम कि NEET PG 2023 में क्या क्वेश्चन आने वाला है, directly or indirectly. Yes, one question from the joint, one question from the our muscle fiber direction. This knowledge will be helpful. Okay, so this is the first question. Can you tell me next question? Yes, NEET PG 2022. Again, this is the question from the cranial nerve. So I'm telling you the one more topic. Yes, suppose 15 questions are going to ask. One question from the joint, one question from the your muscle cadaveric image, and sure one question from the cranial nerve part. Agree? So patient complains of the headache, sir dard with periorbital pain. Yes. Tearing, lacrimation, drooling of the saliva, jaw spasm. there is the jaw spasm. Maybe the involvement of the muscles of mastication with light and accommodation reflex normal. So this is your clue that light and accommodation reflex normal. Third cranial nerve is normal. Agree? Neither dilated nor constricted. Feature of the patient can be explained by the involvement of the which of the following. So you can see there is a drooling of the saliva. Okay, sir. Sir, this is the facial palsy. Okay, fine. You are right. In facial palsy, there is a drooling of the saliva. But this is the controversial question pattern. Look here. Yes, my dear children, look here that there is a jaw spasm. Yes, there is a tearing and lacrimation, periorbital pain. This all are the features indicating for the sensory nerve of the face. So best answer is the our fifth cranial nerve. Agree? Fine. Yes. Trishita is right. Priya is right. Very good. Very good. Shalini, you all clap. My clapping for all of you. My clapping all for all of you. Concentrate each question and each option. See here, it is controversial. You can say, sir, there is a drooling of the saliva. Sir, this is the Bell's palsy. But the maximum features they are going for the our fifth nerve. Now, see here. Yes, one question. Embryology and histology. Very few questions are asked, but if you want to study the embryology, definitely you have to study remember you have to study the pharyngeal apparatus. Okay, so I will teach you this pharyngeal apparatus part, but can you tell me what is the answer here? Yes. It is saying development of the structures related with the tetany. Tetany is related with our parathormone. Getting the point? Yes, sir. Parathormone. Parathormone means parathyroid gland. And also there is a thymus. Remember this thymus and tetany, they are developing from the yes. So alpha, anamika, disha, you all are right. Yes, you can see this is the blue color, which is ectoderm cleft, first cleft, second cleft, third cleft, fourth cleft, and this is the pouch, first pouch, second pouch, third pouch, fourth pouch. So this is the point which is developing the parathyroid and the thymus. Yes, parathyroid gland as well as thymus, these are developing. So answer will be C. I will describe this all the points. Okay, don't worry. Can you tell me one question sure from the pharyngeal apparatus? Why? NEET PG 2019. Which of the following muscle develops from the first pharyngeal arch? Now tell me what is your answer. Yes. Tell me. So first pharyngeal arch. No, not C. This is your, yes, remember digastric, the hybrid muscle of the neck. Anterior belly, it is a derivative of the first arch, while the posterior belly, it is derivative of the second arch. So first pharyngeal arch, answer is anterior belly of digastric. So what I want to tell you, one question from the joint, one question from the muscle, definitely one question from the cranial nerves, and one question in embryology, pharyngeal apparatus, directly or indirectly for the 2023. Agree everybody? Yes. Now see here the next question. NEET PG 2021. Tell me better. Tell me. 33-year-old male. Patient has undergone submandibular gland excision. Yes, sir. And the duct of the submandibular gland, Wharton's duct. Yes, it is ligated. Which of the following nerve is most likely damaged? Okay, so one thing I want to tell you from the Gray's Anatomy as well as from the BD Chaurasi textbook. See here, this is suppose our submandibular gland. Agree, sir. And here is our submandibular duct. Remember, the lingual nerve is very close to it. Yes, lingual nerve is first laterally, then it is running below, and then it is running medially. Getting the point? So remember, this is our submandibular gland. Yes, sir. This is our Wharton's duct. And which nerve? Sir, this is lingual nerve. And its relation is, remember, it is related. It is our basic concept. Don't forget it. Sir, it is first laterally, then it is below, and then it is medially. So your mnemonic is LBW. We are looking for the question NEET PG 2021. What I want to tell you, one question from the gland. Either our parotid gland or the submandibular gland or the sublingual gland or the thyroid gland. Remember, one question sure from the glands, either from the surgery or from the ENT or from the anatomy. Agree everybody? So remember, right now there is a cricket match between the India and the Australia, and Jadduji, our Sir Jadeja came forward. Okay, and yes, the bowlers, they are doing the LBW. Mohammad Shami is doing the LBW, leg before wicket. So this relation is important. Don't forget it. The question had been asked. Lingual nerve is coming. It is first laterally, then it is below, and then it is medially. Just turn this M, it is converting into W. So this is the beautiful way you can remember. Fine, getting the point? Yes, we will do better one by one. Again, are you getting the point? Yes. So you are saying, I'm repeating Subhashish for you, beta. Yes. The lingual nerve, it is laterally, then it is below, and then it is medially. So when you are ligating this Wharton's duct, the most common chance to get the damaged lingual nerve is the best answer. Other nerves are also, but the best answer is our lingual nerve. Agree, everybody? Yes. LBW, Subhashish, you have to remember, beta. Okay. Now see here. Again, next clinical question, a 37-year-old patient met with the road traffic accident, admitted with the skull-based trauma and difficulty in swallowing. Sir, it is the ortho case. Sir, it is the trauma case. Fine. The doctor was touching the marked structure. So, here is the point. Getting the point? Yes, here was the touching. So, it is our, yes, definitely, sir, it is our uvula. Getting the point? So you are doing test for the uvular reflex, palatal reflex. Which of the following nerve is being tested? Tell me, what is the nerve supply of all the palatine muscle? All the palatine muscles, these are supplied by the 10th nerve. But better answer is vago-accessory complex. But it is contributed by the many other nerves, which is the pharyngeal plexus. Fine. So if you have to opt one answer, remember there is our touching activity and there is our contraction. Fine. So you will see there is the structure you are touching. So answer, this is supplied by the vagus nerve. So vagus nerve is the best answer. Yes, Kalpita, you are right, beta. Raman, you are right. Dr. Bean, sir, you all are right. Very good, very good. My clapping for all of you. You all are very perfect. Now see here, the NEET PG 2020. So who will crack this question? Which of the following structure prevents the upward extension of the thyroid swelling? Yes, it is deglutition test. ENT, medicine, conceptual brainstorming, integration. Getting the point? Yes, it's attachment to the thyroid cartilage. So tell me which muscle is preventing? Remember, there is one muscle coming from the sternum going to the yes, thyroid cartilage. Fine. So below to it, there is the one muscle. So I'm showing you these different muscles. Can you see? Sir, these are our neck muscles. The wide neck muscle is the platysma. Okay, sir. There is one big muscle which is taking origin from the sternum. Yes, sir, sternum. And the clavicle. Yes, sir, clavicle. So this is sternocleidomastoid. Fine, sir. Now, look here. We are removing this all. So you can see the ribbon-like muscles. Yes, sir. There is a ribbon-like muscle. Fine. Can you see? It is taking origin from the sternum part and it is going to the hyoid. So this is the sternohyoid. Getting the point? But our thyroid cartilage is located. Yes. This is our one muscle. Can you see parallel muscle fasciculi? It is taking origin from the sternum and it is going to our thyroid cartilage. So this is the sternothyroid. The thyroid gland is located just below to it. This muscle will prevent upward extension. Agree, everybody? So answer here your yes, sternothyroid. Getting the point? Sternothyroid, just below to it there is our thyroid gland. Now see which nerve passes through the foramen marked in the image below. So this is the bullet train anatomy. We are covering not only the MCQs, PYQs, we are also covering our, remember, we are also covering our theory part, important things with the other subjects integration. Agree? So what you can see, which nerve is passing through the marked foramen? Can you tell me? This is the mandible. What is the answer? Lingual nerve or the mandibular nerve or the chorda tympani or the inferior alveolar nerve? Yes. Remember, what is your answer? The inferior alveolar nerve is coming from here. It is passing through here inside and as the mental nerve it will come out. Yes, sir. This is our inferior alveolar nerve. Why it is important? For your ENT, for your dental procedure, there is our inferior alveolar nerve block procedure. Agree? Very good. Very good. Alpha, Naveen, Dr. Bean. Very good. Dark Knight. Very nice. Hussain. Very good. So answer is inferior alveolar nerve. Now can you see there is another question. What I want to tell you, this is the question integrating with the ENT with your surgery. Yes. So we are integrating with the anatomy. Tell me, beta, tell me, identify our nerve marked in the arrow. Yes, sir. Can you see this point? Which nerve is located here? Fine. And you can see the options like the great auricular nerve, laser occipital nerve, facial nerve, auriculotemporal nerve. Remember, here is the one muscle. Which muscle? Sir, sternocleidomastoid. Fine. Yes, sir. There is our sternocleidomastoid. just behind the sternocleidomastoid there is the one point. Yes, this is our nerve point from where the different nerves comes, and the nerve which is coming and it is supplying to the auricle. This is the great auricular nerve. Don't forget it. Yes, it is our great, because it is the main nerve supply of the pinna, ENT integration. Fine. Now also remember that there are the more nerves. Supraclavicular nerve, it will go down. Yes. Transverse cutaneous nerve of the neck, it will go transversely. Yes. Laser occipital nerve, it will go backside. Fine. So the great auricular nerve is the best answer here according to the direction. Everybody getting the point? Yes. Great auricular nerve is the option. What I want to tell you, NEET PG 2018, even 2017, 18, 19, 20, Fraze syndrome. We will see the integration with the Fraze syndrome. Agree? Yes, auriculotemporal nerve syndrome. Frequently asked question from the ENT surgery. So don't miss this great auricular nerve. It is very important question. So what I want to tell you, yes sir. Till now, what are the questions for the NEET PG 2023? I am writing here. First question, yes, one question from the joint integrating with the ortho. One question sure. Another question, muscle or the cadaveric image. Definitely. Third question, yes, cranial nerve. Getting the point? Cranial nerve, sure. Fine. Another question, pharyngeal apparatus, clinical. Agree everybody? So these are the list. Also remember your glands. Surgery. Anatomical point will be used here. Either it may be your parotid gland or submandibular gland, even the thyroid gland. Agree? So till now we had seen these 5 topics, sure short, directly or indirectly related with the ENT or surgery. Agree everybody? Yes, yes, Alpha, you are right. Loss of sensation in the shaving area. Correct? So we are starting this point. Tell me. This is the embryo. We are looking the embryology, the pharyngeal apparatus part, head and neck area we are starting. Can you see this baby? Sir, this is our head bulge. Getting the point? Can you see this is our, yes, cardiac bulge. And remember, it is a bullet train anatomy, so we will not get slow. We will fastly we are covering our different kind of the theory part also. So this is the cardiac bulge. On the side of the cardiac bulge, can you see the upper limb bud? Yes. At the lower side, can you see this is our tail part? So there is another bud. Yes sir, this is our lower limb bud. Can you observe at the back side there is a segment? Sir, these are our beautiful somites. Agree? Now between the head and in between the cardiac there is the opening. This opening is nothing, sir. It is our pharynx, stoma. So there is one very special kind of the structure developing at the stoma. Yes, this is our nothing but pharyngeal apparatus. Agree everybody? Yes. So hope you all are getting the point. Now look here. Where the pharyngeal apparatus is developing, sir, it is developing near the pharynx part. So these are giving rise to the origin area near the pharynx. Agree everybody? Yes. So remember, these arches are developing from each side and they are meeting at the middle line. So first arch is making this point, then second arch, then third arch, then fourth, so on. Agree everyone? Fine. So this is the way the first arch, second arch, different arches. So remember, जहां फर्स्ट आर्च है वहां की चीजों को ये डेवलप करेगा. फाइन. सो व्हाट आर द डिफरेंट थिंग्स? ट्राई टू अंडरस्टैंड. This is our embryo. Yes sir. Again revision for all of you. One thing. Yes beta Jerush. Again I want to tell you to all my amazing students, to all my beautiful students, the PDF will be shared in our platform. So don't write, only and only observe, and remember, and in between whenever you are getting bored, tell me, I will tell you the शायरी. Yes. अर्ज किया है दरकत के पैमाने पे चिलमने हुस्न का फुरकत से यूं शर्माना. Are you getting the point? Yes, enjoy the session. दरकत के पैमाने पे चिलमने हुस्न का फुरकत से यूं शर्माना. अरे भाई वैलेंटाइन वीक चल रहा है, खूबसूरती की बातें, प्यार मोहब्बत की बातें तो होनी चाहिए. दरकत के पैमाने पे चिलमने हुस्न का फुरकत से यूं शर्माना. पहली लाइन समझ में आई हो तो मुझको भी समझाना. Okay, so this was one funny thing. So hope you all will enjoy, and whenever you are getting the bored, yes, lots of the shairi, lots of the motivation, lots of the song for all of you. Okay, so my clapping for all of you, my thumbs up for all of you, my heart for all of you. And if you're enjoying the session, please send me your heart, your flower, any kind of the emoji. बेटा ऐसा नहीं लगना चाहिए कि आप मोबाइल में पढ़ रहे हो. मुझको ऐसा नहीं लगना चाहिए कि मैं कैमरे में पढ़ा रहा हूं. Getting the point? हमको क्या लगना चाहिए? ऐसा लगना चाहिए, yes, we are sitting in front together and we are learning together. Agree? So yes. Thank you, Alpha, Dr. Bean. Thank you, everybody. Yes, word of entertainment, definitely, but I will use the English maximum, but in between, few shairi, few jokes, yes, I will use in Hindi also, okay, bye. But remember, 99% totally our English, fine. Now we are going to see these babies. Three-dimensional orientation. Can you see? Sir, this is head. Sir, this is heart, cardiac bulge. So this is upper limb bud. Yes, sir, here is the lower limb bud. So you can see, sir, this is the pharynx. So can you see? We are cutting the baby from the back. We are cutting the baby from the back, and you are looking from the back side. So outside layer, sir, this is our ectoderm. Sir, this is our pharyngeal cavity. So inner side layer is our, yes, endoderm. And in between the ectoderm and endoderm, there is mesoderm. Yes, sir, this is our mesoderm. Agree, everybody? Fine. So this pharyngeal apparatus is having the three layers. Now what we are doing, do three-dimensional orientation, hold this embryo and turn it. When you are turning, it is appearing in this way. Again, I want to tell you, sir, this is ectoderm, middle part is mesoderm, and inner part is endoderm. Agree, everybody? Fine. Now remember, the ectoderm, mesoderm, endoderm, they are having the competition. The mesoderm is growing fastly. 6 pharyngeal thickenings are formed near the pharynx. So this mesodermal thickening, they are making the arch-like structure. They are making the round thickening at the pharynx. So these are the pharyngeal arch. Pharyngeal arch means mesoderm. Okay. So can you see? There is the 1, 2, 3, 4. Fifth arch totally disappears. So there is a sixth arch. And can you see? There is the ectoderm. Yes, sir. This is the ectoderm. But endoderm. This is the endoderm. Fine. You can see this is the ectoderm. In between the two mesoderm, ectoderm is indipping. Yes, ectoderm is indipping. This ectodermal indipping is cleft. Are you getting? Ecto, cleft. Both are having the T. Fine. And you can see there is the endodermal. Yes, endodermal bulging. This is the endoderm. Sir, these endodermal bulgings are pouch. Agree, everybody? Fine. Yes, beta. See here, you can go at my platform. There is our detailed video, but this is the bullet train anatomy. So just one summary I'm giving. Otherwise, in detail, this is the such kind of the topic you will read once and you will never forget. But this session, this entire pharyngeal apparatus, it requires 1 hour. I'm not giving. So this is our Indian. But this is the only this point you have to remember. If you want to get in detail, we will do another session for it in detail. Okay, but right now bullet train anatomy. So can you see there is our first arch, second arch, third arch, fourth arch, sixth arch. Fine. We are looking this thing from the back side. So you can see this point, and this is our endodermal out bulging. So these are our pouch. Okay, and there is our ectodermal indipping. So these are cleft. Fine. Now see here, within each structure you can observe. Yes, sir. Within each structure you can observe there is a development of the 4 things. Yes, nerve. You can see the artery. You can see the cartilage. Also, one more thing you can add. There is our muscular compartment. Yes, sir. There is the muscle. Every arch gives rise to the 4 things. Yes. Here is the table. How many arch? Sir, first arch, second arch, third arch, fourth arch, fifth arch, sixth arch. Remember, this fifth arch disappear. Fine. And within each arch, there is a one particular nerve. Can you see? Yes, sir. This is our first arch, second arch, third arch, fourth arch, sixth arch portion. So you can observe our nerve, fifth nerve. It is giving the fifth one, fifth two, fifth three. Which is the nerve of the first arch? Sir, our nerve is fifth 3, mandibular. MCQ. Now, can you see the second arch? Yes, sir. This is our second arch. Can you observe it? This is our second arch. Can you see which nerve is coming here? 7th nerve. So, what is your answer? Definitely your answer is 7th nerve. And in the similar way, third arch, it is having 9th. Remember 5, 7, 9. What you have to remember? Plus 2, plus 2. Sure, short questions are asked here. Fine. Yes, Wasim, thank you, beta. Thank you for your positive points. Now, see here, 4th and 6th arch, there is the longest cranial nerve of body, vague nerve of the body, vagus nerve. But better, according to our Langemann and Larson textbook, 4th arch, the branch of the vagus, superior laryngeal nerve, and 6th arch, recurrent laryngeal nerve. Agree, everybody? Itna hi padna, you have to revise again and again. Yes. Now, muscles. What are the different muscles? Keep the hand here. So what are the muscles here? Keep the hand. Sir, जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. Here is the temporal bone, temporalis. Now come here, sir. Here is the masseter, and inside you will see our medial and lateral pterygoid. See here. This is our beautiful three-dimensional orientation. Rotate it. Can you see these muscles? Yes. Look here. Yes. Can you see? This is our pterygoid bone. Lateral pterygoid plate, medial pterygoid plate. From the lateral pterygoid plate, there is our lateral pterygoid muscle is taking origin. And remember, this is another muscle which is taking insertion at the angle of the mandible. Yes, sir. It is our mandible. So at the angle of the mandible, the medial pterygoid muscle. These all the muscles are located here. So remember, 4 muscles of mastication. I am telling you the common sense. Remember, 4 muscles of mastication. Aggression. And when you are putting the hand here, what are the other muscle? Sir, here is our digastric muscle, anterior belly, posterior belly. So remember the anterior belly of digastric. Also there is our floor of the mouth. Yes, this is our mylohyoid muscle. Also remember there is our TT and TP. Yes, sir. Tensor tympani and tensor palatini. One muscle which is responsible for the tension over the tympanic membrane here within the ear. So all the muscles are derivative of the first arch. No need to mug up, just put the hand here. Do imagination, what are the spatial muscle? Yes, tensor palatini, the muscle which is responsible for the tension over the palate. Okay, otherwise you can remember the mnemonic also. Yes, you can remember the mnemonic MAT2. Fine, sir. M for mylohyoid. Yes, A for anterior belly of digastric. T for tensor tympani. T for tensor palatini. Agree, everybody? Fine. Now look here, the second arch. Second arch is giving rise to all the facial muscles. Also you can remember over the face we apply the sun protecting factor. So you can remember the stapedius, you can remember the platysma, you can remember the F for, yes, definitely our facial muscle. Okay, so these are the muscles. Also P for posterior belly of digastric. Remember this question had been asked, the anterior belly of digastric. It is a derivative of the first arch, and nerve of the first arch is the mandibular nerve. So definitely anterior belly of digastric is supplied by which nerve? Yes, mandibular nerve. This was the your NEET PG question. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. Getting the point? So remember S for stylohyoid also, and S for your, yes, stapedius. Now third arch, it gives origin to only one muscle, that is our stylopharyngeus. You can remember. स्टाइल मारना है, यस, कहां पर? ग्लॉस के आगे, मिरर के आगे. विच इज ग्लॉस? सर, ग्लॉसोफेरेंजियल. स्टाइल मारना है ग्लॉस के आगे. दिस इज द वन फनी निमोनिक. यस, फोर्थ आर्च, इट गिव्स ओरिजिन टू ऑल द पैलेटल एंड pharyngeal muscle, except, yes, there are few exception, we will see later. So all the muscle of the palate, all the muscle of pharynx, they are supplied by our nerve of the fourth arch, vagus nerve. But remember, the better answer is the vagoaccessory complex, and more better answer is the pharyngeal complex. Yes. Now all the muscles of the larynx, they are developing from which arch? Sixth arch. I told you, जो nerve जहां रहती है, जहां बहती है, उस area को supply करती है. All the laryngeal muscles, they are developing from the sixth arch. Nerve of the sixth arch is the recurrent laryngeal nerve. So remember, all the laryngeal muscles, they are supplied with the recurrent laryngeal nerve, except, yes, there are the few exceptions. Fine. Now also the cartilage, you can remember easily the cartilage. The first arch, it is giving rise to the our 5M. Second arch, it is giving rise to the 5S. Yes, 5M, I'm just telling you, malleus and incus. Yes, there is the also mandibulo-sphenoid ligament. Yes, you can remember the mandible, you can remember the maxilla. But recent concept is saying that all the muscle of the skull, they are derivative of the neural crest cells. So 5M you can remember. Second arch is giving rise to the 5S. What are the different 5S? Yes, you can remember what are the different 5S. Yes, S for stapes. From the our styloid process, there is another S, styloid process. From the styloid process to the hyoid, stylohyoid ligament. Then our superior half of the body of the hyoid, and remember small cornua. So 5S is your mnemonic. And what are the different structures coming from the third arch, remaining part of the hyoid? Which hyoid? Remember, yes, greater cornua and lower half. And remember, what are the fourth and sixth arch are doing? They are giving rise to the our laryngeal cartilage. Getting the point? So these are the different points. Yes, remember the pharyngeal arteries, Right now many times the questions are not asked, but just one thing, first arch is disappear and its remnant is there, that is our maxillary artery. Also you can remember the inferior alveolar artery. Second arch there is our stapedial artery. Also you can remember the hyoid artery. Third arch, it is giving rise to the common carotid artery, also the internal carotid artery. New growth is there which is giving rise to the our external carotid artery. Getting the point? Yes. Our fifth arch, it is disappearing. Now fourth arch on the left side, it gives rise to the arch of aorta. MCQ, yes, it is the bullet train anatomy, so I am just revising the high yielding points only. Okay, right side, it is giving origin to the our right subclavian artery. Getting the point? And sixth arch, remember the sixth arch, it is giving rise, yes, to the our pulmonary artery. On the right side it is getting obliterated, but on the left side it is giving rise to the our, yes, ductus arteriosus. Remember this ductus arteriosus is obliterating and it is making the ligamentum arteriosum. If it is persisting, then you will see there is our patent ductus arteriosus, which is important for the pedia. So this is integration. Yes, remember this is the sixth arch. Fine. So this is your table, no excuse. But right now see here, there is our Valentine Day I love you joke. So there are the few exceptions you must remember. So on this Valentine Day, don't forget there are the 4 exceptions. I am going to tell you 1, 2, 3 and 4. Tell me, all muscles of the palate, they are derivative of which arch? Sir, fourth arch. So nerve of the fourth arch, sir, vagus nerve. But the better answer is vago-accessory complex. But the best answer, remember, few more nerves are contributing. So there is the pharyngeal plexus. Correct. And pharynx, it is also having the same thing. Concept is there. Because all these muscles are derivative of the fourth arch. Yes, pharyngeal, all the muscles are derivative of the fourth arch. In detail classes, when we will meet together, I will tell you each and every point in detail. But it is bullet train anatomy. Yes, you all had studied the anatomy. We are just quickly revising. So now tell me, all the muscles of the palate, they are coming from the fourth arch. But remember one muscle, tensor palatini, it is derivative of the which arch? Sir, first arch. And which is nerve of the first arch? Yes, yes, yes. Tell me, sir, mandibular nerve. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. Which river is flowing here? Remember, sir, mandibular nerve. So tensor palatini is supplied by which nerve? Mandibular nerve. MCQ. Remember, which is the nerve supply? Mandibular nerve. So there was the one funny joke. एक लड़का होता है, एक लड़की होती है. Yes, boy is saying to the girl, I love you, and girl is saying, yes, I know this all the things. So tell me any such kind of thing which I don't know. Now the boy says, all the muscles of the larynx, they are supplied by, yes, this is the WhatsApp joke, this is the memes, what you have to remember. Now the boy says that all the muscles of the larynx, they are supplied by recurrent laryngeal nerve except cricothyroid. Remember, this cricothyroid is derivative of the fourth arch. So nerve of the fourth arch is vagus nerve, and the branch of the vagus is better answer superior laryngeal nerve, and the best answer is external laryngeal nerve. ENT integration. Okay, so there are the 4 joke what I want to tell you. Remember, yes, pharynx. In the pharynx, remember all the muscles of pharynx, they are derivative of the fourth arch. Nerve of the fourth arch, sir, vagus nerve. Better answer is the vago-accessory complex. Best answer is pharyngeal plexus. But you all are aware, sir, there is our stylopharyngeus. Do you remember? Stylopharyngeus was the derivative of which arch? Sir, third arch. Every point is MCQ. Every point is MCQ. Third arch nerve is there. Remember that this third arch nerve is glossopharyngeal nerve. So this is the concept of why the stylopharyngeus is supplied by the glossopharyngeal nerve. Because stylopharyngeus is derivative of the third arch, and the third arch nerve is the glossopharyngeal nerve. So all the muscles of the third arch, there you will see it is supplied by the glossopharyngeal nerve, and only one muscle. Agree, everybody? Hope you all are getting the point. Now remember, supplied by, I told you, the 9th nerve. Now last, tongue. Remember, do you know Hollywood, Bollywood, Tollywood, all are coming from the anatomy. What I want to tell you? Yes, remember. Yes, one famous dialogue. मेरे बच्चों, मैंने कहा था ना, एक्टिंग सब्जेक्ट पढ़ने से पहले एनाटॉमी पढ़ा जाता है. एंड रिमेंबर, हॉलीवुड, बॉलीवुड, टॉलीवुड, दे ऑल आर कमिंग फ्रॉम द अवर, yes, anatomy. Do you know any song which is dedicated to the tongue? Any song which is dedicated to the tongue? Yes, one song. Can I sing the song? Yes. तूने मारी एंट्रियां तो घर में बजी. Yes, I think, sorry, दिल में बजी. तूने मारी एंट्रियां तो दिल में बजी घंटियां रे. टंग 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 टंग. Yes, tongue is important. Just I'm making fun now. Okay, remember 3T. Yes, tongue, thyroid, tonsil. Sure question from the tongue, thyroid, tonsil. These are very most important. Hollywood, Bollywood, Dollywood, they all are depending on our anatomy. So what I want to tell you, all the muscles of the tongue, they are derivative of the what? Yes, remember, occipital somites. Remember occipital somites. Yes, thank you. Hope you all are enjoying. Yes, Dr. Drisha, Hussain, Osama, Alpha. Yes. So remember, yes, doc. When we will meet together, then you will understand this properly. Okay, so don't worry. Few students they are laughing right now, but few students they will understand at the night. Okay, that was, and then they will laugh. Okay, so don't worry, everybody will find, you will get these jokes, and there will be too much shari, too many funny motivation. What you have to remember right now, tongue is developing from the occipital somites. Remember the nerve of the occipital somites, sir, 12th cranial nerve. Getting the point, beta? Yes, 12th. So all the muscles of the tongue, yes, remember now the boy is saying all the muscles of the tongue, they are supplied by which nerve? Sir, 12th cranial nerve. Except, remember the which muscle? Sir, there is the word palatoglossus. Yes, there is a palatoglossus. Remember, this palatoglossus is the muscle of the palate, which is the nerve supply of the palate. Sir, vagus nerve. Sir, but the best answer is vagoaccessory complex, and the best answer is our, yes, pharyngeal plexus. Okay, so remember, this learning process is not only depending on the teacher, it is depending on the our student also. हम ही हम हैं तो क्या हम हैं, तुम ही तुम हो तो क्या तुम हो. Remember, this is the famous dialogue from our border movie. Student बिना teacher नहीं और बिना teacher के student नहीं. So just enjoy this all the session, and what I want to tell you, short question from this table or this table, not only directly from the anatomy, but ENT, but the medicine, surgery, different subject. No excuse. Agree everybody? Fine. So now we are going to look the pharyngeal cleft. You all know there is the word first cleft, second cleft, third, fourth cleft. Okay, sir. First, second, third, fourth. What is happening? The second cleft is going rapidly down and it is getting fused here. So there is a formation of the gap here. There is a gap in the neck. So this is known as sinus. Yes, surgery and our pedia integration. If there is the abnormal opening and having the, yes, there is the embryological structure, it is not getting obliterated, two opening, then it is your sinus. Agree? Surgery integration. If one opening is getting obliterated, then, sorry, this is two opening, this is our fistula. Sorry, make correction. Yes, sir, it is our fistula. And one opening, yes, sir, one opening, then you will say sinus. Getting the point? But if there is the obliteration of both end and one cavity is persisting, so this is our cyst. So you can see during the development, this is the clinical point. Just in front of the our sternocleidomastoid, there is a formation of the cyst, sinus or fistula. You will see in the radiological appearance, there is a formation of the abscess also. Getting the point? And try to understand what are the different common site. Yes, you will see the preauricular sinus in front of the sternocleidomastoid. This is your surgery part. Because the pharyngeal cleft, they are ectodermal, they are outside. And in radiology, what you will do? Radiology integration. See here, you are injecting the dye. And if fistula is there, then the bitter taste of the dye will be felt in the oral cavity. Agree everybody? Fine. So this is very important. Hope you all are getting the point. So get ready for this cleft. Now see here, there is a pharyngeal pouch. Yes, sir. Endodermal outbulging is the pharyngeal pouch. Fine. So there is the first, second, third, fourth. Can you see? This is our endoderm. Yes, sir. Here is the ectoderm and this is the mesoderm. So one very special structure is developing here. This is nothing. It is our tympanic membrane. Why the tympanic membrane is having all the three germ cell layer? Ectoderm, endoderm, mesoderm. Can you see? The outside there is the first cleft. First cleft is ectodermal. This is the arch remnant, mesoderm, and here is the endoderm. Yes, this is the site where there is a development of the tympanic membrane. So it is the very rare structure, ENT integration. Yes, the first arch it is making the tubotympanic recess. The second arch is making the palatine tonsil. Third arch it is giving the dorsal part and the ventral part. Dorsal part is giving the parathyroid 3 and ventral part is giving the thymus. Yes, you can see the our fourth part. Yes, parathyroid 4 is there and you can see the lateral thyroid element. No excuse. This is our, yes, cervical, also you can say branchial sinus. Normally it obliterates, but if it persists, then there is the our formation of the fistula, sinus, this all the things. One another very, very beautiful integration you can see. The third pouch, sir, it is making the parathyroid 3. The fourth pouch, sir, it is making the parathyroid 4. MCQ and MCQ. But during the development, you will see this part is going down and parathyroid 4 is going up. So remember that superior parathyroid is a derivative of which arch? Sir, fourth arch. And the inferior parathyroid is a derivative of which arch? Sir, pouch. We have to say we are looking the pouch. Getting the point? So this is the very important point. The third pouch, it is making the parathyroid 3, but it is going inferiorly, so it is making the inferior parathyroid. And you can see the fourth pouch, this is the parathyroid 4, it is going upside. No excuse, no excuse. Yes, you are right, it is the making only epithelium. Remember, the connective tissue part is coming from the neural crest cells. I will teach you the neural crest cells later. Agree everybody? Fine. Now look here, why I am teaching you, why I am telling you all the 200 questions, they are related with the anatomy. This question, DiGeorge syndrome, is asked in your ENT and different subject. It is related with our, yes, third arch. It is also known as the velocardiofacial syndrome, also known as the Spinian syndrome, DiGeorge syndrome, and the beautiful mnemonic is the catch-22. Yes, you will see the cardiac abnormality, A for abnormal face, T for thymus aplasia. Yes, it is related with the third pouch, cleft palate, and hypocalcemia. Yes, it is related with our parathyroid hormone. Getting the point? So this is your DiGeorge syndrome appearance. No excuse, it is integration. Fine. Now look here, this is the appearance cleft palate you will see in DiGeorge syndrome. Now look here, this is our first arch syndrome. First arch is making the mandible. Yes, the one clinical point, this is the Treacher-Collins syndrome, ENT and the medicine integration. Remember, when we celebrate the Teachers' Day, sir, we celebrate the Teachers' Day on the 5th September. So this is the MCQ. The Treacher-Collins syndrome is due to mutation in the 5th number chromosome. Your clinical integration, you will see such kind of appearance. Yes, there is our small angle jaw. Also, you will see the eyes, they are showing the slanting. Also, you will see the ear abnormal shape. Also, there is a cleft palate. So this is the Treacher-Collins syndrome. Also, you can remember one more, another first arch syndrome. Sir, this is our Pierre-Robin syndrome, ENT integration. You can remember the mnemonic GCR, Girls Common Room. Yes, Girls Common Room. In the Girls Common Room, what we are doing? We are studying our textbook. Which textbook? Robbins. At which age? Yes, when we are getting admission in the MBBS, 17-year age. So remember, there is the mutation of the 17 number chromosome. These all are the integration. So G for what you will get in the Pierre-Robin syndrome? Sir, G for glossoptosis, C for cleft palate, and R for retrognathia. Can you see? There is our retrognathia, clinical integration. Fine. There is the glossoptosis. There is a large tongue which is falling over the our trachea. Agree everybody? Fine. So hope you all are getting the point. So we are not only dealing with the anatomy, we are integrating. And if the questions are asked from this point, so definitely anatomy was used here. Okay, your pharyngeal apparatus. Now we are looking for our head, neck, face. Try to understand. We had seen the related our embryology part. So hope you all are getting the point. So just give me the little vocal rest. Till now, definitely one question from the joint, one question from the muscle fiber cadaveric image, one question from the nerve also. Okay, and cranial nerve is very important. Sure short one question on the day of exam. We will talk at this beautiful platform. Yes, one question sure from the pharyngeal apparatus part. Okay, fine. So hope any doubt till now? Okay, so we are moving further things. Okay, yes. So look here, we are looking the scalp. Scalp is the part where we are applying the shampoo. Face, where we are applying the face wash. Neck, yes, where we will apply the neck wash. Very soon, Patanjali, Baba Ramdev is going to launch the face wash. No, neck wash. Okay, remember, never apply the face wash over the neck. So this is the funny point. Only one thing you have to remember for the scalp, sir, for the scalp, SCALP. You all are aware. S for yes, skin, C for connective tissue, A for yes, aponeurosis, L for loose areolar tissue, and P for what? Pericranium. Agree everyone? what you have to remember, only one thing, this loose area of tissue, this is dangerous area of, yes, scalp. It is the dangerous area of what? Scalp. Later I will teach you the dangerous area of the face, the lower part of the nose and upper lip. This is the dangerous area of the face, but this is the scalp. Only this thing you have to remember. Now we are going to look, yes, Anjali, very soon. Only one branded company, our Baba Ramdev, Patanjali, is going to launch that neck wash. And never apply the face wash over the neck, okay? Because neck is coming, neck is starting from this chin part, okay? So just one thing you have to remember. Yes, Dr. Drisha, this dangerous area is very important. Fine. Now we are looking for the face. So when we do dissection, let's start the dissection, sir. Skin, and then there is the superficial fascia, but remember deep fascia is absent. Fine. So after this dissection, I told you there is the muscle. So you can see the muscles are located just below the skin and superficial fascia. Such kind of the muscles are known as panniculus carnosus, very well developed in the animal. Okay, so these are the very special kind of the muscle. These all the facial muscles are derivative of which arch, sir? Second arch. So these all are supplied by which nerve? Nerve of the second arch, facial nerve. Except, remember, exception is our levator palpebrae superioris. It is eye muscle. Levator, palpebrae, superioris. Three muscles are there, three words are there. So it is supplied by the third cranial nerve. No excuse. No excuse. Fine. Now you will see there are the different kind of the muscles which do the facial expression. Right now I am not teaching. At my YouTube channel, Dr. Shrikant Verma classes, you can go. There is a Priya Prakash Warrior. There are the different kind of the facial activity. There are the different kind of the facial expression, and how you can remember, I told there. Okay, so there are the different kind of the muscles, like the our Hollywood, Bollywood, Tollywood, they all are depending over this facial muscle expression. Priya Prakash Warrior, Valentine Day special, that all was also depending here. And do you know, if there is a damage in this facial muscle, then there is our Bell's palsy. Okay, so go for that. But right now what I want to tell you, this all the facial muscle, which is the whistling muscle. Yes, buccinatory is the whistling muscle, and which is the our, yes, winking muscle. Winking muscle, remember our this particular orbiculis oculi. And again I want to tell you, Hollywood, Bollywood, Tollywood, they all are depending over the anatomy. Yes, the song which is dedicated, Aankh Mare, O Ladki, Aankh Mare, Siti Bajaye. Yes, means it is saying about the our orbiculis oculi and the buccinator. Remember, this all are the muscle. One MCQ in your INI-CET, rhizorius. Yes, rhizorius. It is the Venus smile muscle. It is our grinning muscle. So these are the different questions which had been asked. So these are the points which you have to remember. If there is a damage in this our facial nerve, then definitely there is the our, yes, Bell's palsy, which is lower motor neuron paralysis. Agree everybody? Now look here, what are the different arteries? I am going to tell you the arterial supply. See here, look at this point. The external carotid artery is the artery here. Can you see? This is our artery. Yes sir, it is our common carotid artery. Can you see? It is giving one branch. This particular branch is going inside the cranial cavity. Yes sir, it is internal carotid artery. Agree? Fine. Yes, you all are right. Fine. Now see here, where is the another artery? Can you see the face artery is supplied by the external carotid artery? Yes sir, there is the one artery. Sir, this is the external carotid artery. It is running outside. It is running outside. It is giving the different branches. One branch is going towards the thyroid. So just one diagrammatic presentation for all of you. Quick, because it is important and many things are asked. So just see, suppose this is the forehead, here is the nose, this is the upper lip, lower lip and the chin. Agree everybody? You can see here, this is our neck portion and here is our occipital area. Agree? Just I am drawing the scalp area for all of you. Fine. For the beauty of the diagram, yes, suppose this is our eyebrow and eye. Fine. And yes, this is our margin of mandible, angle of mandible, and this is the ear portion. Agree? Now what you have to remember? Quick, tell me, this is which artery? Sir, this is common carotid artery. Sir, there is our external carotid and internal carotid artery. Remember the first branch of our, yes, try to understand what you have to remember. Yes, Lakshya, Shukriya, thank you. Okay, so thank you. We will do this singing phenomena also, but I want to tell you that when I was singing in my college, all the auditorium, it became vacant. Okay, yes, I am very good poet, very good share, but I am very bad singer na. Okay, but even I will try for all of you. So try to focus here. What I want to tell you, sir, this is common carotid artery. Sir, here is internal carotid artery. Sir, this is external carotid artery. The first branch, Gray's anatomy. What I want to tell you, yes, see here, the Gray's anatomy 42nd edition update. One update for all of you, that first branch of this external carotid artery, that is our, yes, ascending upside and supplying the pharynx. So APA. MCQ, 3 MCQ I am telling you. It is the first branch of the external carotid artery, 1. It is only single medial branch of the external carotid artery, 2. It is a smallest branch of the external carotid artery, 3 branches. APA you have to remember, it is the blood supply of the pharynx. Now it is supplying the artery to the thyroid gland, superior thyroid artery. Then it is giving the branch to our tongue. Sir, it is our, yes, lingual artery. And now focus here, this artery is running upside. It is reaching to our temporal region and it is giving the branch over the maxilla also. So these are our two terminal branches. What are these two terminal branches? Focus, sir. It is our superficial temporal artery. Remember Robin's pathology integration in case of the giant cell arteritis. Sorry. Vasculitis. This superficial temporal artery, it is getting thickened and it is, yes, also painful, important. And this artery is running over the maxilla, sir. It is our maxillary artery. What I want to tell you, one question from the connective tissue disorder, one question from the vasculitis, sure shot. We are talking for the 200 question from the NEET PG. Remember, vasculitis, connective tissue disorder is important. Here I am integrating with the giant cell arteritis, which is seen in old age. There is a thickening of the superficial temporal artery. Sometimes it is involving the ophthalmic artery also. So these are our two terminal branches. But focus here, this is our facial artery, which is zigzag. It is winding over the our lower angle of the mandible and then running over the face, yes, and reaching to the medial angle of the eye. Yes, what are the different branches? INICET question. It is giving the branch, yes, to the lower lip, inferior labial, to the upper lip, superior labial. It is giving the branch to the lateral part of the nose, lateral nasal, and then it is ending at the medial angle of the eye. This is angular artery. It is also giving the various our muscular branches. Remember, this artery is palpable here. This is our facial artery. Remember, this is also known as the anesthetist. Agree everybody? No excuse with this facial artery. It is very important. It is palpable artery. Fine. Now there are our two posterior branches. One is running posterior to the ear and another is with the zigzag course to the occipital area. Sir, this is our, yes, occipital artery. This is our posterior side to the ear. So posterior auricular artery and this is our occipital artery. So these are total 8 branches I had shown here. It is very most important for your surgery, for the ENT, for the anatomy, different subject. No excuse. One question from the artery show. Agree? Fine. So now we are looking for the venous drainage. Same thing. I am not drawing. I am just tracing because it is the bullet train anatomy. So try to understand. Sir, there is a supratrochlear vein. Sir, there is a supraorbital vein. Both the veins are uniting and making the angular vein. Yes, मेरे साथ याद करो. Supratrochlear vein, supraorbital vein, meeting together and making the angular vein. This angular vein is running in the face, facial vein. Agree, sir? Here is our mandible. Agree? Behind the mandible, there is our retromandibular vein. When we will meet for the detailed classes, yes, I will draw each and every diagram, but it is bullet train anatomy. So quick revision. Sir, this vein is behind the mandible, retromandibular vein. How it is formed? Sir, it is formed by the, just give me a few seconds for the charging. Yes. My iPad will get less charge or the energy will be down, but our energy will not get down. So remember, we are doing the very beautiful session for all of you, all the amazing beautiful students. So remember, see here, my chat box is also here. Little technical setting I need. Okay, so chat box is also open for your comments. Fine. So what I want to tell you, sir, this is our superficial temporal vein. Here is the vein over the maxilla. क्या बोलोगे? Sir, maxillary vein. So this is the retromandibular vein. It is dividing into the anterior division. It is dividing into the posterior division. Anterior and the posterior division. MCQ. See here. MCQ. Jugular venous pressure. Yes. Thus, this our posterior division of retromandibular vein and posterior auricular vein, these are uniting and making the external jugular vein. No excuse, no excuse. Jugular venous pressure, right atrial pressure for the your, yes, medicine. Fine. Now, while this anterior division, it is meeting with the facial vein and making the common facial vein, which is opening into the internal jugular vein. Agree, beta? Fine. Now, try to catch this our more point. Jugular venous pressure. Yes. This is directly making connection with the subclavian vein. Yes, it is making the our, yes, internal jugular vein. It is opening into the subclavian internal jugular vein. Internal jugular vein is uniting with the subclavian vein and making the brachiocephalic vein. Right and left brachiocephalic vein, they are uniting, making the superior vena cava, which is opening into the right atria. So the pressure of the right atria is directly reflected in this external jugular vein. So remember, the two posterior, they are making the external jugular vein. Agree, everybody? Now try to understand, if there is the contraction of the atria, A for atrial contraction, A wave, then there is a relaxation of the atria. So there is our X descent. But during the atrial relaxation, there is the tricuspid valve closure. Tricuspid valve is closing. So C for closure of the tricuspid valve, which is producing one small wave. Then there is a ventricular contraction, which is increasing the atrial pressure. So this is your V wave. And then there is a V, your, yes, relaxation of the ventricle. So Y wave. So if this knowledge will be applied, definitely it will be applied in any question. Okay. So remember, anatomy will be helpful for there. So again, I want to tell you, yes, मेरे बच्चों, मैंने कहा था ना, 18 सब्जेक्ट पढ़ने से पहले एनाटॉमी पढ़ा जाता है. So remember, directly or indirectly, anatomy is hidden in every question. Yes, we will see internal jugular vein is formed by the our sigmoid sinus. Fine. Now remember, the infection from this lower part of the nose and the upper lip, it is going to the our facial vein, and then it will directly, indirectly, it will go to the cavernous sinus. I will teach you the cavernous sinus. So here infection is reaching and causing our meningitis and even death. That's why this is known as the dangerous area of the face, which is also known as the maxillofacial death pyramid. Agree? So now what I want to tell you, see here, after this all, nerves of the face. Sir, there is a sensory nerve, trigeminal nerve. Why I'm telling you? Because if there is a trigeminal nerve problem, yes, there is a trigeminal neuralgia. Motor nerve, sir, facial nerve. You all are aware with this 5 terminal division of the facial nerve. Agree? If there is a damage, Bell's palsy. But what are the different branches of this trigeminal nerve? Why I'm telling you? Because you have to study the trigeminal neuralgia. MCQ, pharma and the medicine integration. Remember, trigeminal neuralgia to the Salman Khan. Yes, you know, the trigeminal neuralgia, there is the pain along the trigeminal nerve. Algia means pain. So tell me, pharma integration, medicine integration, the sensory nerve supply of the face, sir, trigeminal nerve. If there is a pain, then which is the drug of the choice? Yes, carbamazepine. MCQ. What is the second drug of the choice? Yes, valproic acid. MCQ. But clinically, the gabapentin is also given. But if it is not properly used, yes, if it is not corrected, then you have to do the neurosurgery. Yes. So this is our anatomy, pharma, medicine, neurosurgery, ENT also you will see. So I am telling you what is the surgical process. Yes, look here, observe here. Can you see the cranial cavity? Yes, I am rotating here, and this is our Turkish saddle. So here is our trigeminal nerve. I am showing you the cranial nerve. Yes, see here. See, observe. This is the network of the cranial nerves. Fine, sir. This is the largest cranial nerve. Can you see? Beautiful cranial nerve. Yes. Cranial cavity, trigeminal nerve. So if there is the pain and it is not treated by the carbamazepine, valproate, gabapentin, then you will make surgery over the pterion. Can you see the pterion shadow? Yes, sir. This is the H-shaped area, pterion. So here you will drill and then you will reach along our trigeminal nerve. Can you see? This is the trigeminal cranial nerve, which is having the fifth one, fifth two, fifth three. You will inject the 90% alcohol न रहेगा बांस न बजेगी बांसुरी. 90% alcohol is very irritating. It will destroy the trigeminal nerve and it will be total treated. Getting the point? But there is a one drawback. You have to do opening of the cranial vault, that is a craniotomy. So nowadays there is a one another surgery. Yes, integrating. Again, I want to tell you, Hollywood, Bollywood, Tollywood, they all are coming from our anatomy. How? Do you know? When the Thanos, Hulk, they were snapping, at that time gamma rays were released. Gamma rays, they are very, very destroying in nature. So these gamma rays, they are destroying the everything. So this Hollywood, this knowledge from our medical science, it was applied there. Okay. So what I want to tell you, gamma knife surgery for the trigeminal neuralgia. Nowadays, gamma knife surgery is used. Yes, you are carrying the patient into the MRI like machine, localizing the brain tumor or trigeminal nerve ganglion, and the rays are focusing over this particular part. So there is a total destruction. No need of single incision. No need of single incision. Agree, everybody? Fine. Yes, 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 Dr. AK Knight, you are right, except the angle of mandible. We are going to talk about that all also. Fine. So this is the gamma knife surgery. Remember, it is important for the acoustic neuroma. Yes, sir. ENT integration. This is our best surgery for the acoustic neuroma also. Fine. So these are our different points which you must remember. What are the different branches? I'm just telling you one funny way to remember. Yes, it is the dermatome. Fifth cranial nerve is supplying all the skin of the face except this angle of mandible, which is supplied by the greater auricular nerve. Root value C2, C3. Single option. If you have to opt, then C2 is the best answer. Remember, this nerve is damaged in the Fraze syndrome. Everything is written here. Yes. So this is our shaving area, angle of mandible. No excuse. It had been asked. Now, no excuse, no excuse, no excuse. The question is going to ask from this point. Fine. Now we are looking for the our more things. There are the fifth one, fifth two, fifth three. What are the different branches? Yes. So here, see here. There are the different branches: supratrochlear, supraorbital, lacrimal, infratrochlear, and external nasal. MCQ: the tip of the nose. The tip of the nose is supplied by which nerve? Sir, external nasal. Your mnemonic is yes. सू सू करके लाई बोल दो, झूठ बोल दो, सुसु करो और झूठ बोल दो. One funny trick. Yes, su. How you can remember? Do with me. Supratrochlear, supraorbital. There is a lacrimal. Yes, infratrochlear, external nasal. Complete. Fine. Now try to understand. Who is doing susu and telling lie? Yes, jijaji. Yes, maxillary nerve. Z for zygomaticotemporal, I for infraorbital, Z for zygomaticofacial. So what you have to remember? Zygomaticotemporal, infraorbital, and zygomaticofacial. Yes, these are the branches of the maxillary nerve. Now see here the mandibular nerve. Yes, jijaji is doing the MBA. Yes, you can see the mental nerve, buccal nerve, and auriculotemporal nerve. You can see the mental, buccal, auricle, and temporal region. So remember, pinna is supplied by which nerve? Sir, great auricular nerve. Also by the auriculotemporal nerve. Few more nerves are there, but right now anatomy integration. Except this angle of mandible. No excuse with this great auricular nerve. It had been asked many times in INICET, in the NEET PG, also in your FMG exams. Okay, so hope you all are getting the point. So if you all are getting the point, if you all are enjoying the session, just give the clapping, just give the thumbs up, just give the flower, just give your hearts. So all the emojis for all of you. Hope you all are enjoying. Fine. So this is our damage to the facial nerve, Bell's palsy. You all know all the features, and here is the appearance. So remember, there is a contraction. Yes, this is our normal side and it is our abnormal side. Our Bell's palsy most common cause is idiopathic medicine question. So you all are aware? Yes, yes, yes. So now after this beautiful integration, can you tell me microbiology integration? Yes, yes, yes. Herpes infection. See here, any patient coming to you with the painful vesicular eruption along the dermatome. Yes, sir, this is our fifth one dermatome. Agree, everybody? Yes, it is the fifth one dermatome. So there is the supratrochlear, supraorbital. Yes, exactly. There is the painful vesicular eruption. So this is what? Sir, this is the herpes infection. Can you see? Yes, our ophthalmology integration. So any patient is presenting with the yes, painful vesicular eruption, then definitely it is our herpes infection, herpes zoster ophthalmicus. Fine. So these are our points related with our, yes, scalp we covered the face. Now we are going to talk about the neck. So in the neck, when you are doing dissection, skin, neck dissection, our rule is there, na? Then superficial fascia, yes, deep fascia is present, and then there are the muscles. Remember, Within the superficial fascia, one muscle, that is the platysma. Agree everybody? Yes, yes. Dark night, you are right. Geniculate ganglion, yes, it is related with our seventh nerve. You are right. Here the herpes virus infection, they are coming. Very beautiful. Same thing we have to do. मेरे बच्चों याद रखना, we have to integrate. So whenever you are learning about the facial nerve, recall the geniculate ganglion, herpes virus, they are coming and they are invading there and they are spreading. So you know our Justin Bieber, he got the our same kind of the infection. So you are right. Fine. Auriculotemporal nerve is, I will tell you. Don't worry, I will tell you, Sayanthani. Okay, Sayanthani, I think you are the student from the Assam. I think if you are same Sayanthani, so just tell me better. Okay, so very happy that yes, Ramsay Hunter syndrome. Divyanand, you are right, beta. You are right. So I'm very happy. Our old student, our new student, they all are joining. Thank you very much. My humble, very humble kind of the all kind of the regards for all of you students. Yes, at this beautiful platform. Definitely, Hari Shankar, PDF bilkul milega beta. We will share this PDF annotated file at the our platform. Okay. Any more doubt? Please ask. Yes, we will do Ritu, we will do the forum and don't worry. उसके लिए एक बढ़िया सी मैं कहानी सुनाऊंगा. एक राजा होता है, दो रानियां होती है, राजा रानी को रोज देता है. वैलेंटाइन का वीक चल रहा है, बिल्कुल आपको याद हो जाएगा. Don't worry for it, okay? Okay, fine. So we are looking the deep fascia. So in the neck there are the 6 modification. Yes, sir. There is the our investing layer of deep fascia. Yes, fascia coli also you can say. This deep cervical fascia, it is enclosing the neck like the collar. That's why. Second, what you have to remember, in front of the vertebra, that's a prevertebral fascia. Yes, in front of the trachea, that's a pretracheal fascia. Remember, नाम को तोड़ो और सोचो. शेक्सपियर ने कहा है, नाम में क्या रखा है. बट रिमेंबर, मिर्जा गालिब कहते हैं सारे राज नाम में दफन रहते हैं. जस्ट थिंक इट. Pre means in front, trachea. Yes, this fascia is in front of the trachea. And last is our BP and PB fascia. Agree? What is the our BP fascia? Sir, this is buccopharyngeal fascia. What is the our? Yes, PB fascia. Sir, this is the pharyngobasilar fascia. And last is carotid sheath. Sorry. Yes, but I will tell you. There is the abnormal, yes, Dr. Sanjeev, there is the abnormal joining between the great auricular nerve and auriculotemporal nerve, both. I will tell you, don't worry. We are covering the theory part also. I will tell you, okay? Yes. So this is our carotid sheath. Remember, what are the different content and wall? Remember, this is the anterior wall. Again, I want to tell you the update from the Gray's Anatomy. The Gray's Anatomy update for all of you. It is having the 2 different walls. What are the our different 2 walls? Yes. Anterior wall, it is formed by the pretracheal fascia. Yes, on the back side you will see there is this is the Gray's Anatomy update, also included in the BD Chaurasia, sir. Also, yes, this is the our prevertebral fascia. Okay, sir. So carotid sheath is formed by, there are our carotid vessels, around it there are the deep fascia modification. Remember, deep fascia, around the carotid vessels, carotid sheath, around the axillary vessels, axillary sheath, around the femoral vessels, femoral sheath. Yes, around the rectus abdominis muscle, rectus sheath. Sheath is nothing, modification of deep fascia. Now, what are the content? Sir, the common carotid artery, this is our internal carotid artery. But external is not the content. And can you see the internal jugular vein? There is our vague nerve, vagus nerve. It is also content. But the recent concept is saying, sir, the 9th nerve, 10th nerve, 11th nerve, and the 12th nerve. These are also the content at upper part. What I want to tell you, 9, 10, 11, 12. All are content. This question had been asked in your INI CET 2019. There is the update, so remember. Now, try to catch this point. On the entry wall, there is a one loop of the nerve. Yes, this loop means ansa. Ansa means loop. Cervicalis means neck. You know, there is the one word, ansa Henle. Physiology, ansa Henle. Remember, ansa means loop. So, loop of Henle is also known as the ansa Henle. Remember this question? Yes, AN for anterior. Sir, ansa cervicalis, it is located on the anterior wall. So when you will cut, definitely you will see only the 1 dot and 2 dot. At detailed classes, we will draw all the diagrams, but right now you have to remember there is a one loop of the nerve in the neck which is embedded at the anterior wall. Remember, it is supplying the muscles of the neck. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है, हिल्टन लॉ. So here are the strap muscle. Yes, sternothyroid, sternohyoid, omohyoid. But one muscle is not supplied by thyroid to hyoid. Thyroid is not supplied by. So question, thyroid is supplied by which nerve? So it is very close to the first cervical nerve. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. So thyroid is supplied by C1. MCQ. Each and every point is MCQ. This is important. Agree? Neck surgery. This all are important. Fine. Now try to understand. Yes. According to the Gray's Anatomy, we had two fascia, prevertebral and the pretracheal. Fine. Now look here. We had seen the scalp, we had seen the face, we had seen the neck. Now we are cutting and we are looking inside. Come to this. Sure question from here. Fine. So catch here. Whenever any image is asked, so at that time, catch any silly point. You know, Rahat Indori Sahab told one shairi. We are applying the same thing for the cadaveric image. Yes. वो बुलाती है मगर जाने का नहीं. You know, राहत इंदौरी साहब, very famous शायर. You know what is the next line? वो बुलाती है मगर जाने का नहीं, ये दुनिया है इधर आने का नहीं. Yes, ये नीट पीजी एग्जाम है, इधर आने का नहीं. So remember, for the cadaveric image, वो दिखाता है मगर देखने का नहीं. You have to look above, you have to look down, you have to look front, you have to look back, you have to look for the option. It will give the direction to your thoughts. Agree everybody? Yes, it will give the direction to your thought. You are right, everybody, you are right. This is epiglottis, but try to understand. Look properly. Sir, pick any silly point. This is the silly point, sir. This is the nose, mouth, and this all the our structure. Anatomical point we are covering here. Yes. So one by one. This is scalp. Agree, sir. Here is brain. Agree, sir. You can see the skull bone also. Correct. Very silly point. But can you see there is the band of the white matter here? Yes, sir. This is our what? See. Just below to it, there is the one partition. This is the one partition. This is the thin septa, thin partition in between the two ventricles. So this is septum pellucidum. Yes, it is the septa, which is lucid in appearance, which is transparent in appearance. And just below to it, very important, another structure, the thin band white matter. So this is fornix F. So your first mnemonic, first trick I am telling you, CSF, corpus callosum, septum pellucidum, fornix. Agree everybody? Now no confusion. So can you compare with this? Yes, sir. This is C, here is S, and this is F. Agree? Yes. Compare with the radiology. When we will meet for the our detailed classes, I will tell you the MEMS, banana theory of the radiology. We will see the radiology principle, but right now come to here. Radiology integration. Yes, sir. There is our C, then S, and then F. Agree? Corpus callosum, just below the corpus callosum, septum pellucidum, just below the septum pellucidum, fornix. Okay? Fine. Now, try to understand. Yes, Arifa, very nice, beta. You are from the Assam. So, my regards for all the Assam student, my different kind of the soft feeling for the Assam student because they are associated with our platform very beginning. So, my love to all the Assam students. Thank you. So, try to understand. Just below to it, you will see there is our, yes, diencephalon mass. That diencephalon mass is, remember, thalamus. We are showing with the T. What is the another structure just below the thalamus? Remember, that is our hypothalamus. Getting the point? And hypothalamus is making the hypothalamo-hypophyseal tract with the pituitary gland. So just below to it, there is the pituitary gland. So remember, okay? Tum hamare piya. Yes, it is our Valentine week. So you can remember tum hamare piya. CSF THP. T for remember. This is our thalamus. Just below the thalamus, you will see always hypothalamus. Just below the hypothalamus, you will see the pituitary gland. Agree. Fine. Okay. So come to here. Cadaveric image. Sir, this is the CSF. So below to it, you will see the gray matter mass, sir. This is thalamus, then hypothalamus, then pituitary stalk. And remember, this is the brainstem. Yes, midbrain, pons, and medulla. And this is your large mass of the ganglion. Many neurons are here. This is our cerebellum. Always I speak to the students that one question sure short from the cerebellum. One question sure short from the cerebellum. Yes, remember, but now every question is from cerebellum. Okay, so it is very important topic, either from the anatomy or from your physio or from your medicine or your pharma. Lithium is the cerebellar toxic drug. Yes, definitely question is going to ask. Okay, so remember, yes, Mohsin, you are right. Okay, THP, tum hamare piya, you are right, Osama, that kind of the pneumonia you can create. Fine, so these are the different structure. Now can you tell me the CT MRI? So you can see thalamus is here, hypothalamus is here, pituitary is here. So just below it, you will see the MPM, midbrain, pons, and then our medulla. And this is our fern tree like branching pattern. Definitely this is our cerebellum. Fine. Now look here. You can see the MPM. Yes, sir. This is our cerebellum. Just behind the midbrain, you can see elevation. Sir, this is superior colliculus. It is inferior colliculus. Extension of the medulla within our spinal cord, within our vertebral column. This is our spinal cord. Fine. Now, see here. You can see the different vertebra. Sir, this is our C1 vertebra. Here is our C2, C3, C4, C5, C6 and C7. Remember, this is our vertebra. In front of the vertebra, you can see the narrow tube-like structure. This is esophagus. In front of the esophagus, there is the trachea. So this is your mnemonic, another mnemonic, VOT. Yes, VOT. V for vertebra. Yes, sir. O for esophagus, T for trachea. Yes, remember, नेताजी सुभाष चंद्र बोस ने कहा था, तुम मुझे खून दो, मैं तुम्हें आजादी दूंगा. But the नेता, the politician of the today's day, they are saying, तुम मुझे वोट दो, मैं तुम्हें बर्बादी दूंगा. Don't forget this vote mnemonic. Yes, तुम मुझे वोट दो, मैं तुम्हें बर्बादी दूंगा. Fine. So this is the statement from the today's politician. Remember this funny mnemonic, VOT. Okay, just in front of the vertebra, whatever the narrow tube, that is the esophagus. In front of it, there is a trachea. Agree, everybody? Getting the point? Now look here. The upper dilated part of this our esophagus is known as pharynx. Sir, this is our pharynx part. Yes, this entire portion is our pharynx. And in front of this trachea, yes, the superior part of this trachea is our larynx. Yes, sir, it is our larynx. Now see, this is our nasal cavity, oral cavity, and yes, it is our tongue. So just behind the tongue, you can see this is our nasopharynx, oropharynx, laryngopharynx. Agree, everybody? Now ENT question. Tell me, what are the relation of the nasopharynx? Anteriorly, it is related with the nasal cavity. Superiorly, you can see there is the base of the skull. Posteriorly, you can see the first cervical vertebra. First part of the pharynx, first cervical vertebra. Can you see? This is the oropharynx. Superior boundary, sir, nasopharynx. Sir, inferior boundary, laryngopharynx. Sir, entry boundary, oral cavity. This is important for the ENT. And posterior part, sir, it is the second part. So it is the sorry, second part. So it is related with the two next cervical vertebra. Can you see? This is the third part of the pharynx. So it is related with the next three cervical vertebra, C4, C5, C6. Yes, ENT integration. Anteriorly, larynx. Superiorly, oropharynx. Inferiorly, esophagus. And posteriorly, this three cervical vertebra. Can you see where the pharynx is ending? Sir, pharynx is ending at the our C6 part. Yes, sir. You can observe here, this is the narrowest part of the GIT. Many times asked question, cricopharyngeal junction. Yes, here is a cricoid question, cricoid cartilage, and this is the pharynx. So cricopharyngeal junction, C6. It is located at which part? C6. Many MCQ. Trachea. Yes, see here, narrowest part of the GIT, cricopharyngeal junction. Can you see? Pharynx ends where? Sir, pharynx ends at cricopharyngeal junction, C6, MCQ. Esophagus starts at cricopharyngeal junction, MCQ. Larynx ends at cricopharyngeal junction, MCQ, C6. Yes. Trachea. Trachea starts at cricopharyngeal junction, C6. Narrowest part of the GIT, cricopharyngeal junction, C6. सबका मालिक एक है, cricopharyngeal junction. Beautiful integration. Many MCQ. Yes, it will be integrated with your radiology also. Agree, beta? Fine. Yes, thank you, Divyanand. Hope you all are enjoying. Yes, thank you. So you all are appreciating my clapping for all of you, my thumbs up for all of you, my heart for all of you, my, yes, every kind of the emojis for all of you. If you are liking the session, just give me your emojis so that I can get more and more energy. Okay. Yes, hope you all are enjoying the session. So fine, come to here, radiological integration. Radiology, sir, this is our spinal cord. You can observe here, sir, C1, C2, C3, C4, C5, C6, so on. Fine. So this is vertebra. In front of the vertebra, you will get esophagus, and in front of the esophagus, your trachea. So you can crack your radiology if your anatomy is strong. Again, मेरे बच्चों, मैंने कहा था ना, 18 सब्जेक्ट पढ़ने से पहले एनाटॉमी पढ़ा जाता है. So remember your radiology. Remember all the medical science, they are starting from the anatomy. If your anatomy is strong, all the subjects will be weak. If your anatomy is strong, all the subjects will be strong. But if your anatomy will be weak, all the subjects will be weak. They are running all the medical science, it is running through the, starting from the anatomy, then it is running through the medicine, surgery, patho, pharma, so on, and ending at the radiology. So anatomy, all the medical science are starting, and radiology, all the science they are ending. Fine. So just one thing so that you can remember. Fine. Yes. Thank you, Dr. DJ Kashan. You are saying you are gonna to be a legend, but my humble request that I'm also just one simple, my HOD sir, Dr. CK Shukla sir, who was the colleague of Dr. BD Chaurase sir. They taught me, many our teachers, we are learning from our friends, we all the teacher fraternity, they are meeting together, and all are my friends, they all are my seniors, they are sharing the knowledge with me. I am aiding the creativity and I am serving to you. Okay. Yes, this is the bullet train anatomy, so I have to concise. But when we will meet for the 4 days class, definitely you will enjoy too much. Every detail we will see. Okay. So we all the teachers are legend. You all the students are legend. Remember, beta, remember, always remember that every teacher is best. Every student is best. Okay. Only there is the matter of the resonance. You are getting the point from any particular teacher and you are enjoying. Okay. So every student is best, every teacher is best. So remember, enjoy the thing. You are learning from where, learn it. And then serve this all, share this knowledge to your next generation, to your friends. एक चीज याद रखना, ज्ञान जो है, knowledge जो है, वो share करने से बढ़ता है. I'm not having any kind of the knowledge I learned from my Dr. CK Shukla sir, from my respected teachers, my friends, my all the Cerebellum faculty, my all the other institute teachers faculty, and yes, we all are having the so nice harmony, and we are sharing this knowledge to you, and it is your responsibility. You have to share this knowledge to your friends and your next generation. We have to make the world for better to live. Okay, so hope you all are enjoying. Yes, Pawni, I'm also proud for all of you. Thank you. Yes, Ankit, everybody, everyone is best. My clapping for all the teachers. Thank you. So we are continuing this, all the things. Yes, can you see the esophagus? Esophagus, you can see the upper dilated part. This is our pharynx. It is ending at the C6 part. And there is our larynx. Can you see? There is our mandible. And yes, you can see there is our tongue. So one muscle is there, this muscle is like the fan. When this muscle will contract, it will cause protrusion of the tongue. This is our, yes, safety muscle of tongue. Can you help me? This safety muscle tongue is nothing, it is our genioglossus. Give the 2G, give proper respect. You know, Modi ji, Rahul ji, Sonia ji, yes. But this muscle is having the 2 times G, 2 times respect. Getting the point? Genioglossus. It is known as the safety muscle of the tongue because it is responsible for the protrusion of the tongue. Yes, it is supplied by the 12th cranial nerve. If there is a right side damage, right deviation of the tongue. If there is a left side damage, left deviation of the tongue. And you can observe here the oral cavity. This is our palate, beta. See here, this is our palate. Yes, hard palate is here, soft palate is here, and here is the nasal cavity. Agree everybody? Yes, Ajay. Yes, you have to remember GG. Our 2 times respect for this muscle. Don't forget it. Okay, sir. Now, on your high demand, we are going to look for the foramen. Yes, try to understand 3-dimensional orientation. Can you see, beta? Yes, 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 yes. This is the bullet train anatomy, very fast anatomy. This is our cranial cavity. We are cutting this cranial vault and we are getting the point. Yes, this is the cranial cavity. Here is the anterior cranial fossa, this is the middle, and this is the posterior cranial fossa. Too many confusion is there. I am telling you, yes, rule of 17 is there. Divyanand, you are right, but I am not discussing that all the rule of 17, this all you all know. That is very simple. Okay, see here at the center, this is our Turkish saddle. Yes, at the Turkish saddle, king is sitting. Who is king? Sir, pituitary gland is king. Okay, pituitary gland is king because it is the master of orchestra. On each side of the king, there are the queen. Queens are shy in nature. Shy, Sharmana. Yes, queens are shy in nature. So these foramen, they are shy in nature. These are foramen le sharam. Are you getting? Yes, le sharam. They are shy, Sharmana. They are shy in nature. And you remember, king, this pituitary gland, it is king. King is giving rose to the queens. So remember R-O-S-E, rose. Yes, R for rotundum foramen, O for oval foramen, S for spinosum foramen. Getting the point? Yes, E for there is the emissary vein. What is the emissary vein? The vein which is connecting the intracranial vein to the extracranial vein. Getting the point? So this is the beautiful vein. Agree? So this beautiful story will help you. Again, try to understand here. These are the different important foramen. Again, pituitary gland at this center, and you will see the foramen lacerum on each side. Then you have to remember R-O-S-E. Yes, rotundum, oval, and then spinosum. Short, one foramen is going to ask in your exam or any clinical question. Fine. So these are the different points. Also, other foramen I am telling you. See here. This is our cribriform plate of ethmoid. So from here, the fibers are coming out, making the olfactory bulb, olfactory tract, and olfactory stria. Sir, this is the first cranial nerve. This is the first cranial nerve. Agree? Yes, you will see the few rudimentary fiber near the first cranial nerve. These nerve fibers are at terminal position. This is known as the zero pair cranial nerve. This is nervi terminalis. Yes, this is also considered as a 13th pair cranial nerve. Sir, it is 13th pair cranial nerve. One update for all of you. Now, here is the optic canal. Remember, at this optic canal, there is a formation of the optic chiasma. Yes. So this is our position of the which cranial nerve? Short question is going to ask from here. Second cranial nerve. One question pattern integrating with other subject. Listen carefully. Listen carefully. Yes. If there is a pituitary gland tumor, pathology, medicine. 2 types of the pituitary tumor: pituitary adenoma, pituitary carcinoma. Pituitary adenoma is more common. Again, 2 types: macroadenoma, microadenoma. MCQ. What is the size? Sir, 10 mm. Less than 10 mm, microadenoma. More than 10 mm, macroadenoma. Yes. If there is a pituitary adenoma, there is a damage to this nasal fiber. Ophthalmology integration, nasal fiber is getting damaged. Physiology integration, nasal fiber, it is looking the temporal side. So there is bitemporal hemianopia. Getting the point? Yes, sir. And in case of the bitemporal hemianopia, try to catch this point. There is a change in the vision. Yes. When the patient is observing, then you will see the patient cannot see the right and left side, but he will be able to see only at the center. So this kind of the vision, here is the dark, here is the dark. So this is known as tubular vision. Very, very important MCQ. Don't forget it. This is our bitemporal anopia, bitemporal hemianopia. Now see, pituitary adenoma, which cells are getting hypertrophied? Physiology integration, physio, short question from here. Yes, lactotroph. If the lactotrophs they are proliferating, which tumor? Sir, prolactinoma. Ops-gyne integration. If there is a prolactinoma, then there is a natural amenorrhea. This is known as galactoria amenorrhea syndrome. Ops-gyne galactoria amenorrhea syndrome. Short question is going to ask from here. Agree everybody? Yes, yes, yes. Dr. Bean, Mohsin, hope you all are getting. Yes, very nice, very nice. Very good, very good. Yes, very good, Dr. Bean, excellent. What is a drug of choice for the galactoria amenorrhea syndrome? What is a drug of choice? Yes, you will give the, because the prolactin hormone, it is the dopamine antagonist, pharma. So you will give the dopamine agonist. Which is the dopamine agonist? Sir, bromocriptine. But bromocriptine is having the many side effects. So you will give the cabergoline. What is the drug of choice? Yes, cabergoline. Now look here. How you will treat? How you will treat? Sir, pituitary gland, we are giving the medical treatment. If not treated, then surgery. Pituitary gland is the king. It is sitting here. You cannot go from here. Neurosurgery integration. Look here, beta. Look here, neurosurgery integration. Yes. The pituitary gland is king. It is sitting here. So you will go from the nose, transnasal. Then you will break the sphenoid bone, transsphenoidal. Then you will cut the pituitary gland. That is our hypophyseectomy operation. So any topic which is having the multiple subject integration. Right now I told you anatomy, physiology, yes. Then your pathology, adenoma, pathology, pituitary tumor, medicine, neurosurgery, ophthalmology, ophthalmology, multiple subject integration. Sure, short, any question from this related topic is going to ask. I think we had seen the 7-8 topics which are going to ask from this our recent in our next NEET PG. Okay, fine. Yes, yes. Very good, Gautam, very good. So here is the Gautam Gupta, another GG. Don't forget this GG, genioglossus. Okay, so thank you, Gautam, for your participation. So we are looking the cranial nerves. Now try to catch this point. This is our superior orbital fissure. Sir, here is a location of 3rd, 4th and 6th. Yes, which cranial nerve? 3, 4, 6. So 0 is here, 1 is here, 2 is here, 3, 4, 6 are here. Sir, where is the 5? Try to understand. Largest cranial nerve, 5th cranial nerve ganglion. It is dividing into the 5th one, which is passing through the superior orbital fissure. Then 5th 2, foramen rotundum, maxillary nerve, foramen rotundum. And then 5th 3, foramen ovale. Hope you all are aware foramen ovale is passing the MALE. Yes, M for mandibular nerve, A for remember our, yes, accessory meningeal artery, L for laser petrosal nerve, E for emissary vein. Fine. So this is our 5th cranial nerve. I told you the 6th cranial nerve already. Then can you see this is the internal acoustic meatus? Yes, sir. It is internal acoustic meatus. So remember through this internal acoustic meatus, the nerve, yes, 7th, 8th, these are passing. So you can see 7th and 8th cranial nerve. These are passing through the internal acoustic meatus. Then MCQ, the second largest foramen of the skull. Remember, this is our jugular foramen. So from this jugular foramen, 9, 10, 11. I will tell you later in detail classes that jugular foramen is having the 3 part. Yes. What are the different 3 parts? Anterior part, middle part, posterior part. आगे आई, पीछे आई, बीच में, yes, 9, 10 and 11. 9, 10 and 11. आगे आई, inferior petrosal sinus. पीछे आई, yes, internal jugular vein. Also you can say sigmoid sinus. And in between 9, 10, 11, no excuse. And this is our hypoglossal canal from where the 12th cranial nerve is passing. All the things we had seen. But this is your question, which is considered as 13th pair cranial nerve and which is considered as 14th pair cranial nerve. So this is the question for all of you. I am not telling the answer. This is question for all of you, which is the 13th pair cranial nerve. I told you, na, but I had not told you the 14th pair cranial nerve. This is question for all of you. This is question for all of you. Agree? Yes. So now we are again looking this sure cranial nerve, cranial foramen. Definitely questions are going to ask. Can you see the cribriform plate of ethmoid? Yes, sir. So there is our olfactory nerve, olfactory bulb. Yes. Correct. I am helping you. I just told you there is our 0 pair or 13th pair cranial nerve, nervi terminalis. Can you see? This is our second cranial nerve. This is location of the pituitary gland. On its side, you can see the very important sinus, cavernous sinus. Yes, sir. Now, when you are cutting the cavernous sinus, you are looking at the lateral wall. Yes, third cranial nerve. Then the thinnest cranial nerve. This is the fourth cranial nerve. And beautifully, you can observe the fifth cranial nerve, which is dividing into the fifth one, fifth two, and the fifth three. Yes, sir. Beautiful diagram. And then you can see the sixth cranial nerve. Can you observe this artery? Yes, sir. This is a foramen spinosum. This artery is running, and it is passing here. Sir, this is our dura mater, and this artery is passing outside the dura mater. So this is our external dural hemorrhage. Yes, when this artery is getting ruptured, the blood is collecting outside the dura mater. This is your external dural hemorrhage. Remember, short, one question. I want to tell you, focus here, everybody focus here, that there is our dura mater. Yes, sir. There is our arachnoid matter, there is our pia mater, and then there is a brain. So outside the dura mater, extradural. Yes, below the dura mater, subdural. Below the arachnoid matter, subarachnoid hemorrhage. And inside the pia mater, within the brain, there is our intracerebral hemorrhage. What I want to tell you, try to focus over this point. Sir, this is our extradural hemorrhage. You can see this is subdural hemorrhage. You can see there is a subarachnoid hemorrhage, and you can see this is our intracerebral hemorrhage. Short one question. Tell me, extradural hemorrhage due to the rupture of which artery? Sir, this is due to the rupture of, yes, middle meningeal artery, mama. Subdural hemorrhage due to the cortical vein rupture. Subarachnoid hemorrhage, don't forget, it is due to the Berry aneurysm. And intracerebral hemorrhage, very important for the MCQ, hypertension, yes, high BP. Patho and the medicine question, no excuse. Agree everybody? Short, the question is going to ask from this topic. Agree, fine? Yes, don't forget the mamma. It is the middle meningeal artery. Later we will see the amma, accessory meningeal artery also later. Okay, fine. So hope you all are getting the point. Fine. Now look here. This is the sixth nerve, and you can observe the seventh and then eighth cranial nerve. Fine. And I want to tell you, this is one small part of the seventh nerve. Yes, it is our sensory division of the facial nerve, which is known as the nerve of, yes, Risberg. I want to tell you, yes, I'm telling you, it is the 14th pair cranial nerve. Yes, it is considered as the 14th pair cranial nerve, the sensory division of the facial nerve, which is also passing through the internal acoustic meatus. This is your 14th pair cranial nerve. It is considered as the 14th pair cranial nerve. Agree? So this is the update. Can you see? आगे आई, पीछे आई, आगे आई inferior petrosal sinus, पीछे आई sigmoid sinus, and in between them there is the, yes, 9, 10 and 11. 9, 10 and 11. So this is the bullet train anatomy. We are revising rapidly, and on the back side there is a definitely 12th pair cranial nerve. Getting the point? Agree everybody? Fine. So yes sir, this is our 12th pair cranial nerve. So you can see all the cranial nerves beautifully arranged from the front to the back. Again, first cranial nerve, olfactory nerve. Yes, 0 pair cranial nerve. You can see the second pair cranial nerve. Then after the 2, there is a 3, 4 and 5. And then 6. Then yes, our 7th and 8th. Then 9, 10, 11 and 12. Very simple. Just do practice again and again with the different sources. Fine. Yes, Anjali, you are right, beta. 14th pair cranial nerve, that is a nervus intermedius. It is also known as nerve of Pincus. Okay, no need for the so detail, but yes, it is beautiful. Now look here, dural venous sinuses. What I want to tell you, within our brain, beautiful three-dimensional orientation. Look here. Can you see here, beta? Yes, cranial cavity. We are doing dissection. So here is the fold of the dura mater. The fold of the dura mater, three-dimensional orientation for the cadaveric image, every kind of a thing. It is separating the two cerebral hemisphere. Sir, this is falx cerebri. So here, there is the one large vein. What is the sinus? A large vein is the sinus. It is superiorly. It is at the middle line. So superior sagittal sinus. Okay. So you can observe when you are removing this all the things, then you can see one another sinus. Sir, inferiorly. So inferior sagittal sinus. Agree? Now you can observe when you are removing this all the things, then you can see this is straight running sinus. Straight sinus. This straight sinus is created by the meeting of the great cerebral vein of Galen. Don't forget this great cerebral vein of the Galen. Why? Galen vein deformity. Radiology, pediatrics integration. Galen was the anatomist who kept the anatomy and the medical science in the dark knowledge. Dark era of the anatomy, PSM community medicine is saying the dark era of the medicine is related with this vein, Galen vein, and this question had been asked in NEET 2019. Galen vein deformity. Remember this Galen vein and our inferior sagittal sinus both are meeting together and making the straight sinus. Yes sir, it is a straight sinus, and this all the sinuses are meeting together and making the, yes, torculi hierophyllae. It is confluence of the sinus. One small MCQ, we are studying the anatomy and we don't know who is the father of anatomy. Can you tell me who is the father of the anatomy? Father of anatomy, tell me, father of anatomy. Yes, Herophilus. Hero of the anatomy, Herophilus. Don't say Vesalius. Don't say Vesalius. Don't say Vesalius. Vesalius is father of modern anatomy. Yes, we celebrate the anatomy day on the 16th October on the name of the Vesalius. Foramen of Vesalius is there. But Vesalius is the father of modern anatomy. Who is the father of anatomy? Herophilus, who studied the brain, proper study of the entire body. This is our torcular hierophyllae. Here is meeting of the different sinus. Then this sinus is running transversely. Yes sir, it is transverse sinus. And then it is taking the S-shaped course, sigmoid sinus. Now see, this S-shaped course is coming outside through the jugular foramen. Sir, this is our internal jugular vein. MCQ, internal jugular vein is formed by which vein? Answer is our sigmoid sinus. Agree everybody? Yes. Yes beta. Here, see here. Falx cerebri. Look here. Break the name. Falx cerebri. Falx means fold. Cerebri means, yes, cerebral hemisphere. So fold of the dura mater, which is separating the two cerebral hemisphere, this is known as falx cerebri. Agree everybody? Fine, fine. Getting the point? In the same way, there is the another fold of the dura mater, which is separating the cerebellum. So falx cerebelli. Getting the point? Also, there is a one little diaphragm over the pituitary gland, diaphragma celli, and one another, our fold of the dura mater over the cerebellum. That is our, yes, you will see our tentorial cerebelli. Fine. So you can see another. These all are the fold of the dura mater. Can you see? On your asking on your query, this is the falx cerebri, fold of dura mater. There is our tent shaped over the cerebellum. Yes, this is our fold of dura mater over the cerebellum, tentorial cerebelli. Another fold of the dura mater. Can you see here? Which is in between the cerebellum. Yes. This is very small fold which is known as falx cerebelli. One more fold of the dura mater over the Turkish shuttle, over the sella turcica, that is the diaphragma celli. More detail we can do, but this is the bullet train anatomy, so I am not doing too much. Okay, this is sufficient. Fine. Now we are moving for the next. Yes, on each side of the our king. Who is the king? Pituitary gland. There is the one large cavity which is having the small caves. Yes, large venous cavity which is having the cave. This is the cavernous sinus. You know? Yes. This cavernous sinus is related laterally with the different cranial nerves. Remember, it is related with the third, fourth, fifth one, and fifth two. So these are related. But Gray's Anatomy 42nd edition, it is not saying that fifth two is passing through here. It is passing outside. Yes, definitely fifth three is passing outside. But the Gray's Anatomy, again, Gray's Anatomy update. Fine. So remember, the Gray's Anatomy is saying it is not passing. So look at the options carefully. According to it, you have to say Gray's 42nd as well as 41st edition. They are saying this fifth two is passing outside. Now, can you see this is our internal carotid artery? Yes, sir. And here is our sixth nerve. Remember, this sixth nerve is passing through the one tunnel, dura mater tunnel. This dura mater tunnel is known as Dorello's canal. So this is the MCQ. Fine. Now you can see that internal carotid artery is giving the branch. Remember, internal carotid artery, it gives the ophthalmic artery. Agree? Fine. So this ophthalmic artery is supplying the eye. So if there is the cavernous sinus thrombosis, ENT, ophthalmology, also you will see in the medicine surgery, cavernous sinus thrombosis, dangerous area of the face, infection is reaching to the our cavernous sinus, there is a death. What will happen? Third cranial nerve damage. Eye symptom. Superior oblique will get paralysis because SO4. All the muscles of the eye supplied by the third, except SO4 and LR6. Yes, sixth cranial nerve will get damaged. Also, you will observe there is the involvement of the internal carotid artery. Yes, sixth nerve I told you. Fine. So definitely you must remember. But internal carotid artery is also involved in the cavernous sinus thrombosis. So ophthalmic artery is involved. So our thrombosed sinus is not pushing the blood to the eye. So according to the each beat of the heart, the eye is getting more and more force. So there is the pulsatile exophthalmos. What I want to tell you, the ophthalmology integration. Yes, there is our, remember, don't forget the Khurana pulsatile. Don't forget the our Parson pulsatile exophthalmos in case of the cavernous sinus thrombosis. Agree? Fine. Okay, now look here. This is one very interesting question. This is our H-shaped area. This H-shaped area is known as pterion. I told you here is the relation of the middle meningeal artery. Fine. So if there is the rupture of this middle meningeal artery, there is the accumulation of the blood on the lateral side. Getting the point? So this is our, yes, by convex, or you can say lens. Also few authors, they are saying the idli shaped. Yes, tasty yummy idli is observed. Okay, so this kind of the opacity is seen. So definitely it is due to the middle meningeal artery rupture. Yes, it is our extradural hemorrhage, where you can see the lucid interval also. Yes, the question from your NIMHANS exam. Remember, this middle meningeal artery is passing from the foramen spinosum. This foramen spinosum is passing the different structure MEN. M for middle meningeal artery, E for emissary vein, and N for nervous spinosum. Getting the point? Fine. So these are our different points. Yes. So foramen ovale, it was passing the mandibular nerve. Then accessory meningeal artery, amma. If I did any slip of the tongue, please correct it. The foramen ovale is passing the mandibular nerve. Then it is passing the our accessory meningeal artery, amma. And there is our also lesser petrosal nerve and the emissary vein. But this foramen spinosum is passing the M for mamma, middle meningeal artery, then emissary vein and nervous spinosum. Sometimes emissary vein is also absent. Now, fine. So we are looking for the our more very important topic for the NEET PG. Okay, so this is our ganglion, parasympathetic ganglion and the glands. Try to catch this point, sir. This is our neuron. Fine. So you can see the cell body. You can see there is our axon. Correct? Remember, the cell body collection within the CNS is known as nucleus, but outside the CNS is known as ganglion. Agree, everyone? So outside the CNS is the ganglion, and this is our axon. Remember, the bundle of the axon is known as tract. Bundle of the axon is known as the tract. Don't forget it. Agree, everybody? So we are going to look for this our parasympathetic ganglion. Fine. For which you have to remember the rule of the relay race. Whenever there is a relay race, what is happening? One person is giving the baton to the other, another is giving baton to the one more, and then. So in this way, the nerve will send the impulse. So try to understand. We are going to study the ganglion. Getting the point? Remember, these ganglion are located in our outside the CNS, in our head neck face area. 4 ganglion are there. What you have to remember? Sir, there is the otic ganglion, which is near the ear. Yes, it is related with the parotid gland, which is related with the 9th cranial nerve. MCQ. Short discussion. Yes, another thing you have to remember, below the mandible, there is a submandibular ganglion, which is related with the submandibular gland. Yes, we will see it is related with the facial nerve. Another thing, what you have to remember, that there is our one more ganglion. Yes, that is pterygopalatine ganglion. It is also related with the 7th cranial nerve. And also we will see the ciliary ganglion, which is related with the 3rd cranial nerve. It is seen in the our eye orbit. Okay, sir. Only one thing you have to remember. So try to understand. Whenever you are looking the tasty food, how there is a salivation. I'm just telling you the quick revision. Yes, in detail classes, I teach the student in detail. See here, this is the midbrain, here is the pons, and this is the medulla. In the pons, there is the superior salivatory nucleus and inferior salivatory nucleus. MCQ, S for superior salivatory nucleus, S for submandibular gland. Yes, the secretion from the submandibular gland is controlled by the superior salivatory nucleus. Whenever you are looking the tasty food, why there is a salivation, this is the topic, okay? This is our ganglion topic. But there is one more nucleus at the lower part of the pons. This is inferior salivatory nucleus. Getting the point? Remember MCQ, it is controlling the secretion from the parotid gland. In detail classes, I draw this all the diagram and teach. But right now, quick revision. See here. So as you are looking the tasty food, there is a salivation because there is the stimulation of this, our, yes, superior salivatory nucleus and inferior salivatory nucleus. Remember, we are talking regarding the parotid gland, otic ganglion. So impulse is coming from the inferior salivatory nucleus and it is running through the 9th cranial nerve. So you have to remember inferior salivatory nucleus and 9th cranial nerve. Now 9th cranial nerve is going to the supply, yes, it is going to supply the tongue and the pharynx. So it is giving one branch which is reaching to the middle ear cavity over the promontory, making it is the bunch. So it is our, yes, tympanic branch of the glossopharyngeal nerve. It is known as the Jacobson nerve. Remember, son create problem, daughter never create the problem. Son create the problem, daughter never create the problem. And one son is going to ask either the Parkinson or the Jacobson or the Wilson, and the biggest problem for the medical student, Harrison Davidson. So just I'm making fun, remember this Jacobson. Okay, so it is making the tympanic plexus over the our promontory. One branch is coming out and running over the petrous part of temporal bone. It is known as the laser petrosal nerve. MCQ, laser petrosal nerve is the branch of which nerve? Answer you can say, sir, 9th nerve. So this question had been asked. Now this laser petrosal nerve is coming out through the foramen ovale. Yes, it is coming out through the foramen ovale. So it is making one collection of the mass. This is our ganglion. Yes, it is our otic ganglion which is related with the ear. So foramen ovale, it is passing the mandibular nerve, amma, laser petrosal nerve, emissary vein. We know. Now from here the another nerve is coming out. This nerve will supply to the auricle and our parotid gland. So this is our nothing, sir. It is our auriculotemporal nerve. Damage to the auriculotemporal nerve is known as auriculotemporal nerve syndrome. Yes, it is known as our Fraze syndrome. So we are going to see the Fraze syndrome. But can you see, sir, this is our nerve and another nerve is starting from here. So there is a collection of the cell body outside the brain, outside the spinal cord. So this is ganglion. This ganglion is related with the ear. So it is otic ganglion. So simple. So if you will ask the question before the ganglion, sir, preganglionic fiber, and any fiber after the ganglion, postganglionic fiber. Which is the postganglionic fiber? Sir, auriculotemporal nerve is the postganglionic fiber. Agree everybody? Yes, sir. This is your postganglionic fiber. Now try to understand. Yes, come to here. Fraze syndrome. One patient, you did the parotidectomy operation. Parotid gland is around the paraotic position. Para means around, otic means here, parotid gland. So after that, he is going to the home and showing the reddishness, yes, sweating over the parotid area. Getting the point? So what is the situation? Try to understand what is the situation. Yes, look here. Sometimes when you are giving the incision over this angle of mandible, over the parotid area, over the shaving area, do you remember which nerve is supplying this skin area? Sir, great auricular nerve. Which nerve is getting damaged? Great auricular nerve. Agree? Now, inside to it, there is our parotid gland, within which there is the auriculotemporal nerve. Yes, sir, there is the auriculotemporal nerve. Agree? Sometimes auriculotemporal nerve is also getting cut. Now, the auriculotemporal nerve and the greater auricular nerve both are getting fusion. Yes. One line you have to remember, aberrant fusion between the great auricular nerve and our, yes, our, you have to remember the great auricular nerve and the auriculotemporal nerve. Abnormal fusion. Now what will happen? See here. Patient is eating the food. Yes, salivation, nucleus, they are getting stimulation. Impulse is relaying. Relay race is there. Yes, what I want to tell you, relays. One nerve is giving impulse to the other nerve is giving impulse to the other nerve is giving impulse to the another. Getting the point? So this inferior salivatory nucleus is giving impulse to the 9th nerve. And now Fraze syndrome we are looking. Now the impulse is jumping to the Jacobson nerve. Now tympanic plexus. Now laser petrosal nerve. Now it is giving impulse to the otic ganglion. Now from here the auriculotemporal nerve, it is causing the salivation. Yes, it is supplying the parotid gland and there is salivation. Patient is eating. But there is abnormal joining of this auriculotemporal nerve with the great auricular nerve, which is supplying the pinna, skin. Along with this great auricular nerve, sympathetic plexus are also there, which are supplying the sweat gland at this area. So sweat gland, they are getting activation. There is the sweating. Yes, these fibers are supplying the blood vessels around it. Fine. So this pathway has been stimulated. So the blood vessels over the our parotid area, yes, remember, these are getting dilatation. So there is more blood supply, more blood supply, more blood supply. That's why there is a reddishness as well as there is the, yes, sweating. Agree everybody? Fine. Yes, you are right, Anjali, you are perfect. So you all are the very amazing student. Now we are going to see the submandibular ganglion. Same theory, see here, you are looking the tasty food. Okay, you are getting salivation. How? Because it is stimulating the superior salivatory and inferior salivatory nucleus. But S for superior salivatory nucleus, S for submandibular gland, sublingual gland. So submandibular and sublingual gland, these are doing salivation. By which part? Yes, remember they are doing salivation due to superior salivatory nucleus. Remember, now the impulse is joining the facial nerve. So impulse is reaching to the facial nerve. Facial nerve is giving the branch which is passing. Yes, facial nerve is passing outside through the stylomastoid foramen. You all know facial nerve is giving the 5 terminal branches. I am not going there, you all know. Yes, facial nerve is giving the branch which is running over the tympanic membrane. This is our cauda tympani. Yes. This is the one cord-like nerve running over the tympanic membrane. That's why cauda tympani. This cauda tympani nerve is going and it is giving the impulse to the lingual nerve. Lingual nerve is supplying the anterior 2/3 of the tongue. So the impulse is reaching to the lingual nerve, but then it is giving the impulse to the another collection of the cell body outside the CNS. So this is the ganglion related with the submandibular gland. That's why submandibular ganglion. Now it will give the impulse again. It is joining the lingual nerve and then it is supplying the our sublingual gland, as well as the fibers are giving the impulse to the our, yes, sublingual gland and submandibular gland. So there is a salivation. So this is difficult, but what you have to remember, submandibular ganglion, it is related with which fiber? Yes, inferior salivatory nucleus, facial nerve. Sir, facial nerve, sufficient. So preganglionic fiber, yes, facial nerve, cauda tympani, sufficient. And after this submandibular ganglion, the postganglionic fiber. Okay, it will be helpful for all of you. So this is the point. This is the same image. Now look here, pterygopalatine ganglion. We are going to integrate with the vasomotor rhinitis. Yes, our ENT, conceptual brainstorming integration. Agree everybody? Yes. So this is the bullet train anatomy. So we are doing everything in the rapid way, but try to understand, yes, the important points you are covering. In detailed classes, we will do all the things with proper drawing and every point with the proper understanding. But right now, can you see? See here. This is beautiful image from the 38th edition of the Gray's Anatomy. Yes. Can you see? This is our pterygoid plate and this is palatine bone. Yes, here is sphenoid bone. So you can observe one cavity here. Can you see? Yes, there is one cavity. This cavity is in between the pterygoid and the palatine bone. What should be the name? Pterygopalatine fossa. Cavity is the fossa. Yes, the door, the margin is fissure. Pterygopalatine fissure. And one collection of the cell body inside it. This is our pterygopalatine ganglion. Easy. Now, see here. This is sphenoid bone. So this fossa is between the sphenoid bone and the palatine bone. So the same is also known as, yes, sphenopalatine fossa. Door is known as sphenopalatine fissure. Margin is known as sphenopalatine fissure. And the ganglion is sphenopalatine ganglion. All are same. Agree? Type 1 hypersensitivity, allergy reaction, microbiology integration. Yes, type 1 hypersensitivity, allergy. Yes, type 1 hypersensitivity. In that situation, this ganglion is getting activation. So there is the secretion from the eye, nasal gland, palatine gland. Okay. So try to catch this point. Yes. So can you see? Just above this, our pterygoid bone. You are getting there is a one bony canal. Yes, sir. This is our pterygoid canal. So the nerve which is running within the pterygoid canal, yes, this is our nerve of pterygoid canal. It was studied by the Vidian. That's why it is also known as the Vidian's nerve. Agree? It is known as the Vidian's nerve. Yes, it is a little bit difficult, but try to concentrate. Try to understand. Yes, sir, this is the Vidian's nerve. We are going to see the neurosurgery and ENT. Now, catch here. How this Vidian's nerve is formed? Gray's Anatomy 48th edition. Yes, it is coming from one nerve. This is our facial nerve. Can you see? Yes, it is coming from the facial nerve. Geniculate ganglion, it is giving one nerve. G for geniculate ganglion. One nerve is coming, which is great, running over the petrous part of temporal bone. That's why greater petrosal nerve. So remember this MCQ for the ENT purpose, that greater petrosal nerve, it is the branch of the facial nerve. Agree? Can you see? This is our internal carotid artery. There is a bunch of the nerve around this internal carotid artery. So there is sympathetic plexus around it. It is making one another nerve. This nerve is running at the deep part of the petrous part of temporal bone. Yes, petrous temporal bone. One nerve deeply. So deep petrosal nerve. See here, deep petrosal nerve plus greater petrosal nerve, they are uniting in the Vidian's canal, making the Vidian nerve. Again, what I want to tell you, very important equation, Vidian's nerve is equal to greater petrosal nerve plus deep petrosal nerve. Khatam, tata, bye-bye. Okay, gaya. This is very important MCQ, Vidian nerve, which is known as the nerve of pterygoid canal. Summary. Yes, it is formed by the union of the greater petrosal nerve, also known as greater superficial petrosal nerve, and the deep petrosal nerve. MCQ. This greater petrosal nerve is the branch of facial nerve at the geniculate ganglion. G for geniculate ganglion, G for greater petrosal nerve. Yes, it is coming from the internal carotid artery. Internal carotid artery, there is a sympathetic plexus around the internal carotid artery. Yes, remember it is T1, sympathetic nerve. So these are uniting within our, yes, pterygoid canal. Getting the point, beta? This is thing which you have to remember. Yes, the impulses, whenever there is the allergy, dust particle, then this ganglion is getting stimulation and impulse is reaching through this nasal part, palatine part, and there is the, yes, type 1 hypersensitivity reaction, nasal secretion, palatine secretion, lacrimal nerve secretion. I'm not telling you that all the point because clinical anatomy is important. So try to understand. If you have to treat the vasomotor rhinitis, yes, what you will do? Treatment of the vasomotor rhinitis. Sir, prevention is the best. PSM is the best. Prevention is the best treatment. Allergic case, type 1 hypersensitivity, you cannot treat. But if there is an inflammation, yes, give the antihistaminics. Okay, yes, anti-inflammatory drugs. If it is not treated, then you can give the steroid. And if it is not treated, then surgery. Yes, come to the neurosurgery. This surgery, what you will do, see here, this is very safe canal. You have to cut the Vidian now here. This is known as Vidian's neurectomy. Agree, everybody? Yes, beta. It also supplies the lacrimal nerve, but I'm not going to tell you. Yes, it is giving the branch to the maxillary nerve, then maxillary nerve, then from here it is giving the zygomatico branch, then zygomatico temporal branch, then zygomatico temporal to the lacrimal gland. So this is the pathway. But okay, that is not important. Clinical, next pattern is there. Clinical is important. This point is important. You have to remember. I told you in short, na? I told you that all the things in brief, but what you have to focus the clinical point, PSM, antihistaminic, yes, steroid you have to give, neurosurgery, you have to cut this Vidian's nerve. This is known as, yes, Vidian's neurectomy. Agree, beta? So this is the importance of this ganglion. Vasomotor rhinitis, the refractory cases you can treat here. Agree? Fine. Hope you all are getting the point. Now see here. Yes, here is all the pathway I told you in the diagrammatic presentation. You can go through it. Okay. Now see here, ciliary ganglion. So in the orbit, can you see eyeball? And here is our lateral rectus muscle. So this is our second cranial nerve, optic nerve, and lateral rectus. So there is a one mass, pinhead size mass is there. It is related with the ciliaris muscle. That's why ciliary. It is outside the brain. That's why ganglion. So it is our ciliary ganglion. Can you see? Yes. See here. The ciliary ganglion, I am telling you the pathway. what you have to remember. Sir, this is the ciliary ganglion. See here, at detailed classes, we draw this all the diagram, but right now, there is our third cranial nerve nucleus at the midbrain. Yes, there is a parasympathetic nucleus, Edinburgh-Westphal nucleus. So, impulses are coming from here. Now, the impulse is running through the third cranial nerve. Sir, third cranial nerve is passing through the lateral wall of the cavernous sinus. It is dividing into the superior and inferior division. Yes, the inferior division is passing through the superior orbital fissure and it is going in the orbit. So, it is giving one branch which is supplying the inferior oblique nerve, nerve to inferior oblique. Here it is giving one branch and then the another nerve is starting. So you can observe there is the collection of the cell body outside the CNS. Sir, this is our ciliary ganglion. Yes, it is our ciliary ganglion and these nerves are a short ciliary nerve. I told you this is the ganglion. The fiber after this ganglion, post-ganglionic fiber, and the fiber before it, sir, it is pre-ganglionic fiber. Agree everybody? Fine, fine. Yes, you all are right. It will go through the nasociliary. Fine. Yes, PSM, why I told you? Prevention is the best treatment. That's why PSM, okay? Okay, fine. So these are our different points. We had seen the many things related with our head, neck, face and our neuroanatomy, but more things regarding the neuroanatomy. Tell me. A patient presents with the ballistic involuntary movement. What is your answer? Yes, ballistic projectile throwing movement. It is controlled by the subthalamic nucleus of the Lewis. This is very old question, 2010 question, which had been repeated in the 2021 and 2022. Actually, this question pattern is coming from the 2010 now. It is not the new question I want to tell you. Yes. Now see here, a patient presented with the vision loss. So this is the ophthalmology question. On radiological investigation, aneurysm causing the damage to the optic chiasma noted. Following arteries most commonly. So optic chiasma, it is very close to the anterior communicating artery. So this is the question. Circle of Willis is important. So one question from the blood supply of the brain. Now a patient presented with the clinical features of the ataxia. Yes sir, ataxia. And in coordination, which artery is getting thrombosed? So remember ataxia and in coordination, sir, it is related with the cerebellum. Fine. Yes, cerebellum. So artery of the cerebellum, remember, it is related with the cerebellar blood supply. So posterior cerebral, no sir, it is brain. Yes, middle cerebral, no sir, it is brain. Internal carotid artery, it is brain. Yes, cerebellar. So in this situation, answer will be the superior cerebellar artery. Yes, again I want to tell you, one question sure from the cerebellum, but now every question from the cerebellum, okay? So just I'm saying one funny thing so you can remember the cerebellum topic, okay? Don't take seriously, and yes, you can take seriously also, fine. So what I want to tell you, which fiber is marked by the arrow in the image given below? So there was the image, fine. I will tell you, but right now, sir, this is internal capsule and internal capsule is inside capsule and inside capsule, it is the bundle of the tract and tract is simply, tell me, short association fiber, long association fiber, projection fiber, commissural fiber. Tell me, yes, tract, they are projecting from the brain to the outside or from the outside to the brain. So answer is projection fiber. Agree? Yes, very nice. Now tell me this beautiful question. Yes, this is the 2019 dermatome. One question dermatome, short from the dermatome. Yes, tell me, what is the nerve supply? Sir, umbilicus is supplied with the T10. Remember, umbilicus is supplied by the T10. Testis is supplied by the T10. Yes, small intestine is supplied by the T10. Appendix is supplied by the T10. So the referred pain of this, all the structures come to this umbilicus. Agree? Now see here, I told you, identify the marked structure. This question had been asked many times. So first, identify what are the different structures. I told you, the corpus callosum. See, just below to it, lucid, translucent. Yes, you can see translucent appearance, septum pallidum, and definitely it is fornix. Then I told you thalamus and hypothalamus, and here will be our pituitary gland. Then I told you there is the MPM. Yes, you can see the superior colliculus, you can see the inferior colliculus, and definitely it is our cerebellum. Can you see there is our CSF flowing pathway? You can observe cerebral aqueduct of Sylvius, and this is our fourth ventricle and the central canal. Getting the point? And where is the third eye of the Lord Shiva? Yes, Bhagwan Shankar ki teesri aankh. This is our third eye of the Lord Shiva. Pineal gland. Agree? So remember, this is our fornix. So identify fornix. I will tell you about the fornix later. Fine. Now this is the NEET PG 2018. Yes, Broca's area, where you know Broca's area is located at which part? Yes, yes, yes. Tell me, sir. It is located at our inferior frontal gyrus. So definitely you will see the brain section. Fornix is very hot topic right now, and cranial nerves. These are our circle of list. So these are the hot topics. So we had seen approximately 10 to 12 topics which are going to show us from the anatomy purely. Other subject more question we had seen. Fine. So now we are looking the our neuroanatomy part. How to study the neuroanatomy? Try to understand. Yes, whenever you are studying from the basics, then first you have to study the spinal cord. Agree? Yes, sir. And after this spinal cord, you have to study the medulla, then pons, and then midbrain. And don't forget to cover the cerebellum. One question sure. And then you have to study the gray matter, then white matter, and then within the our white matter, there is the collection of the gray matter which is known as the basal. Tell me, it is ganglion or nuclei? Sir, it is within the brain. So it is not the ganglion, but it is the basal nuclei. So in this way, from below to the above, you have to study. Agree? Yes, Divyanand, you are right, beta. Fornix is the classical example for the all kind of the fibers. Okay. So there is the one interesting question. In the children, you will see the spinal cord is up to the end. But as the baby is growing, you will see it is ending above. And in the adult, yes, it is ending at which level? Old answer is L1, L2 junction. But then it becomes lower bout of the L1. But the best answer is the L1, middle 1/3. Update again from the grays. 41st and 42nd. Again, I want to tell you, yes, this is just to show you. Okay, so remember, this is the Gray's Anatomy update. This question had been asked. Remember the L1. The spinal cord is ending in the adult at the L1. Don't forget it. Okay. So now we are cutting. Yes, we are looking the, yes, this is the site for the lumbar puncture where you insert the needle and remove the lumbar puncture needle. Okay. So what I want to tell you, yes, adult, children. Where the spinal cord is ending, answer is L. You can remember, yes, our L1, L2 junction. Single answer, L1 is best. Fine. But lumbar puncture where you will do, definitely below to it. So L3, L4, MCQ. L3, L4, lumbar puncture site, MCQ. L3, L4, it is the site of the iliac crest, MCQ. And remember, this L3, L4 is the site for the umbilicus. Yes, if any FMG students are looking, then for them, yes, remember umbilicus, vertebral level, L3, L4, 3 MCQs. But in children, lower side. So remember, in the children, answer is L3, L4. So lumbar puncture you will do at the L4, L5. So this is the pedia, medicine, and anatomy integration. Don't forget it. Each point is your question, site of the lumbar puncture and your ending of the spinal cord. Agree? Fine. Yes, Kalpita, lumbar puncture is done at the L3, L4 in adult. But in children, L4, L5, according to the Nelson and the Ghai. Yes, the spinal cord ending in adult, L1 is the best answer, not given, then L1, L2 you can mark. But in children, L3, L4 you will say. Agree, everybody? Fine. So now what we are looking, yes, we are cutting our spinal cord and you are looking the gray matter and the white matter. Agree? So there is our central canal and butterfly shaped white matter. So this butterfly shaped white matter, it is dividing the white matter into dorsal white column, lateral white column and anterior white column, where you will see the tract. Getting the point? Remember, this gray matter is again divided into the Rexed 10 lamina. MCQ from the INICET. The second lamina is having the substantia gelatinosa nucleus. Integration with your pharmacology. Remember, it is related with the pain and temperature. So if you want to use the painkiller, what you will do? Inhibit this substantia gelatinosa nucleus. Tell me which drug. It is written in your pharma book. It is written in your pharma book. Sorry. Mechanism of action of the morphine. Yes, you all know this morphine is inhibiting. Yes, it is acting over the mu receptor, kappa receptor, delta receptor. But one line from the Goodman-Gilman and your KDT, morphine inhibits the substantia gelatinosa nucleus. So it inhibits the pain and temperature. And you know, this morphine is given as the mona lutulosona, morphine, oxygen, nitroglycerin, and aspirin. This all are the treatment for the angina. Very, very beautiful thing. Remember the second lamina, rexed lamina is there. Only one fact you have to remember this, because this question had been asked many times. And in the white matter, you will see the different bundle of the tract. Remember, on the dorsal side, yes, at the dorsal side there is a fasciculus gracilis, and at the lateral side fasciculus cuneatus. These are responsible for the fine touch sensation. Okay, while the lateral side, dorsal spinocerebellar tract, ventral spinocerebellar tract, and here is a lateral spinothalamic tract. Dorsal and the ventral spinocerebellar tract, they are responsible for the subconscious kinesthetic sensation, and lateral spinothalamic tract, it is pain and temperature pathway. While on the entry side, you will see the entry spinothalamic tract, which is responsible for the crude touch sensation. Also, there are the motor tract, yes, lateral corticospinal tract and entry corticospinal tract, and different extrapyramidal tract. But yes, this is right now more important thing is the cranial nerves, different nuclei. So we are going to focus, and we are going to see this beautiful table. Okay, so look here, can you see this bulb like dilated part? Yes sir, this bulb like dilated part is medulla. Remember, the medulla is the bulb. So what is the bulbar paralysis? Sir, medullary paralysis is the bulbar paralysis. Agree? The central elevation is our pyramid, the lateral elevation is olive. Fine. Remember, just behind the pyramid, whatever the nerve is visible, that is the 12th nerve. And behind the olive, whatever the nerves are visible, they are 9th, 10th, 11th. Getting the point? What you have to remember? Medulla, it is related with the 9th, 10th, 11th, 12th cranial nerve. So remember, medulla is bulb like dilated part. Yes. So what I want to tell you, what is the bulbar paralysis? Always you will study in your pedia and the medicine, bulbar paralysis. It is nothing. It is medullary paralysis. So in bulbar paralysis, you will see there is the 9, 10th, 11th, 12th cranial nerve damage. MCQ, integration. Fine. Now look here. This broad part is our, yes, pons. Sir, this is the pons. Yes sir, this is the pons. Agree? Pons means bridge. So what are the different cranial nerve? Yes, you can see there is our largest cranial nerve, 5th cranial nerve at the pons, and at the pontomedullary junction, can you see 6th, 7th, and vestibulocochlear nerve 8th. So these are the cranial nerve which are related with the pons. So pontine syndrome, if there is a pons damage, 5th nerve damage, 6th nerve damage, 7th nerve damage, 8th nerve damage. Very simple. Your anatomy will create the basics for the brainstem syndrome. Harrison. Agree? Now, look here. This is your midbrain, crus cerebri. Fine. So, you are able to see there is our medial 3rd cranial nerve, and at the back side, you can see there is our, yes, 4th cranial nerve. Getting the point? So, this is our crus cerebri. Yes, these are related with which structure? Midbrain. And you can see beautifully there is the crossing nerve. Definitely, damn sure it is our 2nd cranial nerve. And you can see one more fiber which is on the front. So this is the 1st cranial nerve. Agree everybody? So in this way, these different cranial nerves are from the front to the back side. One summary I am giving to all of you. See here. Cranial nerve nuclei. Yes, color coding for all of you. See here. This 1st and 2nd cranial nerve, these are having no nuclei. While the 3rd, 4th, these are having the midbrain nuclei. While the 5th, 6th, 7th and 8th cranial nerve, these are having the pontine nucleus. While the 9th, 10th, 11th and 12th cranial nerve, yes, these are having the medullary nucleus. So what I want to tell you, your formula is 2, 2, 4, 4. Agree everybody? If you are getting the point, yes, yes, yes. Don't lose your stamina. Don't lose your energy. Yes. रात ये आगे बढ़ते चली जाएगी और हम रात कली की तरह महकते चले जाएंगे. हम थकेंगे नहीं, हम रुकेंगे नहीं. Okay, so remember, keep your energy high. Yes, always remember you are amazing, you are beautiful, and yes, if you want extra, you have to do extra. अगर आप कुछ extra चाहते हैं तो आपको extra करना ही पड़ेगा. If you want to bleed less in the war, you have to sweat more in the practice. Getting the point? तो अगर हम अभी अभ्यास में ज्यादा पसीना बहाएंगे तो जब युद्ध होगा तो हमारा खून कम बहेगा. अगर हम प्रैक्टिस नहीं करेंगे, हम हार्ड वर्क नहीं करेंगे तो बेटा जब युद्ध होगा तलवारें चलेंगी और खून निकलेगा. हमको खून नहीं बहाना है, हमको पसीना बहाना. सेम थिंग. एंड यस, योर एनर्जी इज माय एनर्जी. इफ यू विल शो द एनर्जी, आई विल गेट द मोर एंड मोर एनर्जी. सो टेल मी व्हाट आर द our different cranial nerves. Yes, there is the 2, 4, 4. First two cranial nerves, these are having no nucleus. MCQ. Third and fourth, these are having the midbrain nucleus. Yes, fifth, sixth, seventh, eighth, these are having nucleus in the pons. Agree beta? Fine. Hope you all are getting the point. While the 9th, 10th, 11th, 12th, these all are getting the, yes, these all are having the nucleus in the medulla. So this is the basics. Yes, yes, yes. Yes, thank you, Dark Knight. Yes, please, dear students, if you are enjoying the session, please give me the beautiful comments. Yes, such kind of the positive appreciation, it enhances the energy for we all the teachers. Okay, so thank you, Dark Knight, for your for very beautiful comments. So hope you all are enjoying beta. Yes, and any kind of the problem, we can do the detail session also later. Okay, but this is the bullet train anatomy, so we have to move fast. Okay, now see here, there is our brain stem syndrome Harrison. So definitely if there is our medulla damage, sir, 9th, 10th, 11th, 12th cranial nerve damage. Pontine damage, sir, 5th, 6th, 7th, 8th cranial nerve damage. Midbrain damage, 3rd, 4th will be affected. Now locate them according to their position and different things. Okay, so these are the different points. So what I want to tell you, attachment, sir, the first and second, they are attached at frontal lobe inferior side. Yes, 3rd and 4th, these are attached where, sir? These are attached at the midbrain. Yes, 5th, 6th, 7th, 8th, these are attached at the pons. Same color coding. And 9th, 10th, 11th, 12th, they are attached at the medulla. Same color coding. But this 3rd cranial nerve, it is medial to crus cerebri, while the 4th is lateral to crus cerebri. Yes, 5, 6, 7, these are at 5th cranial nerve at pons ventral surface, while the 6th, 7th, 8th at pontomedullary junction. Yes, 9th, 10th, 11th, they are attached behind olive, but this 12th nerve was attached behind pyramid. You can go through the image also. Now see the foramen. Yes, you all know, I am just telling you, the first cranial nerve, it is passing through our cribriform plate of ethmoid. The second cranial nerve, it is passing through, yes, tell me, optic canal. 3rd, 4th and 6th, these all are passing through the superior orbital fissure. We had seen the 5th nerve, 5th one, 5th 2, 5th 3. Yes, 5th one, it was passing through the superior orbital fissure. 5th 2 was passing through the rotundum foramen, and 5th 3 through the oval foramen. Yes, sir, it was passing through the oval foramen. Getting the point? MCQ. Yes, 7th and 8th through the internal acoustic meatus. 9th, 10th, 11th through our jugular foramen, and 12th cranial nerve, yes, it is passing through our hypoglossal canal. So this is very important table. Agree beta? Fine? Done? Now look here, what are the different functions? So you will see this all the things. Sir, this first cranial nerve is responsible for the smell. If there is a damage, there is the anosmia. Yes, optic nerve, it is responsible for the vision. If there is a damage, there will be the anopia. Yes, this 3rd cranial nerve, 4th, 6th, they all are supplying all the extraocular muscle. All extraocular muscle supplied by the 3rd cranial nerve except SO4, LR6. So if there is a damage to the 3rd, extraocular muscle, they are getting paralysis. 4th nerve, superior oblique is getting paralysis. 6th nerve, lateral rectus muscle is getting paralysis. Okay, now look here, there is our 7th nerve. So 7th nerve damage, it is causing the facial palsy. 5th nerve damage, it is causing the, yes, trigeminal neuralgia like symptoms. Also the muscle of mastication, they are involved. Yes, 9th nerve is getting damaged, 10th nerve is getting damaged. Then these are supplying the tongue taste sensation. So tongue taste sensation, posterior 1/3 and posterior most part, this is getting lost. And 11th cranial nerve, it is supplying the sternocleidomastoid and trapezius. Yes, you know, the trapezius is responsible for the elevation of the shoulder, shrugging of the shoulder. If there is a damage to this 11th cranial nerve, the spinal root is getting damaged. Yes, trapezius is not responsible for elevation. So there is the, yes, opposite shoulder is normal and another shoulder which is affected, that is getting droop. Okay, so this is nothing, it is our Pushpa syndrome. Pushpa jhukega nahi sala. Yes, he was having the damage to the 11th cranial nerve, one funny way you can remember, and 12th cranial nerve, definitely there is a deviation of the tongue, you all know. Yes sir, there is ipsilateral tongue deviation, remember, same side. Agree everyone? Fine. So these are the different points. Yes, yes, dark night, you are right, beta. And also there are the different kind of the brain section. Okay, each level there is the spinal cord, gray matter, white matter, you can see the medulla. Then you can see the central elevation is our pyramid, lateral elevation is the olive, and you can see the different point. But this section is important. Can you tell me? Just tell me the same thing. Yes, it is our midbrain. Can you see? There is the one part which is negro in appearance. My question, this is A, here is B. Which is normal, which is abnormal? Yes, this is one substance which is negro. This is our substantia nigra. Fine. Which is normal? A is normal or B is normal? I want to tell you, within this substantia nigra, there is a biochemical cycle. So biochemistry integration, yes, try to understand. There is our tyrosine. It is making the phenylalanine. It is making the dopa, and it is making the, yes, dopamine. Agree everybody? Yes. So students are saying B is normal. Yes, B is normal. Correct. See here. Very nice. This is black. Black, why? Because this synthesizing cycle is running, and this dopamine, yes, it will make the melanin also. These all are the pigment. So if it is black, then it is normal, and if it is not black, so this is abnormal. Remember, this situation is your Parkinson disease. Agree? Yes, this is the Parkinson disease. This is the pathology. Normal is anatomy, abnormal anatomy is the pathology. And now see, Parkinsonism, you all know. Definitely one question from here. Try to understand. Yes, there is the acetylcholine, there is a dopamine. Yes, integration, fine. So acetylcholine is responsible for the excitatory tone. Yes, it is excitatory neurotransmitter, so it will cause the contraction, while the dopamine is inhibitory neurotransmitter, so it will be inhibit. So there is the decreased tone. There is a proper balance between this acetylcholine and the dopamine. Yes, dopamine from the biochemistry, fine. But if there is a Parkinsonism, substantia nigra damage, in that situation there is a decrease in the dopamine, so acetylcholine relative increase in level. Fine. So there is the increased tone, hypertonia, rigidity. Yes, there is a tremor, hypokinesia. Agree? Yes. Mask-like face, pill rolling movement, fascinating gait. Patient is trying to catch the center of the gravity of the earth. Parkinsonism. So what you will do? Increase the level of the dopamine. Yes, now come to the pharmacology and the medicine. Increase the level of the dopamine. How? Dopamine agonist, dopamine facilitator, yes, dopamine precursor. You will give the different drugs, yes, bromocriptine, entacapone, yes, different enzyme inhibitor, dopamine decarboxylase inhibitor, yes, COMT inhibitor. You will give the different kind of the many drugs, MAO inhibitor, seleziline. Yes, best treatment is precursor of the dopamine, L-dopa plus COMT inhibitor, dopamine decarboxylase. Sure question is going to ask from here. Yes, abnormal movement is there. Nowadays they are asking the abnormal movement like the ataxia, like the hemibellismus. One question sure in the NEET PG 2023. We are disclosing all the question paper. Yes, we are expecting these are the current pattern. So these question will be asked. Okay, agree everybody? Fine. So this is the point. Now we are going to see the different gray matter part. So you all are aware that there is a central sulcus, in front of it area number 4, and behind to it sensory area 312. If there is a damage in the area number 4, motor area, motor weakness, motor activity is lost. Getting the point? So there is our paralysis. There is a damage to this sensory area, loss of sensation. Yes, this is premotor area which gives origin to the extrapyramidal tract. There is a superior and inferior frontal sulcus. So behind our middle frontal gyrus there is the area number 8. This is our frontal eye field area which is responsible for the conjugated saccadic movement. Yes, you can see there is the area number 9, 10, 11, 12. This is the prefrontal lobe. If there is a damage in this prefrontal lobe, there is a prefrontal lobe syndrome. And what is the prefrontal lobe syndrome? Yes, Munna Bhai MBBS, Anand Bhai. Are you know? Do you know this Anand Bhai character? Yes. Just constriction and dilatation of the pupil. This is the prefrontal lobe syndrome. Loss of personality, loss of judgment, loss of behavior, this all the things. And yes, at the lower part, you will see the area number 44, 45. This is our Broca's area, motor speech area. If there is a damage, motor aphasia. Now, see here, this is our temporal lobe. This is our area number 41, 42, which is the primary auditory area. If there is a damage, hearing loss. Agree? And around it, there is the our area number 22. This is our audito-psychic area. Yes, this is secondary auditory area. If there is a damage, auditory agnosia. MCQ. Yes, the posterior part of this auditory area is our area number 22. Getting the point? This posterior part of the area number 22, it is Wernicke's area, sensory speech area. If there is a damage, there is a sensory aphasia. Okay, bullet train anatomy, I am revising rapidly, recalling for all of you. Okay, yes, this is area number 17, primary visual area. If there is a damage, there is a blindness. And around it, there is the area number 18 and 19. So this is the secondary visual area, visual agnosia. And you can see there is a 312 sensory area. There is an intraparietal lobule. Yes, intraparietal sulcus. So there is a area number 5 and 7. Question from your NIM hands that which sensation is earliest lost in old age? Answer is our yes, vibration and stereognosis sensation, which are relaying into the superior parietal lobule, area number 5 and 7. So it is the earliest sensation which is lost at old age. This loss of vibration sensation is also known as palanesthesia or palästhesia. These are the MCQs. So now look here, we are cutting the brain. So this is our brain section. You can see the suprolateral surface and you can see the medial surface of the brain. Agree? Fine. So you are observing the homunculus presentation. Whatever the part of the body which is more and more active, yes, they are having the more and more area. Facial muscle, too much fast. Tongue, चमड़े की जुबान बहुत तेजी से चलती है. Yes, tongue is having the too much receptor. So these are having the more and more motor activity and more sensory activity. So these areas are larger. Hand, yes, our hand is having the too much fast activity. Getting the point? Too much fast activity. So this is our, remember, yes, it is our, yes, fine movement area. Fine. So it is, hand is very large. In the same way, foot. But remaining part, they are having not too much sensory and motor activity, so small. So you are presenting these areas of the brain at the different part. So this is known as homunculus representation. Face and body, they are on the supralateral part. Remember, this entire part is supplied by middle cerebral artery. So if there is a middle cerebral artery damage, medicine, there is the Bell's palsy, aphasia. Yes, you will see upper limb paralysis. The medial surface is supplied by anterior cerebral artery, paracentral lobule, septum pellucidum, corpus callosum, fornix, all are supplied by anterior cerebral artery. Very important question. If there is a damage to this anterior cerebral artery, yes, patient will do defecation on the bed, patient will do urination on the bed, there will be erectile dysfunction due to the paracentral lobule involvement. Okay? Yes, lower limb paralysis, paraplegia. MCQ. Agree already? Fine. Fine. So these are the different points. Yes, Parkinsonism is the resting tremor. You are correct, beta. Fine. Okay. Now see, this is the medial surface of the brain. All the areas are at one side, but this paracentral lobule at one side. This is perineal region. It is controlling the bowel, bladder and the genital opening. So if there is a damage, defecation abnormality, urination abnormality, erectile dysfunction. Agree? And I told you, whenever you are looking the medial surface, there is a CSF. C for corpus callosum, S for septum pellucidum, F for fornix. If anybody is asking what is the blood supply of this all the structure, medial surface is supplied by anterior cerebral artery. This CSF, fornix blood supply had been asked in your INICET. All are supplied by the anterior cerebral artery. And you can see the paracentral lobule, yes, it is supplied by which artery? Again, anterior cerebral artery. MCQ. Fine. Now, look here further. The blood supply of the brain is by the circle of Willis. Very important. How this circle of Willis is formed? See here, there is a common carotid artery, which is making the internal. Internal carotid artery is reaching in the brain. You can see the vertebral artery. It is passing through the vertebra. Yes, more details are there. We are looking the important thing. The right and left vertebral artery, they are making the basilar artery. And then these are anastomosing together. Yes, it is our circle of Willis. Yes, you can observe here. Can you see this beautiful diagram? Vertebral artery, vertebral artery. These are uniting and making the basilar artery. Here is our internal carotid artery. Internal carotid artery is giving the branch anterior cerebral artery, which is anastomosing together with the anterior communicating artery. Yes, you can see this is posterior side, posterior communicating artery. This basilar artery is dividing into the our posterior cerebral artery. Yes, sir. There is our posterior cerebral artery. Agree? So this is circle of Willis, which is formed by first anterior communicating artery, second, yes, anterior cerebral artery, third, internal carotid artery, fourth, posterior communicating artery, and then fifth is our, yes, posterior cerebral artery. Many more questions are there, but this is very important. Tell me if there is the optic chiasma. Yes, you can see this is our pituitary gland and this is optic chiasma. So pituitary tumor, it is causing damage to the optic chiasma. Yes, pituitary tumor, it will cause damage, most common chance to the damage to the anterior communicating artery. Yes, it will cause again tubular vision. Getting the point, everyone? Fine. So these are our important points which you have to remember. Yes, this is the same cadaveric image. You can see the vertebral artery, it is making, yes, vertebral artery, it is making the basilar artery. Basilar artery is dividing into the posterior cerebral artery. You can see here the internal carotid artery. This internal carotid artery, they are giving the anterior cerebral artery and they are joining as the anterior communicating artery. Yes, this is the posterior communicating artery. Remember the Berry aneurysm, which is responsible for the subarachnoid hemorrhage. Pathology, Robbins integration, most common susceptibility, most common chance, anterior-most. Then incidence is decreasing from anterior to posterior side in our circle of Willis. Medicine and the pathology integration. Okay. Now, look here. This is our brain. Gray matter, white matter, and at the base of the brain, there are our few more gray matter mass. These are located at the base of the brain. So, basal within the CNS. So, ask for the nuclei. Don't say ganglion. Don't say ganglion. Basal ganglion is misnomer like the amyloidosis. Amyloidosis is misnomer. Basal nuclei is the correct term. Okay. So, we are looking for the white matter, then we will see the basal nuclei. What are our different white matter? So, remember the Rowdy Rathore. Chintata, Chita, Chita. Okay. So, ACP Rathore. So, you can remember the ACP. What are the different white matters? Yes. Association fiber. C for commissural fiber. P for projection fiber. Simple. See here, association fiber, they are associating the nearby area in same cerebral hemisphere. Yes, commissural fiber, they are joining the two different cerebral hemisphere. And you can see the projection fiber, they are projecting outside to the inside or inside to the outside. Simple. ACP Rathore. Rowdy Rathore, you have to remember. Okay. Now, look here, the corpus callosum. Remember, C for corpus callosum, C for you have to remember it is classical example of the commissural fiber. You all know what are the different parts. So rostrum is there, genu is there, trunk is there, and splenium is there. Definitely this is septum pallidum. C, S, F is your mnemonic. This is the fornix. Agree, sir. Now look here. This is your very, very important question. Fornix. Yes, NEET PG 2023. Any kind of the question related with it. Try to understand. It is having the two part, posterior column, uniting, making the body, and then it is dividing into the anterior column. So simple. Yes, there is a posterior column. Yes, sir. Then it is uniting and making the body, and then it is dividing and making the anterior column. Agree, everybody? Yes. Now look, what is the importance? Sir, here is the seahorse-like structure, hippocampus. On histology, you will see it is seahorse in structure. Remember, this hippocampus is important because this is the structure where Sanjay Singhania got lesion and he forgotten to the Kalpana. Who killed? Yes, Gajni. Short-term memory loss. No excuse. Hollywood, Bollywood, Tollywood, all depends on the anatomy. Yes, hence proved. So you can remember this question. Yes, what I want to tell you, don't forget hippocampus. It is the site where short-term memory is converted into the long-term memory. If there is a damage in the hippocampus, yes, Sanjay Singhania will born. Okay, fine. Now, try to understand. Yes, Kalpita, you are right. Middle cerebral artery is not the part of the circle of Willis. You are right. Now, look here. this our fornix is carrying impulse. Yes, it is carrying impulse from the our hippocampus to the breast like elevation, mammillary body. So this question had been asked many times. Remember what the fornix is doing. Remember, fornix carry impulse from the hippocampus to the mammillary body. So you all know this is our center. Any impulse is coming to the center, so this is afferent, and any impulse is going to the away, so that is efferent. So this question had been asked many times. Remember which is afferent for the fornix? Sir, hippocampus is afferent for the fornix. I want to tell you 2017, 18, 19, 20, 21, 22 continuous. The fornix or related questions are asked. Okay. So no excuse. Again another question from the NEET PG 2023. Yes, who is efferent? Answer is mammillary body is efferent. Agree? If you are considering the fornix as the center then. Okay. Now look here. See here, this fornix is real rowdy rathor. Why? Because it is carrying the impulse from one part of the brain to the same hemisphere. Sir, it is association fiber. Yes, fornix is association fiber. But it is joining to the opposite side also, just like the corpus callosum. Sir, it is commissural fiber. And just like the tract, it is projecting the fiber from one end to the other end. So this is the projection fiber. What I want to tell you, who is the real rowdy rathor? Who is the real rowdy rathor? Answer is fornix. Definitely question is going to ask from this area. It is classical example of the association, commissural and projection. Only fiber in the brain. Don't forget. Agree? And also remember that there is the one almond-like structure which is related with the our Papage circuit. You will read this Papage circuit in physiology. Right now I am leaving. Okay. But see here, we are looking the basal nuclei. Yes, at the base of the brain. Can you see? At the base of the brain, there is a collection of the gray matter inside the CNS. Yes. So remember how you can make strong the base. You will use the ACC cement. You will use the stainless steel. So just one funny thing, your mnemonic for the basal nuclei, ACC cement and SS. A for amygdala, C for corpus stratum, C for claustrum, S for substantia nigra, S for subthalamic nucleus. Getting the point? Now, amygdala. This question, this option had been put in your INI-CET. Na? What I want to tell you, INI-CET, recent 2023. Yes, from our shairi, from our jokes, from our concepts, questions are asked. So what I want to tell you, amygdala is the center for the food and sex activity. If there is the damage in this amygdala, then there is the excessive food and sex tendency, that is Kluver-Bucy syndrome, Guyton. Getting the point? Remember, this amygdala is almond-like structure. This amygdala is almond-like structure. Getting the point? Yes, Doctor Who strange Moj Karadis. Thank you for your positive words. So what I want to tell you, yes, this amygdala is almond-like structure. It is badam-like structure in our brain. Not only the Hollywood, Bollywood and Tollywood, but even the TikTok, they are also coming from our anatomy. Yes, amygdala is almond-like structure. Again, I want to tell you your INI-CET question. 2023. So there was the option over the amygdala. Remember, this is the badam. Arj kiya hai. So just to make a fun, never forget this amygdala. Pyre toda hater bala thake jogi city golden chain diye jaben tate shomon dada kacha badam. Oh, badam dada kacha badam. Don't forget this one. This is amygdala. This is almond-like structure. Yes. Follow my Insta channel. You will get so many funny kind of the reels which are related to study. With this all you will crack. Yes, my every link is Dr. Shrikant Verma classes. You will find such kind of the interesting learning part. So remember this is, yes, thank you Shamin, thank you to all the dear students who are enjoying your positive words that enhances the energy of all of us. Yes, so please, if you're enjoying, send your any kind of the emoji, send your positive words. Thank you so much. Thank you Sanjeev, thank you Dark Knight. Okay, so enjoy, never forget this one. Now what I want to tell you, don't forget this Kluver-Bucy syndrome. Yes, now look here, the corpus stratum. Corpus stratum, break the name. Corpus means body, striation means threads. So there are the certain structure which are having the thread-like appearance. Yes, there is a caudate nucleus, there is a lentiform nucleus in the brain. So can you see? This is our caudate nucleus. Why the caudate nucleus? Sir, it is having the very long tail. So this is the caudate nucleus. What are the different parts of the caudate nucleus? Sir, there is the head, there is the body, and there is the tail. So these are the different parts. Yes, thank you, Akshu, thank you, Osama, thank you, Raman, yes, Hussain, Rocky Bhai, thank you, Rocky Bhai, yes, Praveen, thank you, yes, Neeraj, थैंक यू आदित्य यस मजा आ गया मुझको भी बहुत मजा आ रहा आप सभी लोगों के साथ सो वेरी इंटरेस्टिंग यस प्रवीण तन्मय भट्ट क्रिएट्स कमिंग सून okay fine okay so react whatever your emojis yes please send so thank you very much everybody so hope you all are enjoying so can you see the caudate nucleus head and then body and then tail can you see at the apex of the tail this पैर थोड़ा हाथेर वाला थाके जो कि सिटी गोल्डन चेन दिए जॉवेन इज लोकेटेड एमागडेला इज लोकेटेड एंड विद इन द कॉन्केविटी यू कैन सी द थैलेमस एग्री बेटा फाइन नाउ सी हियर yes babita sure beta sure yes thank you Shriram thank you beta thank you yes Arifa thank you so amazing points so amazing comments from you all the students yes Dr. Bharti Chopra thank you beta your all these statements you are enjoying you are getting interest so this is great pleasure for me okay so we all the teachers are really very happy this is the real prize the day when your result comes that is the biggest day biggest festival biggest day more bigger than the Diwali more bigger than the Holi Eid this all the best festival day when your selection is there okay so thank you yes thank you Rocky Bhai my one student was there who was having this name Rocky Bhai so I am recalling him okay so thank you so okay fine now this is our caudate nucleus can you see this another nucleus it is having the yes lens shaped nucleus that's why lentiform nucleus it is having the two different parts can you see what are the different two parts yes medial part is our globus pallidus and lateral part is putamen you know Spider-Man you know yes this question had been asked Aquaman Batman Iron Man forget everyone remember this putamen yes putamen तूने चुराया मेरे दिल का चैन don't forget this putamen is lateral structure globus pallidus is medial structure remember if there is the damage in this lentiform nucleus then there is the lenticular degeneration disease can you tell me what is the name sir this is our hepatolenticular degeneration that is our yes Wilson's disease I want to tell you sun creates problem sun will create the problem getting the point sun will create the problem fine so what I want to tell you Wilson's disease is important so you are looking that sir corpus stratum is important yes it is involved that's why in Wilson's disease you will see Parkinsonism disease like a clinical feature medicine integration patho integration why in the Wilson's disease when there is the involvement of the ATP B7 chromosome number 13 is involved there is an abnormal copper accumulation in the lentiform nucleus and it is getting degenerated that's why in Parkinsonism you are getting the in Wilson's disease you are getting the Parkinsonism because lentiform nucleus is the part of the corpus stratum agree yes it is the yes Harmesh in a team of legend cerebellum you have arrived like Surya Kumar Yadav yes SKY yes thank you for your so nice word I am very happy for your positive things okay we will do more such kind of the session okay so I am also enjoying with you all so yes come to here what I want to tell you beta don't forget the Parkinsonism don't forget the Wilson disease don't forget the any kind of the tremor any kind of the projectile movement abnormal movement one question sure please focus yes this question may be related to the anatomy or the physiology or the medicine but anything okay fine now try to understand yes substantia nigra we had seen subthalamic nucleus it is very important what I want to tell you substantia nigra then Parkinsonism disease subthalamic nucleus then definitely you will get the hemibellismus agree beta yes so we are going to yes Naveen thank you beta thank you oh Rajiv thank you so much you are saying Rajnikant to me yes this is Kant effect I am not Rajnikant but I am Shrikant so that Kant effect from the Rajnikant it came to me so thank you so much for your positive words Yes, yes, Rocky bhai, 7B, ATPB7 gene, chromosome number 13. Hemibellismus. Yes, Rishikesh, you are right, beta. Okay, fine. Now come to this cadaveric image. Then we are going to see the cadaveric image and radiology integration. Agree? Yes, we will do this radiology integration. Try to catch this point. See here. Brain section, coronal section. This is the brain. You're cutting. So when you're cutting, can you see? Gray matter. Yes. Easy. Take it easy. White matter. Can you see? The white matter band. Yes, sir. The white matter band. It is connecting. Yes. The white matter band. It is connecting the right and left side. So this is our, yes, corpus callosum. I told you just below the corpus callosum there is a septa in between the two ventricle. Yes, sir. It is our septum pellucidum. And just below the septum pellucidum, whatever the structure, I told you, the right and left posterior limb, they are coming and they are fusing together. Yes. So this two limb, they will give the figure of 8. Figure of 8, clavicle fracture. Yes. So you can see the figure of 8 like appearance. So this is our fornix. Always remember, I told you the way, the CSF. Okay. Now try to understand. At the midline, there is the one cavity beta. Yes. At the midline, you will see the cavity. So this cavity is our third ventricle. This third ventricle is very helpful for the radiologist. How? See here. Again, same thing. You can see the gray matter, white matter. Corpus callosum in this section not visible. You know, in the MRI, the ventricles, they are having the fluid. So this is our lateral ventricle. So this thin septa is septum pellucidum, and whatever the belowmost structure, that will be the fornix. Corpus callosum is not visible properly. So at the midline, you can see there is a one cavity, sir. This is our third ventricle. Getting the point? Yes, sir. It is our third ventricle. Remember, this third ventricle is midline structure. It is friend for the radiologist. When you will do radiology, you will walk with the textbook of the anatomy in your radiology department. Without anatomy, your radiology is not possible. Yes, what I want to tell you, if there is your brain tumor at this site, yes, sir, it will push the third ventricle on the opposite side. The third ventricle, it decides the midline of the brain. If there is the brain tumor, if there is the brain swelling, if there is the brain abscess, it will push the third ventricle to the opposite side. If you are observing that third ventricle is pushed over this side, then you will say, sir, there is any kind of the abscess, mass, tumor, swelling on this side, which is pushing the third ventricle on the opposite side. Agree, beta? Yes, this knowledge is not important for the anatomy, but it is very useful for the radiology purpose. Now, try to catch more points. Okay, sir. You know, the third ventricle, it is the cavity of the diencephalon. Yes, it is the cavity of the diencephalon. Yes. What I want to tell you, it is the cavity of the diencephalon. On each side of the diencephalon, yes, there is a thalamus. Yes, sir. There is a thalamus. So this is our, remember, thalamus. Thalamus is the sensory gateway. Remember, every kind of the sensation, every sensation passes through the thalamus. The cavity between the two thalamus, the cavity of the diencephalon, third ventricle. No excuse. Agree, everybody? Yes. Thank you, Rocky bhai. Thank you. So now try to understand. This is our thalamus on each side. Okay. Now, if there is a damage in the thalamus, there is a sensations are getting changed. Change in the sensation is known as the paresthesia. Yes. There is our thalamic syndrome. Fine. Now try to understand. You will be able to see at the floor of the third ventricle. This is our caudate nucleus head. Agree? Yes. Can you see this fold of the gray matter? It is going inside. Yes, sir. It is our, remember, it is our inside sleeping brain part, insula. Yes, sir. It is sleeping inside. So insula, we are saying the insula, it is sleeping inside. Fine. So what I want to tell you, this is also known as hidden lobe of the brain. Remember, it is also considered as fifth lobe of brain. Getting the point? And one more thing which is considered as the sixth lobe of the brain. Remember, it is our limbic lobe. So we are looking very interesting point. Yes, we had seen the 0 pair cranial nerve, 13th pair cranial nerve, 14th pair cranial nerve. Yes, we are looking the 5th lobe of the brain, 6th lobe of the brain, when the two students are meeting together and one is saying, yes, I have very too much knowledge, chal discussion karte hain. And then yes, show whenever anybody is doing show off, then tell them this dialogue, chal discussion karte hain. Our discussion will start from the 6th lobe of the brain. Sir, frontal lobe, parietal lobe, temporal lobe, occipital lobe. No, our question will start from the 6th lobe of the brain. You are doing the show off. Now see the knowledge. Yes, knowledge is unlimited. We have to share. Never show off. Okay. Yes, 5th lobe of the brain. Yes, 0 pair cranial nerve, 13th pair cranial nerve, 14th pair cranial nerve. I will tell you the 0 ventricle of the brain. 0 ventricle of the brain. Within the olfactory bulb, there is the rhinoceal cavity. Sometimes 0 ventricle of the brain. Yes, 5th ventricle of the brain. Sometimes within the septum pellucidum, there is a cavity which is known as the 5th ventricle of the brain. 6th ventricle of the brain, cavam vargi. Yes, there is a 6th ventricle of the brain also. And tell him, if anyone is giving the show off, then just do the discussion with this all the point and tell him, beta, जहां तुम्हारी एनाटॉमी खत्म होती है वहां हमारी शुरू होती है. Okay, so just share the knowledge, be humble, but if anybody is doing the show off, then give him this dialogue. Okay, so enjoy the anatomy. Yes, knowledge is to enjoy and to the share. Agree everybody? So hope you all are enjoying. Okay, so thank you very much. We are going to, yes, Deserine syndrome. Yes, you are right. Thalamic pain syndrome. Everybody. Yes, Dr. Rakiva, you are right, beta. Yes. Now see here. Can you see? This is the bulb-like part. Yes, it is bulb means medulla. And can you see above the medulla? Pons. And you can see definitely it will be our midbrain. Can you tell me the structure which is pigmented? Yes, it is substance which is negro. Yes, sir, it is substantia nigra. You know, if there is a damage in this substantia nigra, there will be the resting tremor. What I want to tell you? Resting tremor. But if there is a damage to the cerebellum, there is an intentional tremor. When you are, yes, suppose this is the glass. Okay, I am not having the tremor, but when I am holding the glass, then there is a tremor. So when I am doing any job, then there is a tremor. This is the intentional tremor. Remember, it is related. It is related with our, yes, you all are aware, cerebellum. Fine. Now look here. Again, another. Yes, but thank you so much, Kalpita. Okay, so we all are friends, we all are the student, everybody. Yes, I'm getting the knowledge from my HOD sirs, my department, okay, my seniors, my friends, my all the other parallel institutes friends. So yes, other subjects friends, we are sharing the knowledge and we are passing that knowledge to you. Okay, we all are also the students. Okay, so we are just passing the knowledge. That's why the first slide, Einstein. I had shown you that creativity is contagious. Pass it on. Knowledge है, ज्ञान है, हमको इसको share करना है. किसी का knowledge ज़्यादा नहीं, किसी का knowledge कम नहीं है. Yes, we all are the students. We are passing this all the things. Thank you. Okay, thank you. Midazolam, thank you, beta. Thank you. Thank you for your words. So nice for all of you. Thank you, everybody. Okay. So continue. Okay. Really, I'm very thankful, and also I'm very thankful for this Cerebellar Academy, Dr. Garg sir, Amit, our Vivek Jain sir, all the Apur Mehra sir. Yes, I'm really so proud. Everybody, Praveen Tripathi sir, yes, Sparsh Gupta sir, every team member. I cannot say all the name, and also to all the other institutes. Actually, my history is that I had taught in each and every institute. Whenever there is a demand, or sometimes there is the not too much hodgepodge between the schedules, so I am having all the experience. Yes, you all are right. I'm Surya Kumar Yadav, because I am coming in front of you after many time. But actual thing is that I am teaching since 2009, and for the PG student at the national level, I am teaching since 2016. So I am having all the my teachers, all the my friends, all the institutes there, they are loving and supporting me. And this time Cerebellum given the beautiful platform to me. So I am deeply humble for each and every teacher and faculty in this Cerebellum team. Thank you very much, and I'm really, you all are my lovely students. So I will do my best, 1000% best for you all the dear students. Thank you very much. Okay, fine. So these emotional things we will do more later. Come to here. Okay, use common sense. Rahat Indori Sahab. Yes, they will show arrow at any point. What you have to remember? वो दिखाता है मगर देखने का नहीं. ये नीट पीजी एग्जाम है. Yes, इधर आने का नहीं. So what you have to remember? Look at any silly point first. Look at the option. Then think carefully. Sir, this is your yes. See here, this is your oval shape. Getting the point? So when this oval shape, when you're looking from the above, so definitely it is transverse section. Agree beta? Okay, sir. Now try to catch this point. See here, definitely this is our gray matter, silly point. Okay, sir. Definitely it is white matter, whitish appearance. Agree? Now, can you see this band of the white matter? It is connecting the right and left side. Yes, sir. So definitely it is our C. C for corpus callosum. Can you see the septa? Yes, sir. This septa is our septum pellucidum. And just below the septum pellucidum, can you see the figure of 8, clavicle fracture? Yes, sir. Such kind of the appearance. This very small structure is definitely fornix. Our concept is clear. I am giving mnemonic to give the reflex answer. C for corpus callosum, S for septum pellucidum, F for fornix. Agree beta, everybody? Fine. So this is the CSF. Now see, this septum pellucidum is separating the lateral ventricle. Yes, sir. Septa, which is lucid. Septum lucidum. And you can see there is our caudate nucleus. Yes, sir, there is a caudate nucleus, which is making floor of the lateral ventricle. Can you tell me this thin cavity? Yes, sir. The thin cavity which is located at the midline. Sir, it is our third ventricle. Sir, third ventricle is the cavity between the two thalamus. Yes, there are the two thalamus. So this is diencephalon. It is the cavity between our two thalamus or diencephalon cavity. Agree, sir. Now look, very beautiful. The white matter band which is boomerang shaped. Getting the point? Yes. So try to understand. We are looking for this all the point. Yes. Praveen sir given the modafinil to me, so that energy has been transferred. Thank you, beta. Thank you, Nandu. Thank you. Yes, Osama Sheikh, Shrikant sir, we like dil mein aata hu par samajh mein nahi. Yes, thank you for your comment. Yes, beta. Yes, Navi. Integration. Actually, there are the no 19 subject. There is a one single subject, that is the medical science. Yes, this all the different subjects, they are the part, but only one science, medical science, and we have to treat the patient. Yes, okay. So fine. Now try to understand. We are looking for this boomerang shaped structure. This is our inside capsule, internal capsule, which is having the anterior limb, genu, posterior limb. Sir, there is our anterior limb, there is a genu, there is the posterior limb. Now look here, there is our, try to understand, lens shaped nucleus. Yes. This is our lens shaped nucleus. Agree everybody? Fine. So look here, there is again two different density. Medial part, I told you, sir, medial part is globus pallidus and lateral part is putamen. Do you know? Putamen. तूने चुराया मेरे दिल का चैन. Yes, superhero. Putamen is the superhero, just like the Spider-Man, Aquaman, Iron Man. And superheroes, they are outside the city. Yes, this is the question from the NEET PG. Which is the lateral part, globus pallidus or putamen? Answer is putamen. Heroes, superheroes, they are outside. Don't forget this, our beautiful concept. Now, see here. Yes, this is our hidden lobe to the brain. Agree, beta? So, this is our, insula. It is sleeping inside. It is hidden lobe of the brain. It is the fifth lobe of the brain. Now, you can see there is one saucer-shaped mass of the gray matter. Clear cut, you can see. Sir, this is our claustrum. Getting the point, sir? This is our claustrum. I for insula, C for claustrum. Getting the point? Now, when you are looking inside, then you can observe another thin band of the white matter. This is outside capsule, external capsule. Yes, this is the concept. But now I am telling you the trick and mnemonic also. Yes, ECI. You know the Medical Council of India? Yes, sir. There is MCI. But here we are talking about the Engineering Council of India. Remember, there is no such kind of the council. We are creating. Okay. So just remember ECI. Yes, sir. There is the E and then there is the C. Yes, sir. There is the E and then there is the C. E, then claustrum and then insula. Getting the point? ECI is there. Engineering Council of India. Tell me, E for yes, external capsule. C for yes, claustrum, and I for remember insula. Don't forget it. Yes, on the basis of it, you will do the question. Yes, Samira, see here, beta. Lens shaped. It is lentiform nucleus near about the lens shaped. Can you see? Agree? Yes, lens is in such kind of the shape. Agree, beta? Samira, hope you are getting the point. So this is the lens-shaped nucleus, lentiform nucleus. Copper accumulation is occurring here. Yes, sir. Copper accumulation is here. That's why there is the Wilson's disease, hepatolenticular degeneration. Agree? Now see, this is lentiform nucleus. Can you tell me what should be the name of this part? This is behind. Behind means retro. So this is the retrolentiform part. Yes, this part of the intercapsule, this is behind the lentiform nucleus. That's why it is retrolentiform part. One more part is there which is below the lentiform nucleus. I cannot show in this image, showing with the dotted diagram. So this is sublentiform part. Agree everybody? Fine? Getting the point? Yes. So Aditya is saying energy खुद शर्मिंदा हो जाएगी. Okay, so thank you. Yes, definitely. जब तुम हो और हम हैं तो सारी दुनिया शर्मिंदा हो जाएगी. Yes, definitely we will study with the so much energy, with the so much concept that every time we will get energy. Yes, can you feel we are learning from the 6 p.m. and there is no down in the energy because yes, तुम ही तुम हो तो क्या तुम हो, हम ही हम हैं तो क्या हम हैं. टीचर बिना स्टूडेंट नहीं और स्टूडेंट बिना टीचर नहीं. So enjoy this moment. Yes. What are the 5 parts of the internal capsule? Anterior limb, genu, posterior limb, behind the lentiform nucleus, so retrolentiform part, below the lentiform nucleus, that's why sublentiform part. Agree everybody? Yes, Naveen, thank you for this beautiful title, Dr. 360 degrees. So thank you so much. I'm really very blessed kind of the teacher. So you all the amazing students, this beautiful platform, Cerebellum. Yes, so we are going to look for the more things. Okay, now compare the same thing with the radiology. Yes, sir. We had seen this all the point. We had seen the gray matter, white matter. Yes, lateral ventricle we had observed. Radiology integration, septum pellucidum, fornix. Yes, third ventricle. So on each side of the third ventricle, can you tell me the answer? Sir, this is our thalamus. Getting the point? Yes, it is our diencephalon area. Agree? Now, can you see here? This is our floor of the lateral ventricle. Yes, sir. So this is our lateral ventricle whitish area, radiology integration. So this is your, yes, caudate nucleus head. Agree everybody? Now look, sir, where is the lens shaped shadow? Can you see this is, do imagination beta? Yes, do imagination. Yes, sir, it is lens shaped part, which is showing the 2 different kind of the density. Can you see the medial part and the lateral part? Yes, the medial part is our globus pallidus and lateral part is our putamen. And the area, yes, beautiful. You can observe the radiology integration. This is the zone of the our internal capsule. Agree beta? Yes, this is our zone of the internal capsule. Fine. I am using the different colors so that you can understand. Yes, sir, this is our internal capsule. Fine. Now, look here. Other parts are not properly visible, but you can say, sir, this is the hidden lobe of the brain, which is insula. Agree? Yes. So here is a question from the Kalpita. Yes, Kalpita, we are going to look for the extreme capsule. Very good question. Can you see? I am hiding this all. Yes, sir. There is our E, external capsule, then C and I. But can you see in between the insula and the claustrum, there is the one another white matter band. Yes. This is the zone of the extreme capsule. No question had been asked. That's why we had left. Our mnemonic will also altered due to it. So remember the ECI, external capsule, then claustrum and then insula. Otherwise, you can remember the ECEI, external capsule, claustrum, then extreme capsule. Extreme capsule is too much outside, and then definitely your insula. Agree, beta? So now we are, hope Kalpita, you got the point, okay? Yes. Fine. See here, beta, जो artery जिधर पास में रहेगी उसको supply करेगी. Circle of Willis is here. So can you tell me? Just apply the knowledge, sir. I'm little bit doing little detail because you are asking, na. Okay. Otherwise, it is bulletin, not me. I was not supposed to deal, but you are asking, sir. Here is the location of the circle of Willis. So enterally there is the entry cerebral artery. It will supply the entry limb. Yes, middle cerebral artery is supplying the middle part. So it will supply the entry limb part or also, remember middle cerebral artery. It is having the one branch which is most commonly ruptured. Charcot's artery, and entry cerebral artery, it is giving the one branch that is also known as the Huberner artery. Getting the point? And there is our posterior side, posterior cerebral artery. It is close to our posterior limb and our this part. Yes, remember middle cerebral artery is the main supply of the posterior limb. Charcot's artery is supplying this posterior limb. Most common part which is affected in our infarction, posterior limb of the internal capsule, which is supplied to the middle cerebral artery. Fine. So that's why Charcot's artery is most commonly involved. That's why. So remember this point. I just one your point. Okay. So these are the different points. Okay. So now we are going to start our upper limb portion. Just my pencil is having the less energy. Okay. So my pencil is having the 5% energy. So just you can take a little break. Then we are going to continue. Fine. Any doubt, beta? Please ask. Okay, hope you all are ready to continue with me. Fine. So now we are going to start our orthopedics integration. I have to charge my pencil. You can take a little rest. Okay. Then we are going to start the orthopedics integration. Oh, yes. Thank you, Raki bhai, for your. My one student, Piyush Agrawal, he was having the collar tune, Salam Rocky Bhai. So that's why I'm just. Can we take the few minutes break? Okay, just take a rest. Fine. Yes. So in between this all we can do few funny thing. You will like the shairi, or you will like, or any kind of the motivational thing, whatever. Okay. So remember few motivational lines from the Hindi. Maybe it may be a little bit difficult, but remember there is one beautiful lines from our Lord Shri Krishna to all the society from the Rashmirati Dinkarji. Yes, remember, मानव जब जोर लगाता है पत्थर पानी बन जाता है. When we do lots of effort, then in that situation definitely we can liquefy everything. Every problem is having the solution when we are doing attempt. Remember, मानव जब जोर लगाता है पत्थर पानी बन जाता है. यह देख गगन मुझ में लय है, यह देख पवन मुझ में लय है, मुझ में विलीन जनकार सकल लय है, मुझ में संसार सकल अमृत डोलता है, मुझ में संहार झूलता है, मुझ में उदयाचल मेरा दीप्त भाल भूमंडल वक्षस्थ विशाल. These are the beautiful lines in Hindi told by Lord Shri Krishna in Hastinapur. Okay, so whenever you are getting the demotivation, just listen this beautiful lines. You will get the too much energy. Okay, मानव जब जोर लगाता है पत्थर पानी बन जाता है. Lots of the lines, but yes, these are the beautiful lines. Fine. So thank you very much. Yes, thank you for your love and respect. I also love you to all the dear students. Okay. Yes, Prashant. Shukriya for your वाह. Yes, always the motivation is not good thing. So just listen. शायरी सुना रहा हूँ, जरा गौर से सुनना. Yes, शायरी सुना रहा हूँ, जरा गौर से सुनना. मुझे शायरी नहीं आती, किसी और से सुनना. Okay, so just one. Yes, Prashant, this was the one joke which I always use in our live classes. Fine. Okay, so you are saying about the one joke, so I am telling you one joke related with this our table of the upper limb. Okay, so we will do one funny trick. Okay, see here, hybrid muscle. I am telling you one joke, hybrid muscle or composite muscle. Fine. What is the mnemonic for the hybrid muscle? Yes, any muscle which is having the double nerve supply, that is known as the hybrid muscle. Agree, beta? Fine. So what you have to remember that this is our hybrid muscle which is having the double nerve supply. Different muscles are having the double nerve supply. Yes, brachialis, subscapularis, pectoralis major and minor, flexor digitorum profundus, and flexor pollicis brevis. You can see all the nerve supply, this all. One funny mnemonic, BSP. You can do Bahujan Samaj Party. It was joined by whom? Yes, FF, Fufa. So our great Fufa ji, you know, we all are having the Bua and the Fufa. Yes, Fufa ji. So Fufa ji joined the our, yes, which party? Bahujan Samaj Party. I think Mayawati is there. So B for brachialis, S for subscapularis, P for pectoralis major as well as pectoralis minor, F for, yes, flexor digitorum profundus and flexor digitorum brevis. So now I am telling you the joke. Okay, so try to understand. There was the one college. Okay, sir, there was the one college. Okay, there was the one batch, and there was the one nickname. You know, all the students, they are putting the nickname, any kind of, like the Hathi or the Lal Badshah or the Pugga, Golu, Bablu. So one girl was having the nickname kept by the batchmate, and her name was the Bua. What is the name? Bua. So she was very sad. One time she complained to the dean, sir. Sir, every student in my classroom, they are saying me Bua, Bua, Bua. Now dean, sir, he was laughing first, but then he told, no, it is very bad thing. It is not good in my college. So he went to the classroom and he told, all the students who are saying Bua to her, stand up. All the students stood. But one student was sitting. Getting the point? One student was sitting. So what you have to remember? Yes, at that time, dean forgotten. He forgot why he came. He asked one question. Hey, you. Yes, sir. You are not saying Bua to her? No, sir. I never say. Why? He told. Because I am Pupa of this class. Okay? I don't know you are getting the point or not. Yes, but I want to tell you Pupa. Yes, FF. So our funny mnemonic. Yes. What you can remember? Bahujan Samaj Party joined by Pupa. Okay, so yes, remember, ट्रिक और निमोनिक बकवास होने चाहिए. अच्छी ट्रिक और निमोनिक रहेंगे तो भूल जाओगे. If you are creating the very bad kind, dirty kind of the mnemonic, funny mnemonic, which is having no sense, you will retain it. Okay, so yes, what are the different our hybrid muscles? Remember, Bahujan Samaj Party Pupa. Yes, tell me, what is the B? B for brachialis. It is having the double nerve supply. You can remember the mnemonic Mr. Brachialis. M for, sir, musculocutaneous nerve. R for, you can remember, sir, radial nerve. Yes, subscapularis muscle, double nerve supply. Sir, subscapular nerve, upper subscapular nerve, lower subscapular nerve. Sir, there is a pectoralis major and pectoralis minor. No need to mug up. Sir, these are supplied by the pectoral nerve. Sir, there is a lateral pectoral nerve, there is a medial pectoral nerve. Yes, flexor digitorum profundus, it is having the dual nerve supply. The lateral half is supplied by the median nerve, but the better answer is anterior interosseous nerve, and the medial half is supplied by the ulnar nerve. No excuse. And then there is a flexor pollicis brevis. Yes, it is having the superficial head, it is having the deep head. Superficial head is supplied by the median nerve and deep head is supplied by the ulnar nerve. So what I want to tell you, whenever you are looking your pupa, yes, recall this mnemonic and you will crack the many MCQs. Yes, when we will meet. Yes, one more thing. If you all are enjoying, this is the just little one break time. Okay, when we will meet, I will tell you the very good kind of the story, the medical gatha. You know, there is the one very hit movie, Mughal-e-Azam. So there was the one great movie. So on that basis, we perform the great. This is the little break now, so that you can get relaxed. Okay. So what I want to tell you, there is the one very famous kind of the movie. Fine. This Mughal-e-Azam. So I will tell you the story, the medical-e-Azam. Try to understand. If there is a medical college and there is our Shahanshah Akbar. Who will be the Shahanshah Akbar? Yes, the HOD. This is the break time. I am just entertaining to all of you so that you can get relaxation of the brain. So what I want to tell you, yes, there is our HOD of the medical college, orthopedics department. Yes, our Shahanshah Akbar, Muhammad Jalaluddin Akbar will be the dean of the medical college. And who will be the beautiful queen of this our medical Azam. So remember that beautiful king will be from the Ops Gynae department, Maharani Jodhabai HOD. And who will be the Shahzada Salim? Remember, Bigdi Hui Aulad. Yes, Bigdi Hui Aulad, who is not able to perform properly in MBBS, who is getting fail, who is getting the too many kind of the unsuccess in Jange PMT, Jange NEET UG, and then he is going for the Kota ke Tapte Registan. LN है तो मुमकिन है, something like that. So he's going for preparation of the NEET UG exam to the Kota, Rajasthan, Jange PMT, Jange NEET UG preparation, and then he is anyhow cracking the NEET UG, then MBBS, then also MD medicine, and then he is doing the DM cardiology and coming back to the our मुगल सल्तनत की सबसे बड़ी ओपीडी, मुगल सल्तनत की सबसे बड़ी ओपीडी में हमारी एंट्री होती है डीएम कार्डियोलॉजिस्ट की. एंड हियर ही गिव्स हिज हार्ट यस टू द अदना कनीज पैरामेडिको हु अनारकली. So this is the beautiful story. When we will meet together, I will tell you this beautiful story. Yes, this drama we perform at our Pulse Amps. Okay, so there are lots of the fun in our NEET PG preparation, in our medical science. Yes, there are the too much stress, but yes, there is a too much fun also. So hope you all seen. Okay. So we are coming. Fine. Okay. I don't need Osama. Thank you for your care. I think you are the same Osama from the Hyderabad, and who is always wishing the new year just exactly after 12 a.m. Okay, Osama, you are right. Okay, fine. Hope you are right. I think you are same Hyderabad student. Okay, so let's start our another session after this small break. And yes, drink the water in the copper bottle. Okay, yes. If you are taking excessive copper, yes, copper, then Wilson's disease. बड़ा है तो बेहतर है. Okay. Always drink the water in the copper pot. Okay, so copper is very good. Ceruloplasmin, this all the things. Okay, fine. So can we continue? Fine. So tell me, a 37-year-old patient met with the road traffic accident. Okay, sir. Due to the overspeed of the bike, yes, presented with the multiple fracture of the humerus. Okay, sir. Humerus fracture. He experienced that he lost his sensation over the lateral side of the forearm. Yes, lateral side of the forearm. This is the clue. Difficulty in flexion of the elbow. So this is the very, very good question. Flexion of the elbow means brachialis and biceps has been lost. Okay. Weakness of the supination. Who is the supinator? Remember, biceps is the powerful supinator. Sir, biceps has gone now. Okay, so which nerve is most commonly injured? Sir, if there is a shaft injury, radial nerve is answer. But all the clue they are saying about the biceps and the brachialis. And remember, the biceps, brachialis and coracobrachialis, these all are supplied by the musculocutaneous nerve. This is the NEET PG 2021 question. Agree everybody? So knowledge of that, our basic concept, general anatomy, जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है, that is created from here. Agree everybody? Fine. So hope you all are getting the point. Now see here. Yes, we are going to look for this. I told you, anatomical snub box. Showed one question. See here. Yes, drug abusing substance. They are taken at the base of the thumb and then they are rubbed and then something like that. So in our body, there is the one box-like structure. It is in our anatomy. So it is anatomical. It is used for the snuffing. That's a snuff box. Fine. Here, various important things. Scaphoid is making the floor. Scaphoid fracture. Orthopedic integration. Second most common bone which is getting avascular necrosis. Scaphoid. Orthopedics. That's why one question from the anatomical snuff box. Either related with the orthopedics. Agree? Scaphoid fracture, yes. Glass holding position, glass holding position. This is the question. This is the question from the FMG exam. Glass holding position for the scaphoid fracture. Definitely scaphoid fracture or anatomical snub box is going to ask. Now see here, I will show you the Finkelstein test. Do you remember? Thumb inside and here and then. This is the pain. This is the question from the INICET. The dequervant tenosynovitis or Finkelstein test. Definitely the question from the anatomical snub box or its clinical point is going to ask. In that dequervant tenosynovitis, there is the involvement of the anatomical snub box tendon. we had seen all the 10-20 question, many topics with related with the other subject. Okay, and this topic is again going to ask in your NEET PG 2023. Try to understand. There is a cephalic vein, and cephalic vein can be used for the intravenous injection. In our ward, we are doing the intravenous injection here. Yes, cephalic vein, clinical point. So anatomical snub box is important. Yes, here is the radial nerve, which is compressed due to the tight wristwatch. Yes, cheralgia, paresthesia, tight wristwatch neuropathy. Sure, another one more clinical with the anatomical snub box. You know, the meralgia, paresthesia, but here we are talking about the cheralgia. Meralgia, cheralgia. जब कोई आता है और मेरे जिया को लेके चला जाता है, दिस इज द वैलेंटाइन वीक, यस, एनीबडी इज कमिंग एंड कैरिंग माय हार्ट अवे, सो दिस इज द मेरालेजिया पैरास्थेशिया. ओके, बट कोई आता है और मेरे चेयर को लेके चला जाता है, दिस इज द चेरालजिया पैरास्थेशिया. फनी थिंग यू कैन रिमेंबर, तो सो रिमेंबर मेरालजिया एंड द चेरालजिया. यस रॉकी भाई, यू आर राइट. Meralgia, paresthesia, compression of the lateral putrescence of the thigh on the lateral side, getting the point? While the cheralgia, paresthesia, our anatomical snub box. So I will teach you. But right now, can you tell me? Yes, lateral boundary. When you will see in anatomical position, the lateral boundary. Remember, the boundaries are आगे longest, पीछे longest, बीच में brevis. What I want to tell you, the boundaries of the anatomical snub box. Yes, anterior longest, posterior longest, between is brevis. So anterior longest is our, yes, abductor pollicis longus. Yes sir, it is making the lateral boundary also. Lateral and anterior both are same. Yes, and just behind to it there is the small muscle, between is brevis, so abductor pollicis brevis. So this is your answer. D is your answer. I will teach you, don't worry, I will teach you, fine. But remember, yes. Now we are looking a patient presented with the extension of the our metacarpophalangeal joint and the flexion of the interphalangeal joint. Which muscle is affected? Now try to understand metacarpophalangeal joint and our flexion of the interphalangeal joint. So tell me, okay, there is our extension of the metacarpophalangeal joint and flexion at the interphalangeal joint. This is nothing, this is our claw hand, you know, the pain holding position. The pain holding position is formed by, yes, this pain holding position is formed by the lumbrical. Yes, the first and second lumbrical, these are supplied by median nerve. The third and fourth lumbricals, these are supplied by ulnar nerve. Getting the point? So what you have to remember, when there is a damage to the median nerve and ulnar nerve, opposite, so there is the extension at the metacarpophalangeal and flexion at interphalangeal. So this is complete claw hand. So your answer is definitely the lumbrical muscles. Getting the point? So where is the lumbrical? Sir, here is the lumbricals. Fine. So palmar introshay and dorsal introshay, they help the lumbrical. Answer is B. Agree everybody? So question sure shot from the short intrinsic muscles of the hand. The muscle marked by the arrow in the image. Yes, tell me. We don't know. Yes, we don't know. Look for the any silly point. You can observe here. Sir, this is ear. You are looking from the back side. So this is our back part. Look at the option. Yes, when you are observing the option, then you will observe the direction. Yes, you will give the direction to your thoughts. So there is a one muscle. Can you observe? This is our, yes, scapula. Fine. This muscle will contract and it will elevate the scapula. So definitely it is our levator scapulae. Agree beta? Now can you observe here another muscle? Yes, this particular muscle is rhomboid in shape, kaju katli in shape. So this is our rhomboid, small, that's why minor. While this another muscle is very big. Yes sir, this another muscle is very big. So you will say, sir, this is our rhomboid major. Correct? Sir, this is our rhomboid major. Fine. Getting the point? So remember, these all muscles are at the dorsum. Yes, sir, it is our dorsum. It is attached to the scapula. So scapular nerve. So simple. It is supplied by the dorsal scapular nerve. Getting the point? Agree? NEET PG 2020, I told you one nerve will be surely asked. Yes, one nerve is there which is running over the dorsal part of the scapula. Now look here, nerve supply the marked area by the arrow. NEET PG 2019. So there was the question, dermatome. One question sure from the dermatome, any part, or its knowledge will be useful for your, yes, clinical side. See here, this is the dorsal side. At the dorsal side, remember, from the anatomical snub box, the radial nerve is coming. It is supplying our dorsum of the hand by giving them many branches. Agree? The many textbooks, they are saying lateral 2.5. Agree, beta? Everyone getting the point? While here is our ulnar nerve is coming, so ulnar nerve is very close. So ulnar nerve will supply. So remember, medial 2.5 supplied by ulnar nerve, and here is our radial nerve. Getting the point? Fine. Few textbook like the Vishram Singh anatomy, it is saying about the our another thing, that lateral 3.5. Yes, dermatome, they are overlapping in nature. It is also correct. It is also correct. But best answer is lateral 2.5. Except our nail bed. So this 1, 2, 3.5. So these parts are supplied by our median nerve. Okay, so just one quick revision. In detail, I will teach you later. Fine. So answer is definitely your radial nerve. Remember, posterior interosseous nerve, it is the deep branch of the radial nerve. It will supply to the muscle. It will not supply the skin. Agree, everybody? Now, look for this question. NEET PG 2019. Which of the following is true regarding the dequervent tenosynovitis? Fine. I will tell you. There is an inflammation of the muscles of the anatomical snub box. Fine. So, it is involving the abductor pollicis longus and our extensor pollicis brevis. And remember, yes, fingers are held in the mid extension. So patient is not able to properly abduct. Mid extension he will do, so that he will get relief. So it is also right. It is also right. Treatment is surgery. Yes, you have to perform the surgery. Yes, most common finger is the index finger. No, it is wrong. Fine. I will teach you this all the points here. You can observe this one. Can you see? Here is our anatomical snub box part. Yes, you can observe the anatomical snub box. Fine. There is an entry boundary, there is a posterior boundary. Entry boundary, aage longus, entry longus. Which longus? Abductor pollicis longus, which will cause abduction. Fine. And posterior longus is which longus? Yes, it will cause extension, extensor pollicis longus. Anterior longus, posterior longus, between is brevis. Which brevis? Extensor pollicis brevis. So entry boundary is formed by this one, and posterior boundary is only formed by this extensor pollicis longus. Now see here. Yes, Salmon Bhoi, आज गाड़ी तेरा भाई चलाएगा. He is wearing the very loose hand wristwatch or hand the wristband. Okay, why? Because if there is the compression of the radial nerve with this wristwatch, there is the compression of the radial nerve. It is known as the chiralgia paresthesia. It is known as a tight wristwatch pathy. Tight wristwatch abnormality. Okay. Now see here. That's why you can remember this image. Okay. Now what I want to tell you, if there is the inflammation of this muscles of the anatomical snub box, then it is known as dequervent tenosynovitis. It is INICT NEET PG exam. So for it, what you do, this is the test. It is our, yes, Finkelstein test, orthopedics. So just do with me. Close the thumb in this way and do abduction. So you are getting the pain at this part. Yes, you are getting the pain at the anatomical snub box part. We are normal. But if there is the inflammation of the anatomical snub box tendon, so he will feel too much pain. Agree, everybody? So this is our Finkelstein test. Fine. So remember these points so you can recall. Now look here. Further. Next. What is the function of the muscle marked in the image below at the metacarpophalangeal joint? So tell me. See here. The tendon is coming. Yes, sir. You can observe. Look at this point. Cadaveric image. First thing, thumb is here. So, sir, it is lateral. Fine. And nails are not visible. So, this is our ventral surface. You are looking from the palm side. Why? Because nails are at the dorsum. You are not able to see the nails. Now, can you see this particular tendon is coming from the front and going to the thumb. What is the name? Sir, it is responsible for the decrease in angle. That's why flexor. Yes, it is going to the thumb. That's why you will say pollicis, and it will go to the distal part. That's why definitely it is our longus. Yes, look here. There is the one muscle and one more muscle. Can you see this muscle is above while this another muscle is below? Agree, beta? Fine. So these are our above muscle. It is responsible for the flexion. It will flex the digits. That's a flexor digitorum. It is above. That's why superficial. But can you see another muscle which is at the D? So this is the flexor digitorum profundus. Agree? Yes. You can observe there is one muscle which is running lateral. Getting the point? Yes. It is unidirectional. Yes, sir. It is unipennate fiber. Remember, this is unipennate fiber. It is round worm-like. Yes, worm-like muscle, round worm-like structure, which is the round worm? Sir, Ascaris lumbricoid. So this particular muscle is Ascaris lumbricoid like. That's why you will say, sir, it is our lumbrical. Yes, forefinger. So there is the first lumbrical. Can you see here? Sir, second lumbrical. Then third lumbrical is taking origin from the both side. Yes, it is bipinnate. And also you will see our fourth lumbrical. What I want to tell you, sir, there is a first, there is a second, third, and fourth lumbrical. Getting the point? Yes. We will share this one better. Don't worry for it. So there are the four lumbrical. Fine. Now try to understand. These lumbricals are having the action. Which action? Yes. These lumbricals are responsible for pain holding position. Okay. This is the action of the lumbrical. You can remember by our Babaji ka Thullu position. Fine. Also, you can see this one. These muscles are taking origin from the front, flexor digitorum profundus, and then crossing the metacarpophalangeal joint from the front. So when this will contract, it will do flexion, and it is crossing the interphalangeal joint from the back. So when it will contract, it will do extension. So this is your pain holding position. What is the name? Yes, sir, it is pain holding position. Getting the point? Yes, sir, it is pain holding position. Fine. Now see here. Also, you can remember the Babaji ka Thullu position. It is the action of the lumbrical. They are responsible for the flexion at, do with me, they are responsible for the flexion at metacarpophalangeal joint and extension at interphalangeal joint. Agree everyone? Fine? Okay? Now, if there is, yes, remember, first and second lumbrical unipennate, third and fourth lumbrical bipennate. First and second lumbrical supplied by median nerve, third and fourth supplied by the ulnar nerve. If both nerves are damaged, so just do opposite of it. Here is the flexion, so do extension. Here is extension, so do flexion. Yes, it is complete claw hand, which is seen in case of the median and ulnar nerve both injury. Agree? But remember, ulnar nerve is more superficial, and PSM integration, our pharma integration, medicine integration, leprosy. In case of leprosy, there is the ulnar nerve involvement, so ulnar nerve is getting damaged. So what you will see, sir, ulnar nerve is damaged. So third and fourth lumbricals, they are involved. So there is only and only ulnar claw hand. Yes, these two are normal. So there is the ulnar claw hand. Agree? Fine. So remember, this is very, very important question. You can observe first lumbrical, you can see the second lumbrical, you can see the third lumbrical, you can see the fourth lumbrical, and these all are taking origin from the flexor digitorum profundus. Agree, beta? So these are the different points which you can remember. Yes. So these are the different things. So definitely, what you have to remember? Function of the muscle. Yes, it is lumbrical. So lumbricals, they are responsible for the metacarpophalangeal joint. What? Sir, these are responsible for the flexion at metacarpophalangeal joint. So remember, answer will be A. Agree? Fine. So these are the different points. Now we are looking for the different bones part. Images are included and the different muscles. I am telling you the three-dimensional orientation quickly. The osteology part of the upper limb. Yes. Look for the here. This is our beauty bone. Yes, sir. This is the collarbone, beauty bone, clavicle. You can see the shoulder blade, scapula. Yes, this is the funny bone, humerus, and the preaxial bone, radius, and here is the ulna. Can you see the carpal bones? Yes, you all are aware, she looks too pretty, try to catch her. Yes, scaphoid, lunate, triquetral, pisiform. Remember, this pisiform is the seed-like bone. Yes, it is the our sesamoid bone. MCQ, last bone to ossify in the carpal bone, important for the age determination, forensic medicine. Then try to catch her. Trapezium, trapezoid, capitate, hamate, and these are the phalanges. Okay, sir. Now, I am telling you the different muscles once quickly. Can you see how you have to study the upper limb? Sir, pectoral region, then axilla, shoulder region, back region. Again, pectoral region, axilla, shoulder, back, arm, forearm, hand. Simple. So, can you see, add this pectoral region, one big muscle. Yes, this is the climber's muscle. It is responsible for the climbing activity. So, this is our pectoralis major. Add the pectoral region, big muscle. Now, cut it. Can you see? Add the pectoral region, small muscle, pectoralis minor. For the cadaveric images, it will be helpful. Can you see? Any cadaveric image is given, and if any muscle is located below the clavicle, so definitely it is subclavius. And no excuse with this muscle. One muscle on the lateral part of the thorax which is having the zigzag appearance, it is serratus anterior. Yes, it is supporting the medial border of the scapula. So if there is a damage to the serratus anterior, long thoracic nerve is getting damaged, Bell's nerve is getting damaged. Nerve of Bell, yes, it is a long thoracic nerve. The medial border of the scapula will get elevation. This is known as, yes, tell me, this is our, yes, winging of scapula. Agree? Now, look here. We are looking for the our, yes, shoulder region. Can you see? Delta shape muscle, deltoid, supplied by the axillary nerve. Now, we are cutting this deltoid muscle. We are removing the trapezius. So, can you see this muscle? Yes, sir. This particular muscle is above the spine of scapula. So, this is our supraspinatus. When it will contract, it will cause abduction. Remember, it is not causing the 15 to 90 degree. Again, Gray's anatomy update for all of you. What I want to tell you, old concept 0 to 15, supraspinatus, 15 to 90, yes, deltoid, 90 to 180, your answer was the deltoid and the your trapezius. But no, now recent concept 0 to 90 degree by the serratus anterior as well, sorry, 0 to 90 degree by the by our supraspinatus plus deltoid. This is the update from the Gray's anatomy. Don't forget it. What I want to tell you, 0 to 90 degree abduction, supraspinatus plus deltoid, then 90 to 180 degree, this is same, serratus anterior plus trapezius. So this is the our supraspinatus. Can you see below the spine, infraspinatus? Can you see the rounded muscle? Yes, sir, it is a rounded muscle and it is a small muscle. It is rounded, that's why you will say teres. And it is a small, that's a minor. Can you see the teres major? It is away. It is not at the shoulder joint. So remember which muscles are not making the rotator cuff. Yes, remember there is the our scapula, there is our humerus. So these are articulating and our humerus is rotating within the our shoulder joint, within the rotator cuff, within the glenoid cavity. So these all are having the supraspinatus, infraspinatus and teres minor, not the major, and the subscapularis sits. You all are aware. So these are making the rotator cuff. Don't forget it. The teres major is not at the shoulder joint, it is away. That's why it is not included in our rotator cuff, also known as dynamic stabilizer of the shoulder joint. Don't forget it. Okay. Now try to understand our more points. Yes. Thank you. Happiness mode. Thank you for your positive words. Okay. So see here, one more muscle which is at the front. Sir, this is subscapularis. MCQ, 3 point I am telling you. Sir, it is hybrid muscle, upper subscapular, lower subscapular, one MCQ. Another, it is multipennate muscle. Middle fiber of deltoid is also multipennate. And remember, it is also considered as the forgotten muscle of the shoulder joint because it is very less injured. Which is most commonly injured in your rotator cuff syndrome? Answer is supraspinatus tear syndrome. This is the most common muscle which is injured in rotator cuff injury, while this is the least common muscle which is injured. Now look here, we are going to look for the our more muscle, back muscle. trapezoid shaped muscle, trapezius, rhomboid shaped muscle. We are dissecting it. Yes. So can you see one very big muscle, lata muscle? This is lata wide muscle at the dorsum, latissimus dorsi, supplied by the thoracodorsal nerve. Getting the point? Remember, this is also the climber muscle. Now look here. When you are looking, this is the question. This muscle will contract and it will elevate the scapula upside. So this is levator scapulae. And can you see this is our rhomboid shaped muscle which is small. So rhomboid minor. And can you see this is rhomboid shaped muscle which is very big. So it is our rhomboid major. Getting the point? Fine. So these are our different muscles. Now we are looking for the muscles of the arm. So entry compartment BBC. Everything is written in the PDF. So can you see this is the our biceps because it is having the long head and short head. Yes sir. And when you are dissecting it, then you can see the Mister brachialis. Yes. And then one more muscle which is taking origin from the coracoid process and getting insertion into the brachium. Yes, it is the scapula. Crow-beak like process, coracoid process getting attachment to the brachium. So coracobrachialis. These are the different muscles. Do you remember which nerve is flowing here? Sir, musculocutaneous nerve is flowing here. And remember, जो नदी जहां रहती है, जहां बहती है, वहां सब स्ट्रक्चर को सप्लाई करती है. इन द सिमिलर वे द नर्व ऑफ द एंट्री कंपार्टमेंट, मस्कुलोक्यूटेनियस नर्व, सो इट विल सप्लाई ऑल द मसल्स ऑफ द एंट्री कंपार्टमेंट. Hilton law is applicable. Go for our basic concept first session. Yes, the nerve supply of the biceps, brachialis, coracobrachialis, musculocutaneous nerve. Yes, it becomes cutaneous on the lateral part of the forearm, lateral cutaneous of the forearm, which had been asked in your NEET PG exam question. Okay, so remember the Mister brachialis. Yes, it is hybrid muscle. It is supplied by the Mister MR, M for musculocutaneous, R for radial nerve. Agree? So now we are. Yes, thank you, Medazolam. Okay, fine, we will do. Hope you all are enjoying. Can you you all are enjoying? Can you continue? You can continue, or we have to carry this session in another part. I can do. I am enjoying the session. I can take the class for all the time. I targeted for the 4-5 of us. Yes, you all are enjoying. I am also enjoying. So yes, I am continuing with the more and more facts which can be asked. Okay, so try to understand. We are looking on the back side. Can you see? This is one muscle which is having the 3 heads. Yes sir, long head. This is the lateral head. And when you will cut this muscle, then you will see one more head. This is the medial head. Sir, it is having the 3 heads. So this is the triceps. Complete. Now look at our forearm muscle. Okay. Yes, tunes officially. Thank you. So can you see? There are the different muscle. This is the our muscle which is taking origin from here. Okay. So just I'm telling you. This is the muscle. When it will contract, it will cause pronation. So this is the pronator teres, forearm entry compartment muscle. Okay, sir. Now look here. We are looking another muscle. Give the name. Yes, it is coming from the medial compartment, medial epicondyle. Sir, it is the flexor muscle. It is going to the carpal bone. Yes, sir. Flexor carpi. It is running towards the radius. So flexor carpi radialis. Simple. Now look here. This is the one another muscle which is reaching to the palm. Very long. Making the palmar aponeurosis. Sir, it is palm muscle, very long. Palmaris longus, very easy. Now, look here. This is the muscle which is in our entry compartment, flexor compartment. It is reaching to the digits. Sir, this is the flexor digitorum. It is above, superficialis. Yes. And then you will be able to see one more muscle. It is deep. It is reaching to the distal phalanges. Yes, it is coming from the same flexor point, ulna also, and it is reaching to the digits. Beautiful. This muscle will give origin to our lumbrical. Agree everybody? Fine. Now, try to understand further. Yes. Can you see this one? Sir, it is coming from the flexor, common flexor origin. It is going to the our carpal bone. So, flexor carpi. What you will say? Radialis or ulnaris? Sir, it is close to the ulna. So, flexor carpi ulnaris. And you can observe, it is showing the ossification of the pisiform bone. MCQ. Remember, all these muscles are on the front. Every muscle is supplied by the median nerve except flexor carpi ulnaris, because here is the river of the ulnar nerve. Remember, जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. It is close to the ulnar nerve. So flexor carpi ulnaris is supplied by the ulnar nerve. Remaining all are supplied by median nerve. Agree? Now we are looking for the deep muscles. Flexor digitorum profundus we had seen. Yes, sir. This is the flexor carpi ulnaris. Yes. Can you tell me what should be the name of this muscle? Yes, flexor digitorum profundus we had seen. Now, look for this another muscle. Proper concept you have to make. Do imagination. Whenever the cadaveric images are coming, you have to look above, you have to look down. Right, left, look at the option, give direction to your thoughts and then opt. Sir, it is the flexor compartment. Okay, sir, flexor. And it is going to the thumb. So it is the flexor pollicis. And it is reaching to the distal phalanges. That's why longus. So simple. Okay. So now try to understand. Yes, Gulshan, good evening. Hope you are same Gulshan from the Pandit Janam Medical College, Raipur. Yes, Rohan. See, yes, better. Yes, we are continuing. Okay. So my all the thanks, my all the regards, my all the love to all dear students from everywhere where I taught due to your all support. Right now I am this at beautiful platform Cerebellum. Okay. Yes, Animesh. Oh, Animesh. Okay, very good. So Animesh is here, Gulshan is here. Very nice. I miss Animesh to you. Okay, so thank you, Gulshan. My thanks and regards to the 2012 batch, Pandit Janam Medical College, Raipur. Hope, am I right? 2012 batch. If I am right, Gulshan, please give me any kind of the emojis. Okay, and Animesh is also from the same batch. Yes. Okay, Anshul is from the RIMS Medical College. Yes, Anshul is very beautiful role in my life. So thank you, Anshul, for your always the positive support. All my dear students from the Pandit Janam Medical College, Raipur, RIMS. Thank you. Also the students from the SIMS. Okay. Yes. Okay, please inform to all the students. Okay, so we are continuing. Now we are looking the back side. Yes, we are practicing for the cadaveric image. You can see all this list of the muscles, whatever I told you in detail class. I teach why the Spider-Man is doing this one, because this muscle is having the extra extensor, this muscle is having the extra extensor. So it is very easy to do this one. Yes, extensor indicis is here, extensor digiti minimi is here, so it is very easy. That's why Spider-Man is doing this kind of. Never he will do this one. There is a difficulty. And also Yo-Yo Honey Singh, he will do yes, yo, hey yo. Never he will do this one. Okay, why? Because this extension is very easy. Extensor muscle we will see. Okay. Yes. So we are going to look for the more. All the list are here. So can you tell me cadaveric images? First thing, don't take any kind of tension. Look above, down, medial, lateral. Look at the option. So can you see? This is the collarbone, sir. It is clavicle. Can you see? This is our humerus. Yes, option will tell you. So one muscle is taking origin from the clavicle, and then it is running from the sternum, and then it is going towards the humerus. Do you remember? Lady between two major, lateral major, pectoralis major, medial major, teres major, and who is the lady? Latissimus dorsi. So definitely, sir, this is the very big muscle. Yes, it is the very big muscle at the pectoral region. So pectoralis, tell me, yes, major. Agree, beta? Fine. Okay, thank you, Animesh. Thank you. Miss you all the dear students. Animesh, Gulshan, Anshul. Okay, yes. So just to see here. Again, we are cutting. Can you tell me what should be the name of this bone? Sir, this is the neck part and the shoulder part. So at this neck part, neck bone, collar bone, sir, this is our clavicle. Agree, everybody? Yes, sir, it is the clavicle. Now, can you help me? What is the name of this small muscle just below the clavicle? Sir, it is below. That's why you will say sub. Yes, below the clavicle. So you will say subclavius. Agree, everybody? Fine. Now you can see there is the one muscle at the pectoral region which is going towards the our coracoid process. Yes, crow-beak-like process. So you can observe this bony elevation. Sir, it is crow-beak. Kauwe ki chonch ki tarah. Yes. When we will meet together, yes, here is a scapula. When we will meet together, then I will show you this all the things. Can you see the scapula? In the scapula, there is a, yes, I'm carrying to the close to the camera. Yes, can you see this scapula? Fine. So there is the our magic of three, na? Scapula, superior angle, inferior angle, lateral angle. Yes, three angle, three border, superior border, medial border, lateral border, three border. Yes, three process: coracoid process, our acromion process, and spine. So this coracoid process, it had been asked in your exam. This is having the crow-beak-like appearance. कौवे की चोंच की तरह जो आपको दिखेगा वो क्या है, कोरोकॉइड प्रोसेस है. एग्री एवरीबॉडी? फाइन. सो दिस क्वेश्चन कोरोकॉइड प्रोसेस हैड बीन आस्क्ड. इट इज फाउंड जस्ट बिलो द lateral one third of the clavicle, deltopectoral groove. So this coracoid process had been asked in your exam. Agree everyone? Fine. Now, so this muscle is at the pectoral region, so you will say pectoralis, but sir it is small, so you will say minor. ब्रेक द नेम एंड गेट द आइडिया. और रिमेंबर, शेक्सपियर ने कहा है नाम में क्या रखा है, बट मिर्जा गालिब कहते हैं सारे राज नाम में दफन रहते हैं. इट इज द पेक्टोरल रीजन मसल, इट इज माइनर. व्हेन इट विल कॉन्ट्रैक्ट, इट विल पुल द कोरोकॉइड प्रोसेस ऑन द फ्रंट. यस, इट विल पुल द कोरोकॉइड प्रोसेस फ्रंट. दिस इज द प्रोट्रैक्शन ऑफ द स्कैपुला. फाइन. Now look here, this is the back side muscle. You can easily guess, sir, this is our ear. Yes sir, it is ear. So can you see there is a one muscle which is showing just rhomboid shape. When right and left will meet together, so it will create the Superman S shape. This is rhomboid shape. Yes, you all know the Superman S shape. So it is Superman S shape. Fine. That's why it is trapezoid shape. Yes, it is our what muscle? Trapezius. Getting the point? Yes, here is the one another muscle which is very wide at the back. So this is our lata muscle at the back. Lata means wide, latissimus dorsi. Now we are cutting. We had seen this image already. Sir, this is our levator scapulae. Yes sir. And here is our rhomboid minor. Correct sir. And this is our rhomboid major muscle. Agree? Fine, we had seen already. Now we are cutting. Can you see this one? Yes sir, these are our vertebral spines, and you can observe this is our iliac crest. So there is a one big muscle which is running at the back side. Sir, it is same latissimus dorsi. It is known as the climber's muscle. Can you see the climber's activity? Yes, there is the one very big muscle. Yes, you can see this is the very big muscle. When person is climbing, this muscle is running from the back, inserting here. So when it is contracting, it will do this kind of the movement. So body will get lift. So that's why it is known as, remember, it is known as climber's muscle. Yes, remember one controversial question. The best answer is latissimus dorsi because it is very big, very bulky. But second muscle, if you have to opt, you can opt the pectoris major also. Okay, because when it contract, it will also do extension. And any muscle which is extensor at the shoulder joint, yes, it is your climber's muscle. Agree everybody? Yes, we will do. Okay, yes Arifa, we will do, don't worry for that. Okay, so these are our different points. Now look here. Yes, I told you the rotator cuff. These are our different muscles. Can you see there is our spine of scapula? So below to it you will say infra because it is below. Yes, spine of scapula, that's why spinatus. Getting the point? Now can you see there is the one muscle which is rounded, that's why teres, but it is small, that's why minor. Can you see one big muscle? Yes, it is rounded, that's what teres, but it is big muscle. When you will cut, then it is appearing rounded. Right now, okay sir, quadrangular, but when you will cut, it will appear rounded. Yes, can you see this is the very long side? Yes, back side. So it is triceps. Only one muscle at the back, so definitely triceps. This is very long, so definitely you will say long head. Yes, this particular muscle is coming from the lateral side. It is our lateral head. Getting the point? Now you are looking, I told you this all the points. Fine, subscapularis muscle. I told you the rotator cuff. Remember the largest bursa of the body is the subacromial bursa. Again, I want to tell you that our Hollywood, Bollywood, Tollywood, they all depends on the anatomy. How? There is the song over this bursa. Yes, Valentine Day is there. So I'm telling you that song. There are the many songs. Yes, like मोहब्बत बरसा देना तुम के सावन आया है. Are you getting the point? Lover is saying that हमको तुमसे मोहब्बत हो गई, तुम अपना बरसा हमको दे दो. What is the barsa? Remember the small synovial pouch which has been separated from the main cavity and helping in the movement, helping in the shock absorption, that is known as the barsa. Okay, so why he is asking मोहब्बत हमको तुमसे हुई, तुम अपना बरसा दे दो. अरे बरसा दे देंगे तो मूवमेंट कैसे होगा? दिल दो. Why you are asking for the बरसा? Also there is other song like टिप टिप बरसा पानी. Are you getting? Yes, येलो कलर साड़ी, हीरोइन इज डांसिंग इन द रेन, ओके यस, बरसा से पानी बरस रहा है, पानी में आग लगा दो, शी इज सेइंग पानी ने आग लगा दी, समथिंग लाइक दैट। अरे भाई जब बरसा से पानी बरस रहा है, साइनोवियल फ्लूइड लीकेज हो रहा है, गो फॉर द ऑर्थोपेडिशियन। Why you are burning the water? I'm just making fun. So remember, whenever there is the bursa, there is the inflammation and there is a bursitis. Agree? Yes, yes, it is known as, no beta, see here, improve this one. This is known as the Dauburn. This is known as the Dauburn. Okay, what is happening? There is our bursa. If it is swollen, then it is getting compression by the acromion process. So when the patient will do abduction, this bursa will go inside, pain will be relieved, fine. Yes, there is the inflammation. So when the patient is doing this movement, bursa is slipping inside, it is locating, it is dislocating inside, pain is relieved. See here, when there is adduction, yes, shoulder adduction, there is pain because bursa is inflamed. But when the patient is doing abduction, so bursa is dislocating inside, so pressure is relieved. So remember, when there is the abduction, no pain. This is known as Dauburn test. Yes sir, it is known as the positive Dauburn sign, which is found in case of the subacromion bursitis, which is largest bursa of the body. Agree? Yes. Now see here, you can observe this muscle which is having the two heads. Yes sir, so this is our biceps. Can you see? This is our triceps. I already told you it is long head of the triceps, and you can see the lateral head of the triceps. Now look here, the cubital fossa. You all know the medial epicondyle, and here is the lateral epicondyle, and you can observe the boundaries formed by the brachioradialis and medial boundaries formed by the pronator teres muscle. What are the content? You can remember easily: M, B, B, and here is our R. Yes, this is the INICT question. M for median nerve, B for brachial artery, B for biceps tendon, and R for radial nerve. Agree everybody? Fine. Now this is the same thing. You had removed the content. Can you see? This is the our radial nerve. Yes, it is coming and it is making the superficial branch. Yes sir, this is our superficial branch. It is superficial branch. But can you see, this is the deep branch. This deep branch will pierce and it will run behind the interosseous membrane. That's why it is known as the posterior interosseous nerve. Remember, this pin, posterior interosseous nerve, is nothing. It is the deep branch of the radial nerve. Radial nerve is having the superficial branch and deep branch. Can you see? One muscle is rounding the radius. This is nothing. This is our supinator, which is pierced by the pin. I am showing you the three-dimensional orientation. Look here. Yes, sir. This is our three-dimensional orientation. Can you see? The radius, the ulna. Yes. This supinator muscle is taking origin from the our ulnar crest, winding over the radius. So when it will contract, it will do, yes, supination. Getting the point? So these are our different points. Cadaveric image practice. These are the different way how you can remember. See here. The muscles. How you will identify? Can you observe? This is our thumb side. And you can observe one muscle is from the brachium towards the radius. Yes, sir. It is brachioradialis. So this first muscle is definitely our pronator teres. Can you see this muscle is coming and it is going towards our radial bone? Yes, flexor carpi radialis. It is a flexor muscle going to the carpal side and it is towards the radius. And you can observe the muscle which is going towards our palm. So this is the flexor digitorum above, that's why superficialis. And another muscle towards the ulna side, that's why flexor carpi ulnaris. Okay, getting the point? Now look here, this one. What you have to observe? Yes, first thing, where is a thumb? So this is your thumb. So definitely it is lateral and this particular part is your medial side. Agree? Now look here. Can you observe this muscle? It is coming and it is going to the thumb. Yes, sir. So it is our flexor pollicis our longus. Agree? Now, look here, this particular muscle is coming. These muscles are coming. Yes, sir. And these muscles are giving origin to the one thin muscle. Yes, these thin muscles are our, remember, these thin muscles are lumbrical. Getting the point? Yes. So definitely, which muscle is giving origin to the lumbricals? Remember, this is our flexor digitorum profundus. Agree? The lumbrical muscles, they takes origin from the flexor digitorum profundus. See here, this is my research work. Okay, pronator quadratus at Indore. I had presented this question, this paper. See here, this is one muscle which is quadrangular. Yes, sir. It is responsible for the pronation. That's a pronator. And easily you can remember it is quadrangular. That's a quadratus. Agree? Yes, you can see the hand side. You can observe one nerve is coming. Yes, yes, yes. So iPad is getting down energy. My pencil is getting down energy. But yes, we will do the session. See here. This is the nerve which is passing depth. Here is the radius. This is the ulna. In between them, there is the interosseous membrane and one nerve is running above. Yes, this nerve is running above the interosseous membrane. So this is anteriorly running. That's anterior. Yes, interosseous nerve. Yes, sir. It is our anterior interosseous nerve. Remember, this anterior interosseous nerve is nothing. It is deep branch of median nerve. Agree, everybody? Getting the point? Fine. So now try to understand. Yes, yes, Priyanshu, thank you, beta, thank you. Okay, so we are, yes, Rohan, thank you, beta. Yes, thank you, HY, for your lovely words. Now try to understand, beta. See here, we had seen this one. Can you see this muscle is coming, going to the thumb? So this is our flexor pollicis. What? It will go to the distal part. Distal part means longus. Now can you see? This muscle is above. So flexor digitorum superficialis. This muscle is at the depth. You can see it is below. Here is above. So flexor digitorum profundus. And can you observe the, yes, unidirectional muscle? Sir, it is first lumbrical. Unidirectional muscle? Yes, second lumbrical. We had seen, na? And here is a third and so on, fourth. So definitely these muscles are taking origin from the flexor digitorum profundus, and these are our different lumbricals. First, second, third and fourth. Agree? Can you crack? Now, can you see? These are our metacarpal bone. Yes, sir. First metacarpal, second, third, fourth, fifth. So, you can observe easily these muscles are unipennate. Yes. Getting the point? What should be the name? Sir, these are in between the bone. So, these are interossei. Yes. When this interossei muscle, it will contract. It will do adduction. It will contract. It will do adduction. It will contract. It will do adduction. So, this interossei is responsible for the adduction. Do you know? Pad. Palmar interossei are adductors. So, these are our palmar interossei. These are the palmar side muscle in between the bones. Palmar interossei. Agree, everybody? Now, try to understand here. Yes, yes, Kalpita, thank you, beta. Thank you for your positive. Yes, Ankit, you are right. The first and second lumbrical, no excuse, median nerve. Third and fourth lumbrical, no excuse, ulnar nerve. Agree, everyone? Now, can you see? Again, there is our first, second, third, fourth, and fifth metatarsal. And you can see beautifully, yes, these muscles are having the bipennate nature. Now, use common sense. If this muscle will contract, it will go here. If this muscle will contract, it will go here. If it is contract, it will go here. Away from the middle line, this is our abduction. These muscles are in between the bones, so these are interossei. Now question, palmar interossei or dorsal interossei? Definitely dorsal interossei are abductor. So for the palmar interossei, you perform the different test. Yes, what are the different tests? See here, hope you all are aware. Okay, so tell me, yes sir, this is our card test. Palmar interossei, they are used for the card test, and dorsal interossei, yes, you will use the Igawa test. Getting the point? Fine. Yes. So these are the different points about the muscles. Now I am going to tell you about the nerve. There are the too many points regarding the nerve. Here is the notes, detailed notes, but at the last I'm not telling this all the detailed notes. Actually this all the questions are the for your detailed part, but I included in the PDF so that you can go for once. But what the important points now are going to ask. Remember the dermatome, you all are aware. I told you on the dorsal side lateral 3.5, yes, on the palmar side lateral 3.5 median nerve, at the anatomical synapse radial nerve, and on the medial 1.5 ulnar nerve. No excuse, you all are aware. And this dorsal side I told you already. Fine. See here, median nerve. Clinical points, orthopedic integration. What you have to remember? Median nerve entire course, it is coming from the brachial plexus, then it is reaching into the arm, then it is situated in the cubital fossa, making the MBBR, then it is supplying the muscles of the entry compartment, and then it is ending the hand. But what the clinical questions are asked? Yes, you can remember the Captain America. Remember, the Captain America was unable to perform the MBBS. Why? Yes, because he joined the Avenger team and he did the bachelor in physiotherapy. So what are the different median nerve tests? C for carpal tunnel syndrome, CAT, BPT. You can remember. Yes, at the Cerebellum PDF, at the Cerebellum platform, you will get better. Okay, few things we will do, and definitely you will get very soon. Fine. Yes, you are right, Dark Knight. The first and the fifth, they are not having the dorsal interossei, but the middle finger, it is having the two dorsal interossei. And in the similar way, the palmar interossei, remember the middle finger is not having the palmar interossei. Fine. Now see here, C for carpal tunnel syndrome, A for apt thumb deformity, P for pointing index, B for Benedict hand, and P for Phelan test or pen test, and T for Tinel sign. So what are these things? You can see the carpal tunnel, yes, for which you are performing the different surgery. Yes, carpal tunnel syndrome, there is a compression of the median nerve below the our carpal tunnel, for which you will perform the surgery. Yes, flexor retinacular you have to cut. See here the Tinel sign. When you are tapping over the flexor retinacular, there is a pain. This is the Tinel sign. It is found in case of the carpal tunnel syndrome, and when you are doing this movement, excessive compression, then there is our Phelan's test. Getting the point? Fine. So this is also positive in case of the median nerve. Yes, you all are aware this is our apt thumb deformity, and this is our Benedict hand deformity, which is found in case of the median nerve. Yes, median nerve is injured at this our mid forearm, then flexor digitorum profundus is normal. Why? Because the medial half is supplied by ulnar nerve. So person can flex this one, but these two fingers are remaining straight. Agree? Fine. Yes, 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 Parth, you can remember the Captain America is bachelor in physiotherapy, okay? And here is the pen test, NEET PG 2021. Yes, you are touching the pen with the abduction. Abductor pollicis brevis is responsible, and it is supplied with the median nerve, so it is the test for the median nerve, okay? This is the pointing index, injury of the median nerve at the mid forearm. This is the Ocean clasp test, same. And remember, these are the 5 structures. Few books are saying the 6th structure, like the superficial branch of the radial artery, it is passing. So these are the different structure passing above the flexor retinaculum. But remember, during the wrist cut injury, yes, anatomy and FMT integration, wrist cut injury, तड़प तड़प के इस दिल से आह निकलती रही, हमको सजा दी प्यार की, ऐसा क्या गुनाह किया. When there is a wrist cut injury, remember the structures which are passing above the carpal tunnel, these will get cut. Ulnar nerve, ulnar artery, tendon of the palmaris longus, and cutaneous branches of the median nerve and the ulnar nerve. These are getting cut. But median nerve will not cut. Remember, there is our palmar aponeurosis. So fibrosis of the palmar aponeurosis, it results in the Dupuytren contracture of our orthopedic integration. Okay. Now try to understand. This is the entire course for the our ulnar nerve. But one mnemonic clinical points are important. You can revise from there. Ulnar nerve, you can remember the A, B, C, D, E, F. A for ulnar nerve. Yes, little changes in the spelling. B for book test for the ulnar nerve. C for card test for the ulnar nerve. D for ductor pollicis test for the ulnar nerve. E for Igawa test, and F for Froment sign. इतना ही पढ़ना है, बार बार पढ़ना है. ब्रूस ली को आपको याद रखना है. Yes, 10,000 times for the single thing. Same thing you have to practice. Yes, we had seen this all the points in lumbrical part. Now look here, there is one new question, Guyon's tunnel syndrome. See here, ulnar nerve, ulnar artery, they are coming from the ulnar side. So if there is a compression of this ulnar nerve and ulnar artery, then it is known as the Guyon's tunnel syndrome. Ulnar nerve, ulnar artery, they are coming here. It is compressed against the handle of the bicycle. So this is also known as the handlebar palsy syndrome. Yes, you can see the carpal tunnel. She looks too pretty, try to catch her. Above this carpal bone, there is our carpal tunnel. So median nerve is passing depth. But you can see here is the one more tunnel. This is Guyon's tunnel. Through this Guyon's tunnel, which structures are passing? Ulnar nerve, ulnar artery. So compression of this ulnar nerve, ulnar artery in bicycle riders, this is known as the handlebar palsy syndrome. Yes, it is passing through the Guyon's tunnel, so it is also known as the Guyon's tunnel syndrome. Getting the point? Now try to understand. I told you this, all the palmar introshite, dorsal introshite, Igawa test. Yes, sir. And this is our radial nerve. Yes. Nowadays, this is not the question how the radial nerve is passing, but their question is, yes, can you tell me this is what, sir? This is our crutch palsy, compression of the radial nerve at the axilla. Can you see the Saturday night palsy? Yes, sir, it is our Saturday night palsy. At the Saturday night, yes, compression of the radial nerve by the edge of the chair. And don't forget this one. This is our what? Yes, wrist drop. Wrist drop due to the radial nerve injury. And you can see this is our, yes, finger drop. Yes, finger drop due to the radial nerve injury. And one more thing, one new fact, honeymoon palsy. Yes, remember this is our honeymoon palsy. So, honeymoon palsy, there is the compression of the radial nerve. Okay, fine. And usually seen at time of the honeymoon. I am telling you what is the treatment. If medical treatment is failed, then only two treatment. Either cut the arm or cut the throat. This is the permanent treatment. Okay, don't take seriously. I am joking. Okay, fine. So remember, this is the your honeymoon palsy, radial nerve injury. And don't forget this our part, anatomical snub box. See here, there is our you can remember the anatomical snub box, everything, boundary, entry boundary, I had written here, longus, posterior boundary, longus, and between is brevis. So there is our longus, abductor pollicis longus, posterior boundary, extensor pollicis brevis, and there is the between is our extensor pollicis brevis. Yes, posterior boundary is extensor pollicis longus, आगे longus, पीछे longus, बीच में brevis. So these are our different boundaries. Roof, use the common sense, skin, superficial fascia, deep fascia. At the superficial fascia, there is a radial nerve. So I told you the salmon boy, yes, wristwatch neuropathy, chiralgia paresthesia. Yes, at the superficial fascia, cephalic vein, which is used for the intravenous injection. And then floor is formed by the touch here. Sir, styloid process of the radius is here. Then scaphoid bone is here. Then carpal bone, trapezium. Then our first carpal. Don't try to mug up, just to feel it here. Do imagination, think about it, you will get the answer. Remember, orthopedics, most common bone getting avascular necrosis, neck of the femur, head of the femur. But second most common bone, scaphoid bone, MCQ. Scaphoid fracture is important. Also remember that there is our, yes, third most common bone, talus. Okay. Content, only one content, radial artery. And here I told you the Finkelstein test and our, yes, already I told you de Quervain tenosynovitis. So these are our points. Okay, fine. So these are the things. So now there are the more things I had included in the PDF for all of you. But right now, okay, we are going to look for the lower limb. So just a little vocal rest, then we are going to continue. Yes, Salman Bhoi, and yes, he is most respectable person in our India. Okay, आज गाड़ी तेरा भाई चलाएगा. Okay. Yes. Any doubt till now, beta? Yes, ask. Then we are going to see our PYQs. We are going to do this our PYQs. More things we will discuss. Hope you all are enjoying. So we will do in our upcoming session more. But right now we are going to start our lower limb part. Fine. Ready? So thank you. So hope you all are enjoying. Your emojis are saying yes. So let's start. Energy is 10,000%. Yes, Parth, thank you, but thank you for your positive words. Yes, when you all are with me, then definitely my energy will never get down. Okay, so just see here, NEET PG 2022 question. Fine. What they are asking? Patient who underwent varicose vein surgery. Okay, now presents with loss of sensation in medial leg. Yes, sir. There is a loss of sensation in the medial leg. Which nerve is injured? Yes, remember, this is our saphenous nerve. Can you see PG 2022 and can you see PG 2021? Again, coronary artery bypass grafting. Yes, we are taking the great saphenous vein. But nowadays, internal mammillary artery is the best choice. Okay, so what you can see, the complication, which nerve is injured? Again, answer is saphenous nerve. Are you looking the pattern? Sir, saphenous nerve, 2021, 2022 question and topic is getting repeat. Yes, clear cut it is visible. Foot drop is due to damage of which nerve? Tell me. Yes, you all are aware this is due to the our common peroneal nerve. Agree? Fine. So we are going to look for this different points. Try to understand. This is our ASIS, anterior superior iliac spine, pubic tubercle, pubic crest, pubic symphysis, and you will be able to see the thigh. Then there is the knee. Just one single diagrammatic presentation. Only these few questions are asked from the lower limb, so we are concentrating for this one. And then you can see the leg part. Yes, sir. So here is our medial malleus, lateral malleus, and there is our great toe. For the beauty of the diagram, we are showing the dorsum, so we are making the nails as well as we are doing the nail polish. Okay. So try to catch this point. At the inguinal region, there is one ligament. This is our inguinal ligament. Yes, sir. It is our inguinal ligament. Agree, everyone? So try to understand. At the dorsum of the foot, yes, there is a dorsal venous arch. Here is the medial marginal vein. Both are meeting together and making the great saphenous vein. Yes, sir. It is our great saphenous vein. This great saphenous vein is lying in front of the medial malleus, and then it is ascending upside, and then it is passing backside. Yes, it is running at the roof of the cubital fossa, our popliteal fossa, and then running in the femoral triangle, and it is running at the roof. Yes, at the roof there is the cribriform fascia. There is a saphenous opening. It is entering inside and opening into the deep vein, femoral vein. Getting the point? Remember, the longest cutaneous nerve of the body, saphenous nerve, is here. So if you are doing the phlebotomy, clinical integration, phlebo means vein, tomy means cutting. You are cutting the vein. Yes. Or you are cutting the vein for the hemosiderosis. Yes. For the coronary artery bypass grafting. At that time, there is a high chances for the cutting the saphenous nerve. So definitely there is a loss of the sensation at the medial side. One thing I want to tell you, lateral nerve, lateral side vein, it is meeting with our dorsal vein of the foot, lateral margin, and it is making the short saphenous vein. Which vein, beta? Yes, sir. This is our short saphenous vein. Also, you can say a small saphenous vein. Remember, at the lateral side, there is a which nerve? Sural nerve. Never forget this nerve. Sir, this is very important. This is our sural nerve. So, if there is the damage to the short saphenous vein, sural nerve is getting damaged. It is having the root value S1. No excuse. Very important. Fine. Now, yes, beta, yes, Dr. Amit, it is very, very unique question. Right now, I conducted the first MBBS university exam. The long question, yes, it is very important. So all the questions are coming from the first MBBS from our basic things. Okay, so remember these points. So there are our different points. I'm showing you the different bones here. Yes, lower limb, look here. You all are aware. Sir, hip bone. Sir, femur, longest and strongest bone of the body, the largest seed-like bone. This is our patella, largest sigmoid bone. And remember, patellar fracture is important for all of you. Okay, we use the K-wire fixation, and then this is the tibia. Here is the fibula, and can you see the foot bone? The largest bone is our calcaneum. Then here is our talus. Just in front of it, there is a navicular bone, and then you can see 1, 2, 3 our cuneiforms, and these are the first, second, third metatarsal. Lateral side there is a cuboid, and here are our different other bones. Yes, you can remember these are our fourth and fifth metatarsal, and here is the phalanges. This knowledge will be useful for the arches of foot and congenital talipes equinovarus, this part. Okay, so we are looking for our different muscles. See here, can you see cadaveric image? Focus here. This is our external oblique aponeurosis. Here is anterior superior iliac spine. Fine. So you can observe beautifully one longest muscle of the body. Sir, this is our longest muscle of the body, sartorius. This is also known as the Taylor's muscle, honeymoon muscle. You can observe here another muscle. Can you observe? See here, this another muscle. Yes, it is coming from the medial side. So it is adductor. One mnemonic I want to tell you: A, P, then P, and then I. Epi. We all are aware with our soft drink Epi. A for adductor, longus. Sir, P for pectineus. P for, yes, psoas major, and I for iliacus. Tendon of the psoas major is there. So you can remember A, P, P, I. Agree? Yes, sir. This is medial border of the adductor longus and medial border of the sartorius. This is our inguinal ligament making the femoral triangle. Okay? Yes. So you must remember what are the different content. You all know, sir, there is the femoral vein, then femoral artery, and then femoral nerve. I told you everywhere the relation is the VAN. Agree? Fine. But there is our femoral lymph node of the Rosenmuller and Cloquet also. Yes, sir. There is the lymph node of the Rosenmuller and Cloquet. And I told you the modification of the deep fascia around the femoral vessels. Yes, sir. There is a modification of the deep fascia around the femoral vessels. This is our femoral sheath. No excuse. It is very, very important. This is our femoral sheath. Femoral hernia you have to deal in your surgery. Fine. So, which structure is outside? Sir, femoral nerve is not the content of the our, yes, femoral sheath. Agree, beta? Now, there is a question, which is the femoral canal. So, catch this point, femoral hernia surgery, the medial most compartment. Yes, sir. This medial most compartment is known as femoral canal. What is the content of the femoral canal? Sir, lymph node, deep inguinal lymph node of the Rosenmuller or Cloquet. Remember, Dil is located here. No. Dil is located in the femoral triangle. Dil is located in the femoral canal. Dil, Rosenmuller or Cloquet lymph node is located in the femoral canal. Don't forget. Yes, femoral hernia, it occurs through this femoral canal. Now, you will start the surgery after this anatomy. Agree? Fine? Yes. Now, look here. There are the more things. Don't forget this muscle. Largest muscle of the body. You can see the sacrum. Yes, sir. Iliac crest part. And very big muscle is coming from the back side. So, definitely sacrum is there. Means back side. So, back side. So, this is our gluteus maximus. It is getting insertion into the, remember the gluteal tuberosity is the main answer, na? This is our gluteal tuberosity. What I want to tell you, one question sure shot from our gluteal region. Fine. Now we are cutting this all the muscles. So you will see the gluteal muscles are removed. So you can observe one very thick nerve, very thick nerve. Definitely this is our sciatic nerve, thickest nerve of the body, which is also considered as the pregnant nerve. Now remember, this nerve is coming from the whatever the muscle that is pear-shaped muscle. Yes, piriformis. Getting the point? Now, there is another muscle which is taking origin from the inner side of the obturator foramen. So, this is obturator internus. Above to it, superior gemelli. Below to it, you will say inferior gemelli. So easy. Okay? Yes, I am telling the important points. Otherwise, when we will meet for our detailed classes, I will show all the 3D dimension, all the origin insertion. But right now, you have to crack the exam. Just to main point I am telling you. So, you can see one muscle at the depth. Can you see? Observe. This muscle is quadrangular in shape. Yes, sir. So, this muscle is our quadratus femoris. Fine. And here you can see the ischial tuberosity. So, from the ischial tuberosity, very long muscles are taking origin. Can you see this muscle is coming from here and it is having the one more head. Sir, this muscle is having the two head. That's why it is our biceps, but not the brachii. It is in the femur. That's why biceps femoris. Agree? Agree everybody? Yes, sir. It is biceps femoris. Now you can see one more muscle is coming from here, but it is becoming tendon-like. So this is our what? It is our what? Yes, it is half a tendon. So you will say semi-tendinosus. Sir, it is half a tendon. That's a semi-tendinosus. And another muscle at the depth. Yes, it becomes like the membrane. So you will say, sir, semi-membrane. membranosus. Getting the point? And now catch. Anatomy means cut and observe. So observe here, beta. Yes, this is rhomboid shape space. Yes, it is our popliteal fossa. And you will see within the popliteal fossa different content, but this is the exception where AVN relation is found, not the VAN. Here there is a AVN relation. The superficial structure is our nerve. Deep to it, yes, you will see the vein. And the deepest most structure, yes, you will see the artery. So remember, it is superficial to deep. That's why in surgery department, it is not so easy to palpate the popliteal artery. Yes, there is our nerve. Sciatic nerve will divide into two. This particular nerve is tibial nerve and another is going towards the neck of the fibula. Common peroneal nerve. Getting the point? Yes, sir. This is our tibial nerve and this is our common peroneal nerve. Don't forget it. Fine. Now, try to understand. Yes, beta. Pharyngeal apparatus we had seen in the embryology. Few more points we will see. Okay. So these are our gluteus maximus, medius minimus for your practice. And I had given all the theory part. Gluteus maximus, origin, insertion, action. Yes, remember it is coming from the back side. When it will contract, it will do extension. Yes, now supply. Don't forget inferior gluteal nerve, but clinical integration. See here, this is our Gower sign. Gluteus maximus is located here. If it is getting damaged, then there is no extension. The patient will climb up. Yes, this is our Duchenne muscular dystrophy. This is our Gower sign. Don't forget, this is the gluteus maximus integration, anatomy integration with the medicine and the pedia. Yes, chromosome number 19 involvement. Agree? Now, see in the same way, gluteus, just below the gluteus maximus, there is a medius and the minimus. Remember, these are causing abduction. These are responsible for the abduction. Okay, so I am showing you the three-dimensional orientation for this gluteus muscle. Can you see? This is the gluteus maximus. It is crossing the hip joint from the back, so it will move the hip joint backside extension. Yes, but when we are removing this all, so can you see the gluteus medius? It is coming from the lateral side, inserting on the lateral side. Can you see the gluteus minimus? Yes, look here. This is the gluteus minimus. It is taking origin from the lateral to the lateral. So when it will contract, it will move the thigh lateral side, means away from the middle line. That is the abduction, and this abduction is done during the walking. So if there is a damage in these muscles, yes, these muscles are supplied by which nerve? Sir, superior gluteal nerve. Superior gluteal nerve is supplying the gluteus medius, minimus and the tensor fasciae. So when it is getting damaged, so there is the abnormal gait. The person cannot abduct. Okay, so during patient cannot abduct. So if there is a damage, one side damage, lurching gait, both side damage, waddling paralysis. So when we will meet for the offline classes, I will tell you. Yes, our Shakuni mama, remember, मेरे बच्चों, मैंने कहा था ना, रणभूमि में खेलने से पहले तपोभूमि में मनोभूमि में खेला जाता है. Something like dialogue. Yes, he was having the lurching gait, getting the point, this kind of the manner. Why? Because one side of the gluteus medius and minimus was damaged. Yes, superior gluteal nerve was damaged. So it is not doing the proper abduction. So gait was abnormal. And in our Donald duck, yes, waddling gait, right and left, both side of the gluteus medius and minimus, they are getting damaged. So there is the lurching on right side as well as left side. So this is your waddling gait. Getting the point? Don't forget this all. Gluteal question definitely it will ask. And don't forget this Trendelenburg sign. See here. Yes, when we are standing, so at that time, feel the gluteal region. There is a contraction of the gluteus medius minimus. It will pull the opposite sacrum. It will pull the opposite ilium. So ASIS, anterior superior iliac spine, it is getting left. Agree? Yes, it is normal. But if this muscle is getting paralysis, so there is a no pulling of the sacrum, no pulling of the our anterior superior iliac spine. It is getting down. Sagging of the pelvis is known as Trendelenburg sign positive. When there is the abductor muscles are damaged. Getting the point, everybody? Yes. So hope you all are catching the point. So now see here our sciatic nerve. Yes, you all are aware. I am telling you again. Suppose this is our diagrammatic presentation. Okay, sir. Just one simple linear presentation. There is our piriformis muscle. Agree, sir? Which is pear-shaped muscle. Okay. So the nerve which is taking origin, which is coming from here. Yes, remember that is our sciatic nerve. It is reaching to the which fossa? Sir, we all are aware, popliteal fossa. Agree? Now, at the apex of the popliteal fossa, this nerve is dividing into two. One is running laterally, another is running downside. Yes, this downside running nerve is our tibial nerve. Getting the point? So, remember this is our, yes, sciatic nerve. This is tibial nerve. Here is common peroneal nerve. Remember, this common peroneal nerve is in close relation with the fibula. Here it is dividing into two. Deep branch, yes, the deep peroneal nerve which will run on the front side, and another is our lateral side running nerve. So this is making the our deep peroneal nerve and our superficial peroneal nerve. What I want to tell you, see here, look at this part. The sciatic nerve is having the course on the back side. Yes, this sciatic nerve is reaching into the, yes, it is dividing into the our tibial nerve and lateral side nerve. Yes, sir. This is our sciatic nerve, tibial nerve, CPN, common peroneal nerve. It is in close relation with our neck of the fibula. Here it is dividing into the deep peroneal nerve and our superficial peroneal nerve. Yes, don't forget it. Deep peroneal nerve and superficial peroneal nerve. So if there is a fracture of this neck of the fibula, yes, common peroneal nerve is the best answer. Clinically, common peroneal nerve is seen. But if it is not given, then you can mark the deep peroneal nerve also. Fine. And it is nerve of the front compartment. So if deep peroneal nerve is damaged, foot will not elevate, it will go down. Yes, just like the wrist drop, foot drop. So don't forget this question. Fine. Now, look here. Yes, runner muscle. Remember, I told you the hamstring muscle. These are the runner muscle. Four muscles: semitendinosus, semimembranosus, long the biceps femoris, and adductor magnus ischial head. Because these muscles are taking origin from the back side, inserting on the back side. When they will contract, they will do running movement. Okay. So these are the points. So you can revise the leg part from here: anterior compartment, lateral compartment, posterior compartment. These are the three compartments. In the anterior compartment, you can remember the mnemonic: the hospitals are never dirty places. Agree, everybody? Yes. T for, you can remember, tibialis anterior. H for extensor hallucis longus. A for artery. Which artery? Anterior tibial artery. Nerve. Which nerve? Deep peroneal nerve. D for digitorum longus. Which digitorum longus? It is extensor compartment, extensor digitorum longus. And P for peroneus tertius. Remember, nerve of the anterior compartment, sir, deep peroneal nerve. This all the notes will be available at our cerebellum platform. Don't worry for it. Just concentrate and revise these things only. So remember, all the muscles of the anterior compartment, they all will be supplied by which nerve? Answer is deep peroneal nerve. So easy. Why? Hilton law. जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. On the anterior compartment, which river is flowing? Sir, deep peroneal nerve. So deep peroneal nerve will supply all these muscles. Agree, everybody? Now, the lateral compartment, on the lateral side, there is only peroneus longus and peroneus brevis. So, on the lateral side, which nerve? Sir, sapna is there. Sapna is where? Lateral side. So, what is the nerve supply of the peroneus longus and peroneus brevis? Sir, superficial peroneal nerve. And we will see the posterior compartment, but one few line about the medial compartment. At the medial compartment, you will see the pore structure. You can remember again Salmon Boy, the most respectful person from our country, India. Huge respect for him. Yes, आज गाड़ी तेरा भाई चलाएगा. Yes, remember the mnemonic for this structure. Salman गधे से टकराया. Just one funny mnemonic so that you can remember. S for Salman, S for Sartorius, G for gracilis. Yes, G for गधे से gracilis. S for semitendinosus and T for tibial collateral ligament. So in your tibia, you will see the four structure. What are the four structure? Sir, there is a sartorius, sir, there is a gracilis, sir, there is a semitendinosus, and then one ligament, tibial collateral ligament. In orthopedics, you will see there is the anserine bursa, most complex bursa of the body in between them. These muscles are also known as the guy rope muscles. Yes, sir, these are also known as the guy rope muscle. Getting the point? Yes, yes, Ash, you are right, beta. Fine. So these are the different points. Now see here, posterior compartment muscle. The posterior compartment is very bulky. Superficial group and the deep group you can divide. In the superficial group, you can remember the GSP. Yes, gossip, the best job in the world, GSP. G for you can remember the gastrocnemius. S for you can remember the soleus, and P for you can remember the plantaris. Gastrocnemius is having the lateral head and the medial head. Yes. Soleus, which is the peripheral heart. These all three are combining in making the triceps suri, and the tendon of the triceps suri is making the Tendo Achilles, the strongest tendon of the body. Troy, watch the Troy movie. When we will meet for the live class, I will tell you the story of this Achilles. But remember, the strongest tendon of the body is our Achilles tendon, which is made by the tendon of the triceps suri. One more thing, remember, this plantaris is having the very thin, orthopedics integration. Can you see? The all bulky muscles are here. This is our tendo Achilles. Now I am showing you this particular muscle. Can you see? Beautiful. It is having the short belly and very long tendon. So in orthopedics, which muscle you will use for the tendon grafting operation? Answer is your plantaris. Which muscle in upper limb you will use? Answer will be palmaris longus, because these are having the very long tendon. Agree everybody? Fine. Yes. Thank you, Jitu. Thank you, beta. Yes. So Sunil is saying Sunny Leon. Yes, Sunny Leon mnemonic will also come. So don't worry for that. Okay. So these are the different things. Now try to understand further thing. What are the deep muscle? So you can remember the mnemonic. The doctors are never hungry. Doctors को कभी भूख नहीं लगती. वो अजर अमर हैं. Doctor इंसान नहीं है. Yes, they are never hungry. Okay, sir. Now it is 11, it is 12. Yes, we are feeling hungry. Okay, yes, take your whatever dish, watch and just eat. Okay, so enjoy the session with your dinner also. Okay, so what I want to tell you, see here, T for, sir, there is our tibialis posterior. D for, you can remember digitorum longus. A for, you can remember the artery. Which artery? Positibial artery. If FMG students are there, I want to tell you continuously FMG 2019, 20, 21, 22, but not in the 23. This question had been asked. Okay, which is the nerve of the posterior compartment? Sir, it is the tibial nerve. All the muscles of the posterior compartment, it will be supplied by which nerve? Answer is tibial nerve. Which rule? Hilton law. Yes. All the muscles will be supplied by the nerve of this compartment. And H for, yes, hallucis longus. Agree everybody? Fine. So now after this all, we are looking for the arches of foot. You know, the Martin Guptill, he is not having the toes. The great player of the World Cup 2019 World Cup final, he is not having the remaining toes. So amazing. But remember, in anatomy, it is the sentence, no role of the toes. If you will cut these two toes also, there is a no effect. Why? Because these toes are never participating in arches of the foot. Okay, so there are the different arches of the foot. I had drawn this diagram in live class. I draw, but this is the bullet train anatomy. We are running rapidly. So you can see the largest bone is the calcaneum. In front of the calcaneum talus, there is the boat-shaped bone, navicular, then medial, intermediate, lateral, our cuneiform, then first metatarsal, second and third metatarsal. Remember, there is a magic of 3 which are making the medial longitudinal arch. Yes, how the magic of 3? 3 metatarsal, sir, 3 cuneiform, and yes, 3 tarsal bone. Yes, cuneiform, there are also the tarsal bone, but you can include. And what are the bones making the lateral longitudinal arch? You can see the 2 tarsal and 2 metatarsal and 2 tarsal, cuboid and lateral half of the calcaneum. If there is a problem in these bones, then there is the deformity in the foot. No excuse with the club foot. Your mnemonic is CAVE. No excuse. Yes, this is our congenital talipes equinovarus. From this anatomy, your orthopedics will start. Okay, so from here you will see there. Okay. Yes, Ankit, go at the internet, Google, and type Martin Guptill toes. You will get. Okay, fine. So now try to understand. I told you. See here, venous drainage. I told you. Fine. Varicose vein. That's why it is important. It is running in your pattern 2021, then 2022. Okay, varicose vein is important. That's why this venous drainage is important, as well as our deep venous thrombosis is important. That's why. Now little information about the arterial supply. Why? Gangrene of the foot, thromboangiitis obliterans, Burgess disease. So try to understand. Yes, there is our aorta. Which aorta? Yes, sir, abdominal aorta. Go for my YouTube channel. There is the one session, 2 hours. All the artery supply of the body in the 2 hours with the 3-dimensional orientation. You can get the idea. Okay. So you can see here there is an abdominal aorta. Yes, sir. It is dividing into the right and left common iliac artery. NEET PG 2021 question had been asked. Then it is dividing into the internal and external iliac artery. This external iliac artery, yes. See here, it is running in our femoral triangle. So it is making the femoral artery. Femoral artery is nothing. It is a continuation of external iliac artery. Now it is passing into our popliteal fossa. So it is making the popliteal artery. Then this popliteal artery is dividing into the anterior tibial and the posterior tibial artery. Yes, so anterior tibial and posterior tibial, they are nothing. These are continuation of our popliteal artery, and then the same artery is running as the dorsalis pedis artery. Don't forget this dorsalis pedis artery is very important. Different landmass I had put here, but at least this point you have to remember. Agree? Now we are going to look for the abdomen and pelvis. Okay. In anatomy, what you have to see, only the peritoneal ligament and anterior abdominal wall. Complete. Remaining things are related with the surgery, so watch there. But just to start here, a patient with history of pain in the both legs while taking long walk, he developed toe gangrene. Toe gangrene means, yes, our lower limb artery, femoral artery is involved, popliteal artery is involved. Admits to having erectile dysfunction. Sir, erectile dysfunction, genital part will be supplied by the our internal iliac artery. Okay. So what is the best answer? Sir, right internal? No. Right external? No. Left internal? No. Because genital and both are involved. See here. If there is the blockage at this site, then genital part will be involved and lower limb will be involved. So this is the answer. Otherwise, our bifurcation of the site is also correct. But if this is involved, then bilateral will be seen. If it is involved, then unilateral will be seen. Hope you are getting the point. Fine. So now come to this. Yes, ligament derived from the marked structure. So this is our, remember, I will tell you, don't worry. I will tell you, otherwise, see here, just one little description. We are cutting the abdomen transverse section. Okay. So this is our abdomen, anterior abdominal wall, posterior abdominal wall. Getting the point? Yes. Peritoneum is where, sir? Peritoneum is lining the inner side. Okay, sir. But there is a development of the what? Viscera. Agree? So what is happening? Yes, there is an anterior abdominal wall, posterior abdominal wall. There is a development of the our GIT, and which is migrating inside. So now the peritoneum is covering in this way, in this way, in this way. Yes, sir. This is the way. Fine. So now this peritoneum is having the two different layers. Sir, this is outside layer. Sorry. Just give me a few seconds. And another is, suppose this is stomach. So this is visceral layer. Agree. Now there is a GIT rotation. It will fall at one side. So what is our next step? See here. Yes. Stomach is falling at one side. So you will be able to see there is a parietal peritoneum. Yes, sir. And it is having the peritoneal fold in this way. Yes. Earlier there was the two equal cavity, right, left cavity, both are equal. But now, suppose this is the stomach, so the cavity is big on front side of the stomach. Sir, this is greater sac. And another cavity which is small behind the stomach, sir, it is lesser sac. Agree? So there is the one communication. There is a one communication between the greater sac and the lesser sac. Yes. Very, very important. The communication between the greater sac and the lesser sac. This communication is foramen of Winslow, also known as the epiploic foramen. Very important. Agree? Fine. So just one diagrammatic presentation. Okay. Now look here. Yes, there is a development of the different ligament, different structures. I am showing you one more thing. Schematic diagram I am drawing, not exact diagram. Fine. See here. So stomach is at the center. Suppose it is our stomach. Yes. Our peritoneum is attached. So peritoneum is covering the stomach. Fine. Yes, it is attached with the stomach. Fold of the peritoneum is known as the meso. It is attached with the stomach, so it is known as the mesogastrium. Agree? Because suppose it is anterior side, this is posterior side, so it will be known as ventral mesogastrium. This is our dorsal mesogastrium. Agree? Just one simple schematic diagram. I am not drawing exact diagram. just making easy. So this is lining the parietal peritoneum, it is lining the visceral peritoneum, okay, parietal peritoneum, okay sir. But now later during the development, at the right side there is the development of the hepatic bud. Yes sir, suppose here is the liver development. So liver is developing where? Sir, liver is developing in our ventral mesogastrium. Sir, this is our hepatic bud. Agree? And in the similar way, on the left side, there is the development of the splenic bud. Yes. Here is the development of the what? Splenic bud. Agree? Yes, sir. So this peritoneal fold is covering in this way. So there is the DMG, dimag, and here is the VMG. You know, always we are saying, तेरे पास दिमाग विमाग नहीं है क्या? Yes, मेरे पास दिमाग भी है, मेरे पास विमाग भी है. What is the dimag? Dorsal mesogastrium. What is the vimag? Ventral mesogastrium. Agree? Now see here, this vimag, ventral mesogastrium, again it is divided into the ventral part. Yes sir, it is our ventral part, and this is the dorsal part. Yes sir, the ventral mesogastrium, it is divided into the ventral part, and this is dorsal part of the ventral mesogastrium. And in the similar way, this dorsal mesogastrium is divided into the front part, ventral part, and this is the back part, dorsal part. So dorsal mesogastrium is also having the ventral part and the dorsal part. Agree? Fine. Now look here. During the development, this is the liver. Yes sir, it is our liver. Getting the point? So this liver is attached with the anteroabdominal wall. Remember, it is nothing. It is our ligament falciform. So this is the question. Such kind of the image had been asked. Ligament falciform is developing from ventral part of the ventral mesogastrium. MCQ. Why? See here, this particular part, dorsal part of ventral mesogastrium, it is attaching the liver with the stomach. So this is our, yes, gastrohepatic ligament. Better to say, this is our nothing, it is our laser omentum. I will show you. So remember, laser omentum, it develops from what? Remember, dorsal part of the ventral mesogastrium. Sir, it is spleen, and on the posterior back side there is a development of the our, yes, kidney. So remember, this ventral part is making the ligament between the stomach and spleen. So this is making the splenogastric. Also you can say gastrosplenic ligament. Gastrosplenic ligament is developing from the ventral part of the dorsal mesogastrium. Agree? And in the similar way, yes, you will see this dorsal part. Yes, here is the kidney, na? Our posterior abdominal wall structure. So remember, this part is between the spleen and kidney. So this spleen is also known as the linoid. So this is nothing, it is our linorenal ligament. Agree everybody? Yes, I know it is bullet train anatomy, it is very, very high speed, but hope you are getting the point. Otherwise, you can revise later from revising the YouTube video as well as from the your yes, this one PDF. Okay, PDF we will share. Fine. Agree, beta? So now we are going to look for the our more things. So I described that all the questions ligament they are asked. So this is our diagrammatic presentation. You can see here, NEET PG 2020-22. Fine. This is our vertebra, means it is back. Can you see the kidney? Yes, this is stomach. Here you can observe the liver. So you can see this ligament is at the front attached with the anteroabdominal wall. So you will say, sir, this is our falciform ligament. I don't know exactly on the recall basis the arrow was where, but here in this image, whatever the arrow you have to focus, whatever the situation, according to that you have to answer. Yes, here arrow is between the liver and stomach. So this is your what? This is your, yes, hepatorenal. I think arrow had been displaced because actual answer was the falciform ligament, but in this image arrow is displaced. Okay, so this is our, yes, nothing, it is our laser omentum. Now you can see the kidney, and here you will see the spleen. So you can see this ligament, this will be our Gastrosplenic ligament, and definitely at the back side you will see the lino-renal ligament. In this question, actually the arrow was over the falciform ligament, so we are improving the arrow direction. When I was making the notes MS Word format, the arrow had been shifted, actually falciform ligament. Otherwise, in the option, if laser momentum will be given, you can mark it. Okay, so we are changing the arrow. Fine. Yes, hepatogastric also you can say. Now can you see there is a 34-year-old male with the fever? Yes, on palpation spleen was 15 cm directed obliquely when measured from the right iliac fossa. Which of the following structure prevent the vertical and downward descent of the spleen? So you know, here there is a phrenicocholic ligament which make the direction due to which spleen is not growing directly downside, it is growing obliquely. So answer is phrenicocholic. So ligament is going to ask in your next exam. Yes, a tumor of the uncinate process of the pancreas affects which of the following vessel? So remember, this is actually surgery related question. There is our pancreas, and you all are, hope you all are aware that the superior mesenteric vein and superior mesenteric artery, they are passing from here. Yes, it is passing from here. You all are aware that splenic vein is coming from the back, superior mesenteric vein is coming from the back. Both are uniting and making the portal vein, which is dividing into the right and left division. So in front of the uncinate process, remember which vessels are passing? Sir, superior mesenteric vessels, superior mesenteric vessels. Okay, so answer correct, you all are correct, Dr. Reformer Dash. Okay, now there is a blood supply of the stomach. Common hepatic artery, it is impairing which artery? So common hepatic artery, it will go, I will tell you the blood supply of the stomach. Okay, so there it is giving the our gastroduodenal artery and the proper the hepatic artery. Fine. So you will see the blockage of the different arteries. Okay, so you can observe here this one. Can you see? This is our celiac trunk. It is giving the left gastric artery. Yes, it is giving the our common hepatic artery. It is giving the our, yes, zigzag artery, splenic artery. Can you see the common hepatic artery? It is dividing into the proper hepatic and our gastroduodenal artery. So in the surgery, this question had been asked. If there is a blockage in this gastroduodenal artery, yes, then if you will block, then duodenal ulcer can be cured, and it is giving the our superior pancreatic duodenal and our right gastroepiploic. So with this diagrammatic presentation, you can remember that all the different things. Fine. So ligation of the common hepatic artery will impair blood supply. So answer is our, yes, you can say the right gastroepiploic. Yes sir, getting the point? Right side gastroepiploic, it will be affected, as well as right gastric artery, both. Fine. Now there is the our one more question. All of the following structure derived from the aponesis of the external oblique. So remember, external oblique, it is giving origin to the LIP. L for lacunar ligament, I for inguinal ligament, and P for pectineal ligament. Lip you can remember, IPL you can remember. So you can see there is linear similarity. No, it is not the answer. It is not derivative. Okay, so you can mark. Answer is written also here. Fine. So these are the different questions from the lower limb part. Yes, anterior abdominal wall, you must see what are the different abdominal muscles, because on the basis of it you can solve the surgery question, the inguinal hernia. Okay, so I told you this peritoneum will be asked. Yes, one more thing, see here, this is important, epiploic foramen. Can you see? This is our stomach. Yes, here is liver. So along the laser curvature, yes, you all know this is our laser omentum, and along the greater curvature, here is the greater omentum. Fine. I told you, in front of the stomach, greater sac, behind the stomach, laser sac. So you are inserting the finger from the greater sac to the laser sac, and here is one small foramen. What is this? Sir, this is foramen of Winslow. So this is the site of the foramen of Winslow. Fine. This procedure is known as Pringle's maneuver, which you will learn in surgery for the hepatobiliary surgery. Okay. So catch this point. Along this our laser omentum, can you see the green color, red color? Yes, the vein artery duct. The hepatic, yes, remember what are the vein? Portal vein, hepatic artery and bile duct, they are located. So if you have to compress this structure, you can insert the finger in the foramen of Winslow and you can press. So this is the clinical use, that's why it is asked. Yes, what are the different boundaries? You can use the surgery knowledge. Superior boundary is formed by what? Sir, liver. Yes, entry boundary front side, it is formed by the vein artery duct, free margin of the laser omentum. This stomach is continuing as the our duodenum. First part of the duodenum, second part of the duodenum, third part of the duodenum. So inferior boundary is formed by the our, yes, first part of the duodenum. Posterior boundary is not so simple. Surgery. Okay. So with the help of the surgery, you can make strong your anatomy. Anatomy is difficult, but when you are using the concept, your surgery will be also strong, anatomy also. Now remember one thing. This first part of the duodenum add the L1. Second part of the duodenum add the L2 and third part of the duodenum add the L3. So there was a question, this foramen of Winslow at which level? Sir, above the L1. So you will say T12. Agree? So easy. So these are your different question. When you will do transverse section, so you will see the posterior boundary. You can remember that there is our S, I, T, T12. So what are the posterior boundaries? Sit, suprarenal gland, inferior vena cava, T12. And this is our free margin of the laser omentum, where you can see the hepatic artery, where you can see the portal vein and the bile duct. Getting the point? Yes. Now compare it. If there is a portal hypertension, if it is getting enlarged, so it is just converging, it is just changing into the Mickey Mouse like appearance. Yes. So portal hypertension, radiology integration. Actually, I taught this all the things in 2018, and immediately in that exam, this question had been asked in radiology. Okay, so that beautiful integration, can you see? There is our face of the portal vein, and you can see the Mickey Mouse like appearance in case of the portal hypertension. Ultrasonography, this is the your USG finding. Don't forget it. Mickey Mouse sign is visible at the many part. One of them portal hypertension. Yes, you can integrate with the epiploic foramen. You can integrate with the our, yes, Pringles maneuver. Getting the point? Yes, Dr. Disha, correct. These are the different points which you can revise. I told you these points D1, D2, D3. Remember the structures having the 25 centimeter length. So what are the structures having the 25 centimeter length? D, U, D, E, S. D for duodenum, U for ureter, D for descending colon, E for esophagus, S for stomach. Okay. Now see here, we are looking for the our branches of the abdominal aorta. So you can observe it is having the appearance just like the our Bahubali. Yes, see here, eyes, nose, mouth and ear of the Bahubali. This scene is just same like the archery scene. Okay, it is beautiful memes over the your social media. Okay, this is the upper limb of the Bahubali. Here is the nipple of the Bahubali, umbilicus of the Bahubali, and yes, here is the lower limb. So one funny way. Now look here for the more things. Yes, what are the different branches? Ventral branches, you can remember with that image, celiac trunk, superior artery and inferior artery. Remember, celiac trunk is located where? Sir, this is our celiac trunk in between the T12 L1, superior artery L1, and here is the inferior mesenteric artery L3. MCQ. Yes. Lateral branches, you can remember the mnemonic IMRT, Imrati, the brother of the jalebi. I for inferior phrenic, M for middle suprarenal, R for renal artery, and T for testicular or gonadal artery. Also you can say ovarian artery. Terminal branches, yes, two common iliac artery you can remember. Yes, the aorta is dividing at the L4 L5 junction into the two common iliac artery. And dorsal branches, yes, median sacral is one single. So these are the points. Now we can remember our branches from the internal iliac artery. Yes, internal iliac artery, it is dividing into the anterior division and posterior division. What are the different points? The posterior division, yes, you can remember the mnemonic I love Salman. Yes, I love Salman Bhoi. He is most respectful person of this our India. Okay, but one student was recalling the Sunny Leone, so we had put one mnemonic for the Sunny Leone also. So you can do I love Sunny, Sonakshi, Salman, Shahrukh, whatever. Okay, so what are the branches from the posterior division? This will give the branch to the posterior side. Yes, I for iliolumbar artery, L for lateral sacral artery, and S for superior gluteal artery. These all are on the back side. Internal iliac artery, posterior division, complete. Anterior division, remember this all will supply the pelvic organ. What are the pelvic organ? Sir, urinary bladder, Sir, uterus and vagina. Sir, rectum and anal canal. So remember, the anterior division is supplying the urinary bladder. What are the arteries for the urinary bladder? You can easily remember the superior vesicle and inferior vesicle. But in female, there is the no penile urethra part, so it is very short. So in female, inferior vesicle is absent. Now in female, there is a uterus and vagina. Remember, obs-gynae integration, no excuse. Uterine artery, vaginal artery, these are branch of anterior division of internal iliac artery. Don't forget it. Okay. But uterus and vagina, they are absent in the male. So definitely these are not found in the male. And then there is the rectum. So rectum is supplied by what? Remember, yes, superior rectal artery, middle rectal artery, inferior rectal artery. Remember, this superior rectal artery is the branch of the inferior mesenteric artery, and our inferior rectal artery, yes, it is the branch of the internal pudendal, which is the branch from our anterior division. So this is all the points which you can revise. Now pelvis and perineum, you can see what are the question. Can you solve this question? Obs-gynae integration, NEET PG 2021. Yes. Yes, so Harshavardhan is saying extremely refreshing way of teaching. Thank you. Okay, ovarian artery. Yes, it is the gonadal artery. Testicular artery is replaced by the ovarian artery. It is a lateral branch. Yes, getting the point, better. It is the lateral branch. Yes, Dr. Reformer, it is the lateral branch. Fine. Of the abdominal aorta. Okay, now, primary gravida female. After delivery, continued bleeding from the uterus. Patient taken OT, plan for the uterine devascularization, mark the correct order of the devascularization. So what you can tell? Yes. Definitely. You will block, you will ligate the uterine artery. But sir, everywhere is the uterine artery. Now, if it is not successful, then what you will do? Yes. Now, what you will do? Fine. You will block. Remember, uterus is also supplied by the ovarian artery. Na? Sir, lateral 1/3 part of the uterine tube, it is supplied by the ovarian artery. Fine. So, ovarian artery. So, don't mark this one. C and D is better. Now, internal iliac artery, external. Why you will block this external iliac artery? No need. Femoral artery, why? So, definitely your answer is C. Fine. So, this is the way. One question from the prostate gland, because BPH is common. Prostate carcinoma is the one of the most common cancer in the males. So, I will teach you the uvula vesicae is formed by our median lobe. So, these are the few questions, remaining questions related with the surgery and the obs-gynae they will ask. So, just see here, this is our lithotomy position. I am showing you the 3-dimensional orientation. See here. Can you see the hip bone? This is our lithotomy position. So, boundaries of the perineum, anteriorly pubic bone, laterally ischial tuberosity, posteriorly sacrum and the coccyx. Fine. So, one diagrammatic presentation. See here. Yes. Can you see the diagrammatic presentation? This is our perineum. Yes, sir. Anterior boundary is formed by, everything is written in the notes. Yes, anterior boundary, pubic symphysis. Anterolaterally, ischiopubic rami. Laterally by the ischial tuberosity. Posterolaterally by the ligament between the sacrum and the ischial tuberosity. So, this is your, yes, sacrotuberous ligament, and this is our posterior boundary, sacrum and the coccyx. Yes, you will see the 3 opening, 1, 2, 3. The front opening, urethra, then vagina, and posterior is anus. Can you see the perineal body, which is the central tendon of our perineum? 10 muscles are getting attached. Now, draw one imaginary line. It is dividing the perineum into the anterior triangle and the posterior triangle. The anterior triangle, here is the urethra and the vagina opening. So, it is also known as the urogenital triangle. And here is the posteriorly only one canal, anal canal. Yes. So, this is known as the anal triangle. Remember, obs-gynae integration, do episiotomy on the posterolateral side. Never do on the back side. If you are doing the back side, central tendon of the perineum is getting damaged. So, 10 muscles are getting injured, and that's why there is a prolapse of the uterus. Yes. Obs-gynae integration you have to do. Can you see? This is our pelvic cavity. So, different muscles are visible. So, when you are observing the pelvic cavity, you can see the urethra, behind the urethra vagina, and then anal canal. Now, the muscle fibers are taking origin from the pubic symphysis and getting attached to the coccyx. What should be the name? Sir, pubic symphysis to the coccyx. Pubococcygeus, simple. Yes, there is our hip bone, ilium. So, ilium bone to the muscle, our coccyx part. So, this is ilium to the coccyx. Ileococcygeus. Remember these two muscles combinedly known as the levator ani. Sir, why it is known as the levator ani? Because when you are cutting the transverse section, do imagination if you are cutting from right to left side. So this is our hip bone. Agree, sir. Here is our rectum anal canal. So this levator ani, it is slopy muscle. It is slopy muscle. Use the physics vector. Yes, when it will contract, yes sir, it will elevate the anus. Because it will elevate the anus, that's why it is levator ani. Yes, this levator ani is meeting with one more muscle. Can you see? There is our coccygeus. One muscle which is attached with the ischial spine and the coccyx. So this is the ischio-coccygeus or the coccygeus. So this coccygeus plus levator ani is known as pelvic diaphragm. There are the total 8 diaphragm in our body, and diaphragm is important topic. One diaphragm is short asked. Okay, so pelvic diaphragm, it had been asked many times. So remember, whatever the slopy muscle, close the eye and say, sir, this is the levator ani, this is our pelvic diaphragm. Okay, so hope you are getting the point. Now try to understand. We are going to look for the our urethra, prostate gland. One question from this point. Okay. Yes, thank you, Animesh. Thank you for your so beautiful words. Yes. So we are continuing. See here, we are looking for the our male side penis. So there is the penis, then scrotum, and then anal canal. Getting the point? So try to catch this point. There is the fascia in our penis part. So this is our buccal fascia. MCQ. In our scrotum, you will see there is our dartos muscle. Yes, sir, dartos muscle. And in our perineum part, there is our collis fascia. The best mnemonic. Yes, what are the different fascia at the perineum region? Yes, your answer is the BD Chaurasia, sir. The most respectful person on this earth for we all the anatomists. Yes, our HOD sir, Dr. C.K. Shukla sir, and another is the BD Chaurasia sir. Yes, more respectful person than the Grey's Anatomy. Okay, so what I want to tell you, before you can remember, this is our buccal fascia in the penis. Yes, D for dartos muscle. Yes, it is found in our scrotum, and C for collis fascia at the backside. BD Chaurasia is your mnemonic. Now try to understand. Here is our perineal body. Yes, this is our urinary bladder, and here you can see the urethra. Yes, sir. Fine. So you can see one membrane. This is urogenital diaphragm, which is the perineal membrane. Earlier, there was a separate concept. There was a superior layer of the urogenital diaphragm, inferior layer of the urogenital diaphragm. But recent edition, they are not considering these things. They are saying this urogenital diaphragm is the perineal membrane. Yes, perineal membrane and urogenital diaphragm both are same. Now see, when you will do operation, then this space is coming first. So this is superficial. It is in the perineum. So perineal, it is a space. That's why space or pouch. So this below the perineal membrane, this entire part is superficial perineal pouch. Above to it, this part is our deep perineal pouch. Agree? Simple. Now look here. The urethra is passing through the prostate gland. Sir, this is our prostatic urethra. Then it is passing through the perineal membrane. Sir, it is membranous urethra. Then it is dilating, making bulb-like structure, bulbar urethra. And then it is passing through the penis. So this is our penile urethra. Everybody agree? Now try to understand if there is the injury, surgery. Genitourinary surgery, sure one question from the your urethral rupture. Everywhere. Any year you are taking the question paper, you will get. So when there is the put, there is the rotation, there is the hitting of the perineum region with the our such kind of phenomena. Yes, you will see the urethral injury. When there is the urethral injury above the perineal membrane, the urine will go in the deep perineal pouch. If there is the injury below to it, it will accumulate in the superficial perineal pouch. Agree? Fine. Now, this is the diagrammatic presentation. Yes, if rupture below, then it is accumulating in the perineum, around the scrotum, around the penis. Even sometimes it will go up to the clavicle. And you will see if there is a rupture, then above the perineal membrane, it is getting accumulation within the perineal cavity. You must do comparison with the radiology. So anatomy, surgery and radiology integration. Can you see this is our penile urethra. The most dilated part is the bulbar urethra. The narrow part is our membranous urethra, and definitely then prostatic urethra, and this will be the urinary bladder. Agree everybody? Fine? Getting the point? So these are the different things. Yes, see here, we are cutting the prostate gland. You are looking the lateral side view. So this is anterior lobe, posterior lobe. This is median lobe. Yes, sir, it is our median lobe. This median lobe will push the prostatic urethra and it will produce the vesicle, uvula vesicle. You can see the ductus deferens and the seminal vesicle both are uniting and making the ejaculatory duct. Yes, it is opening into the prostatic utricle. Which structure is known as the uterus in the male? You know, males are also having the uterus. Yes, this prostatic utricle is the male uterus. It is a remnant of what? Yes, paramesonephric duct, which makes the female genital tract, but it remains rudimentary in the males. So it is making the prostatic utricle important. Fine. Now you can see this one. This is the transverse section of the prostate BPH or your prostate carcinoma. Sure, one question. So there is our anterior lobe, posterior lobe, right lobe, and our left lobe. Getting the point? Now look here, there is our median lobe. It is pushing the prostatic urethra, so it is converting into the semi-lunar shape. Yes, students, you are right, but a manhole bulbar injury. Getting the point? So what you have to remember, yes, this is our question from the NEET 2021. Getting the point, beta? Yes, remember this is the our median lobe. Yes, sir, this is our median lobe, which is making the uvula vesicle. What is the uvula vesicle? You can see here, okay? Yes, thank you. So Sachin is saying, इतना प्यारा anatomy किसी ने नहीं पढ़ाया. Yes, thank you, beta. This is resonance. Actually, what is happening? Your first MBBS teacher, they are also teaching. Okay, many teachers are there. We all are teaching, but there is a resonance. Resonance. Every teacher is best. Your first MBBS teachers are also best. Your department is also best. There is a resonance. You are catching my words. You are catching my style. So I am becoming best for you, and you are becoming best for me. Every student and every teacher is best. Few other students, they will catch other teacher, so that other teacher is also best, that other student is also best. So everybody is best. Just get your resonance, your tuning is where. Okay, so thank you very much for your so beautiful words. Thank you, Sachin. Thank you. I will remember. Sachin appreciated so nicely. Okay, so thank you, beta. Now, yes, Dr. Ashok, thank you, beta. Thank you. Everyone is the best. Randhir, yes, because of you, all the students, my energy level is high. Okay, so thank you very much. See here, prostate gland, when we are cutting, then you will see there is the one spindle shaped elevation, urethral crest, aggressor. Now at the midline you will see the prostatic utricle, which is considered as the female uterus. Okay, yes, it is the female uterus. In male it is rudimentary. Yes, it is male uterus, better to say. Then you can see the ejaculatory duct. Yes, sir, here is our prostatic sinus, where the opening of the prostatic duct. This elevation at the midline, yes, at the uvula vesicle, you will see this, all the things. Now look here, sir, this is the prostatic urethra. There is presence of internal urethral sphincter. Yes, sir, it is involuntary. While here is our external urethral sphincter. We are coming to the surgery. Yes, sir. Getting the point? So what you have to remember, yes, external urethral sphincter, this is skeletal muscle. Getting the point? Yes, Akash, thank you so much. So Akash is saying Dr. Govind Rai Garg of anatomy. So thank you. So I am getting so nice respect. I'm not, I never thought that Garg sir is also my teacher. When we were at the undergraduate, we were learning from his book. So beautiful words. This is the best comment from you all the students. Thank you very much, beta. Okay, so ek shairi. So Smith is saying for the shairi. So any kind of the shairi, yes. So just few lines, okay. So just few lines. रहने दे आसमां जमी की तलाश कर. होता क्या है लाइफ में, we are always flying here and there and we desire too much. रहने दे आसमां जमी की तलाश कर, सब कुछ यही है कहीं और नहीं तलाश कर. हर आरज़ू पूरी हो तो जीने का क्या मजा है. हम सोचते हैं कि मैं जो भी चाहूं वो मैं पाऊं, सारी दुनिया, समथिंग लाइक दैट. ओके, सो रिमेंबर, हर आरज़ू पूरी हो तो जीने का क्या मजा है. जीने के लिए कम से कम एक कमी की तलाश कर. रिमेंबर बेटा, हर किसी की लाइफ में कोई ना कोई कमी होती है और उस कमी को पाने के लिए वो जानो पूरे शिद्दत से बढ़ जाता है, बहुत मेहनत करता है और इस कारण उसकी जिंदगी की एक कहानी होती है. यस, माई लाइफ स्टोरी इज द सेम. आई वॉन्ट टू टीच पैशन फॉर द टीचिंग एंड यस फॉर इट आई एम रनिंग एंड आई एम वेरी थैंकफुल फॉर द Cerebellum Academy. Okay, yes beta, medicos thing we will share the annotated file, don't worry for it. Okay, yes. So we are moving for the next. So you can see here there is our external urethral sphincter, which is skeletal muscle. Yes, it is voluntary. Why I'm telling you? See here, BPH and your prostatic carcinoma pathology integration beta. See here, you will observe prostate tumor, two types. Yes sir, there is our benign and there is our malignant. Benign is our BPH, malignant is our carcinoma. Agree everybody? Yes, thank you Himanshu, Ashok, yes, Vanshika, Santini, thank you, Smith is here, yes, Sunil, thank you, Drago, everybody. Yes, we will share beta. So there is the BPH and carcinoma. Now see here, patho. You know, the BPH occurs at the peri-urethral zone, and you will see the slitting of the prostatic urethra. So there is a growth and there is the slitting. So the urine is not getting passed. So one old person, any old person is coming with the frequency, hesitancy and urgency. Agree beta? Okay, getting the point? Yes, Himanshu, thank you beta, love you too. Okay, yes, thank you Bharat. Yes, thanks for your love and respect. Thank you Sachin, thank you, more power to you, thank you beta. Yes, so you can see, कोई भी बूढ़ा आदमी आता है वो कहता है कि रात को बार बार नींद खुलती है. yes, many times there is the for the urination, but when he is going for the urine, no urination means hesitancy, and yes, when there is the pressure, there is the urgent to urine. Okay, getting the point? So this is the frequency, urgency and hesitancy. This is the your BPH. What is your treatment? Yes, integration with the pharmacology. This BPH, you will do the treatment. Yes, there is our alpha receptor. So give the alpha blocker. Yes, phentolamine. Yes, phenoxybenzamine. But sir, these are the non-selective alpha blockers. So give the alpha 1 selective blocker. Alpha 1 selective blocker. Which is the alpha 1 selective blocker? Sir, that is our prazosin. But you know the prazosin is having the first dose effect. So start the prazosin with the low dose and give at the bed time. So patient will eat and yes, he will go fall at the bed. गिरे हुए आदमी को और नहीं गिराया जा सकता. So when he is falling at the bed, now he will not get the orthostatic hypotension. Very important. But yes, then study had been done. There is the alpha 1A receptor. So which is the alpha 1A blocker? Yes, Tom Cruise को ये हुआ था बीमारी BPH to the Tom Cruise. So remember alpha 1A blocker, that is our Tom. Sorry, I'm getting this. My pencil has been discharged. Okay. So just a few minutes, few seconds for the pencil charge. Pencil got discharged. Okay. Yes. So I'm telling you, the tamsulosin is there. Okay, so the best treatment. What is the best treatment, beta? Yes, tell me. What is the best treatment, sir? Tamsulosin what with the 5-alpha reductase inhibitor, which is the, yes, you all know, finasteride. Agree everybody? Fine. So remember. Yes, beta, it is more than sufficient. And if you will focus properly, we are not only covering the anatomy, we are covering the many other subjects also. Okay, more than 15 question, 100 plus topics will be asked from this PDF. But yes, I'm enjoying the teaching session. Sometimes I'm getting more details, so this session is a little bit longer, but hope you will get benefit. But yes, now come to the topic. If BPH is not treated, then with the medical treatment, then you have to perform the surgery. What you are doing? You are going through the penis and then you are cutting the prostate. You are going through the penis. You are going through the urethra. So this is your transurethral resection of prostate, TURP. You know, now try to understand, when you are doing the TURP procedure, sometimes this internal urethral sphincter is getting damaged. Happy birthday हो गया. Okay, so now if it is getting damaged, then you can see the ejaculatory duct is opening here. Yes, ejaculation is downside, but if this internal urethral sphincter is getting damaged, so it will go upside. What is this, sir? This is our retrograde ejaculation. This is the one side effect of the our TERP. Everybody getting the point? Hope you all are catching this point. This is very important. Yes, you have to remember the tamsulosin. You have to remember the 5-alpha reductase inhibitor. This is our, don't forget, this is our, yes, finasteride. So this is definitely what I want to tell you. Breast, thyroid, hernia, sure one question, general surgery. Why breast carcinoma is the most common cancer? Cervical cancer in the female, yes, sure, obs-gynae question. In the similar way, prostate cancer is one of the most hot topic. Either the BPH, 70% of the males, they are getting the BPH at the age of the 70 years. It is very common. So get ready. Prostate, one question, sure shot. Agree with me? Fine? Yes, 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 TERP syndrome, this all the things. Now try to understand. Yes, more things, yes, Dr. Aziz, more things you will see in your surgery beta. Okay, now see one more thing. You are observing there is the bladder, there is the rectum, so the peritoneum is coming and it is making one pouch between the bladder and rectum. What is the nomenclature, sir? This is between rectum and the bladder, so this is our rectovesical pouch. Yes, sir, it is our rectovesical pouch. It is the most dependent part in male in the erect posture. Pus collection is there. So what you will do, sir, we will make a puncture, then we will aspire the pus, then we will inject the antibiotic, and then we will re-aspire. It is just like the hydatid cyst like treatment. It is not the pair procedure, but just one similar kind of the procedure. Okay, now in the female, sir, in between the bladder and the rectum, sir, there is the uterus and the vagina. Yes, so peritoneum fold is coming. It is making the our two different pouch. Yes, sir. Between the rectum and the uterus, there is the rectouterine pouch, and between the bladder and the uterus, there is our uterovesical pouch. Which is more lower, sir? This rectouterine pouch is more lower. This was studied by the Douglas. That's a pouch of Douglas. Yes. So this is the most dependent part. Very important. Now, obs-gynae. Yes, if there is the pus collection, then you will go through the pervaginal. Don't go through the perrectal, because pervaginal is more easier. So you will puncture, then you will aspire, then you will inject the antibiotic, and if needed, yes, re-aspire. Getting the point? Yes. So this is our urine. Yes, definitely, beta. Yes, Prabhuraj, just only remove the PYQ and you can leave the ganglion topic. Few more detailed topics for the FMG. Yes, 80% of the same content, but 20% I'm teaching extra also. Okay, fine. You can go at my YouTube channel. There is a bullet train anatomy for the FMG 3 hours session. You can cover there. Okay, fine. So yes, thank you, MD. Yes, colpotomy MCQ wala, you are right, beta. Yes, can you see? In standing position, the pus is in the pouch of Douglas, but when sleeping, it is going back. So it is accumulating behind the liver. Yes, it is accumulating in front of the kidney. So this is hepatorenal pouch. Remember, this hepatorenal pouch is nothing. It is the Morrison pouch. So this is the most dependent part in lying down position. Again, I want to tell you, daughter never creates problem, son creates problem. Jacobson will create the problem, Morrison will create the problem. Yes, your Wilson, Parkinson, Simpson, this all will create the problem. Yes, the biggest problem, Harrison. The biggest problem, your Davidson. Okay, so one funny thing. Now, yes, Dr. Ankit, you are right, beta. Now, the few points regarding the thorax. Only one thing from the thorax you have to see, that is a coronary circulation. Agree, beta? So try to understand. All of the following are true about the right coronary artery except. Fine. So right coronary artery, I will teach you. This is never giving. Yes, it is. All of the following are true. It is asking for the true. Its diameter is less than the left coronary artery. No, right coronary artery is bigger. It arises from the anterior aortic sinus. Yes, it arises from it. It gives rise to the circumflex coronary artery. No, it never gives the circumflex artery. My iPad and the pencils, they are getting low energy down, but due to all of you, my energy is not getting down, but my energy is increasing. Okay, and right coronal artery is its first branch. So these are the different points. Yes, remember the best answer is our anterior aortic sinus. So let's start our intercostal space. So the space between the two ribs, intercostal space, we are cutting and we are enlarging. So can you see there is an external intercostal, it is making the 90-degree with the internal intercostal, and this is the innermost intercostalis. What are the sequence? You can see the VAN, van is there. Getting the point? So what is the utility? See here, when you are performing the thoracocentesis, they never damage this van. That's why always do thoracocentesis just at the upper border. But if you are performing the intercostal nerve block, only then you have to do it. In FMG exam, one time question had been asked, which is not having this van relation? Remember, first intercostal space, it is not having the van relation. Also the popliteal fossa. Agree? So now try to understand. Yes, except I told you better, except first everything is written here, na? Everything is written except the first intercostal space, also, or yes, here except the first intercostal space, also our popliteal fossa. Okay, now see here, we are looking for this trachea. Yes, trachea is coming, and add the carina. Yes, she is mother of Taimur, Karina. Yes, it is not the Karina Kapoor, it is Karina. It is having the cuff receptor. So the cuff receptors, they are getting activation here. So there is our right and left bronchus. Then it is our primary bronchus, then secondary bronchus, and then it is dividing into tertiary bronchus. What is the exact sequence? Yes, you can remember from here. For the respiratory medicine, trachea, it is dividing into the primary, secondary, and then tertiary. Yes, there is a principal bronchus. Secondary is also known as the lobar bronchus, and tertiary is also known as the segmental bronchus. MCQ. The bronchopulmonary segment, it is supplied by water. The bronchopulmonary segment is supplied by the segmental bronchus. Then it is dividing into terminal bronchiole, then respiratory bronchiole. Now physiology starts. The respiratory unit starts from this respiratory bronchiole. Okay, so let's see. There are our two lungs. We know there is the right lung, which is having the oblique fissure, horizontal fissure. So there is the upper lobe, middle lobe, lower lobe. Agree, sir? Yes, in the left side there is the cardiac notch. There is our lingula. Yes, only the oblique fissure. Now you can divide each lung into the bronchopulmonary segment. Yes, lung carcinoma is the most common carcinoma in world among all. Okay, whatever now, if any update, you can go with it. So now if there is the cancer of this lobe, so only cut this lobe. Why you are removing entire part? Anatomy is saying each bronchopulmonary segment is independently, anatomically independent area, physiological independent area, and surgical independent area. Anatomy is independent from the other, function is independent, and if you will cut this segment, there is no effect on the other segment. So this knowledge help in pulmonary resection. Okay, so just draw one Y and then draw one vertical line. So upper lobe is having the apical, anterior, and the posterior, 3 bronchopulmonary segment. Yes, middle lobe is having the medial and lateral, 2 bronchopulmonary segment. And this our basal part, it is having the apical basal, anterior basal, lateral basal, posterior basal. Medial basal is not visible because we are looking from the lateral side. In the similar way, left lung, same. Oblique fissure is only there. So there is the apical, anterior, posterior, superior lingular and inferior lingular because there is a lingula. And basal part, it is having the same. So remember the question, right lung and left lung, they are having the 10 by 10. But again, I want to tell you, the Gray's Anatomy 41st and 42nd edition, they are saying, yes, these books are saying, sometimes in the left lung, 9 bronchopulmonary segment, even sometimes 8 maybe, but the best answer is 10 by 10. Agree? Few MCQ, which lung is most commonly infected? Remember, sir, right lung. In erect posture, which lobe? Sir, basal. But in erect, posterior basal. The most common site of the foreign body, yes, this particular part, this posterior basal, in erect posture. But if you are lying down, then due to the gravity, this apical basal is most common site for the infection. So it will be useful in your respiratory medicine, ENT, foreign body, any structure it is coming. So this is the point which you can remember. Now, yes, forget everything in the our thorax part, but do practice for this our coronary circulation. Getting the point? So try to understand. This is our superior vena cava. Sir, here is our inferior vena cava. This is the right atria. So this is our right ventricle. Can you see ascending aorta, arch of aorta? Yes, just below it, pulmonary trunk. Yes, this is our left ventricle. So this is our entry interventricular artery. Yes, here is our right coronary artery. When you are turning, then you can see there is our superior vena cava, inferior vena cava. So definitely it is our right atria. So this will be the left atria. In the left atria, 1, 2, 3, 4 pulmonary arteries are getting open. Fine. Yes. Sorry, pulmonary veins are getting open, and this is the largest vein of the heart, coronary sinus. Getting the point? So what are the different arteries? Yes, this is the Valentine week. You all know the heart is in this way, but remember, yes, we are doing this, but actually heart is not straight. It is tilted in such a way that 1/3 on the right side, 2/3 on the left side. So just make it tilted. So you can see there are the 4 borders, sir: superior border, inferior border, right border, left border. So controversial question: right border of the heart is formed by right atria only, right border of the heart. But if X-ray is shown, radiology question is there, right border of the cardiac shadow, then you will say superior vena cava, right border, and inferior vena cava. Agree everybody? Fine. And then you can see the base of the heart. So when you are looking at the posterior side, so this is the base of the heart. You will see the right atria and left atria both are making. Left atria is giving the 2/3 contribution, right atria only 1/3. So main answer is the left atria. This is the NEET PG question. Yes, this posterior surface is the left atria. When you do ECG, yes, you are focusing for this base of the heart also. Okay. Now see here, there is our aorta. Sir, ascending aorta, arch of aorta, descending aorta. At the root of the ascending aorta, there is the aortic valve. Yes, sir. There are the 3 cusps in the aortic valve: anterior cusp, left posterior, right posterior. So there is the gap. These gaps are known as sinus. Yes, sir. These gaps are known as the sinus. What I want to tell you again, look here, sir. This is our aortic valve, ascending root, ascending part of our root of the aorta. So you can see this is our anterior cusp, left posterior cusp, and right posterior cusp. So this cavity is the sinus. So remember, right coronary artery, it arises from the anterior aortic sinus, while the left coronary artery, it is arising from the left posterior aortic sinus. From here, nothing is there. MCQ. Fine. yes, MCQ wala, we will share the PDF in our channel. Don't worry for it. Okay, beta. Now here I had drawn the different diagram for your understanding. Just one, give me, kindly keep little patience. I'm telling you so that you can remember, you can never forget. See here, this is the right border, here is the inferior border. Yes, this is the superior border, and this is our left border of the heart. For the diagrammatic presentation, yes, suppose these are our 4 chambers. Agree? Now look here, suppose this is our root of the aorta. At the pericardial surface, it is appearing not exactly at the left ventricle. Ascending aorta, arch of aorta, and this is descending aorta. Agree everybody? Now I told you that there is our anterior aortic valve and 2 other aortic valves. Fine. Now one by one. Right coronary artery, listen carefully. It is arising from the anterior aortic sinus. Then it is running into the in between right atria and the right ventricle. Then it is winding backside and it is reaching to the posterior interventricular sulcus. And here it is giving the posterior interventricular artery. Yes, at the margin it is giving the marginal artery also. These are the 3 main branches. What are the 3 main branches? You can remember with the mnemonic. This is marginal branch, this is transverse artery, and this is the posterior interventricular artery. So your branches, right coronary artery, there are the 3 major branches. You can remember the mnemonic MTP. Yes, what is the MTP? You can remember M for marginal branch, T for transverse branch, P for posterior interventricular artery. Remember this PYQs, it decides the cardiac dominance. Important, it decides the cardiac dominance. Remember, the 90% people we are with the right cardiac dominance, while the 10% people we are having the only the left cardiac dominance. Getting the point? This is the main artery which is dividing, which is deciding the cardiac dominance. If it is the branch of the right coronary artery, right cardiac dominance. If PYQs is the branch of the left coronary artery, left cardiac dominance. Getting the point? So these are our different things which you can remember. Now there are the small branches also. Yes, one branch, right conus artery. When this right conus artery directly arises from the our anterior aortic sinus, then it is known as third coronary artery. Update. Third coronary artery, remember this is our right conus artery when it directly arises from the anterior aortic sinus aorta. Agree everybody? Fine. Okay. यस यस थैंक यू जीतू। अभी आपको पढ़ने में मजा आ रहा है तो ये मेरे लिए बहुत अच्छी बात है, मेरे लिए बहुत खुशी की बात है कि आप सभी बच्चों को मजा आ रहा है। ओके यस सी हियर बेटा ऑरिकल, दिस इज ऑरिकल, muscular projection is the auricle. Atria means cavity, chamber. So there is the one cavity, this is atria, but from this atria one muscular projection, this is auricle. Atria is cavity, auricle is the part of the atria, muscular projection. This is atria and this is the auricle. My face is atria, this is auricle. Agree beta? Okay fine. So we are looking for our more branches. Remember there are the various small atrial branches, ventricular branches, but one branch is going and it is supplying the SA node. Remember this is our SA nodal branch. Getting the point beta? Yes, it is our SA nodal branch. Remember SA node is supplied by, recent textbook they are saying the 60% na, by right coronary artery, but a 40% it is supplied by left coronary artery. Agree everybody? SA node is supplied by the right coronary artery, it is a SA nodal branch. But sometimes 40%, few books will mention, old edition will mention 35% that is supplied by the left coronary artery. Agree? Now we are looking the left coronary arteries. Yes, see here, this is our superior border. Yes, we will do the histology. I am ready. I am ready for the embryology. I am ready for the histology. Short, sweet, concise, no, not too much detail. Fine. Hope you all are ready. Yes, if you all are ready, just give me the thumbs up, just give me the clapping. Yes, yes, yes. Do the dancing movement. Enjoy the session. Yes, enjoy the study. If you want to get extra, you have to do extra. If you want to bleed less in the war, then you have to sweat more in the practice. Agree, beta? I am ready. Please tell me if you all are ready. Okay. Now try to understand. Nothing. Thank you, Niksha. Yes. AV node, beta. It is supplied by the our. Yes. See here, it is also having the branch. I'm telling you, just to, we are completing it. Then see here, this is our heart. Again, you can see here the branches. Again, what is the story, sir? There is the our aorta. Yes. This is. Yes, Anamika, what is my secret of energy? You all the students, when you all the students appreciate, you give the positive words, that is the best prize for me. Okay, not only for me, but for all the teachers. Yes, when the students are appreciating, fine. So what you can remember, see here, there is our ascending aorta, arch of aorta, and there is our descending aorta. Getting the point? Again, there is our anterior valve and two posterior valve. Hope you all are having the clear concept for this valve. So left coronary artery, sir, left coronary artery is arising from the our left posterior sinus. First MCQ. Immediately it is dividing into the left circumflex artery, and another artery is running in anterior interventricular groove. It is running from the front, and it is supplying the apex of the heart. Pathology MCQ, very important. Yes, MI. There is the image in the Robbins. This area is showing pale. It is supplied by this anterior interventricular artery, which will anastomose with the paiva. This artery is winding backside, and it is anastomose with the transverse artery. And there is one artery which is running diagonal like. Yes, see here. Suppose this is our quadrant, and this artery is running like the diagonal. कर्ण की तरह ये जा रहा है, इसलिए इसको हम क्या बोलते हैं? डायगोनल आर्टरी. गेटिंग द पॉइंट? फाइन. सो व्हाट आई वांट टू टेल यू, दीज आर आवर डिफरेंट ब्रांचेस. सर, this is our anterior interventricular artery. Yes, you can see this is our diagonal artery, and here is left circumflex artery. So you can remember one mnemonic DAL. Okay, so I was teaching at a very late night. Okay, so at the Penja University. So at that time, yes, I created this mnemonic DL, Dal. Okay, and yes, we were remembering our great country India. So you can remember DL, any song which is dedicated to this Dal. Yes, you can remember. Jahan Dal Dal par sone ki चिड़िया करती है बसेरा, वो भारत देश है मेरा, वो भारत देश है मेरा. Yes, DAL. D for diagonal, A for anteroventricular artery, and L for left circumflex artery. So you can remember the MTP. Fine. For the right coronary artery, you can remember the DAL for the left coronary artery. Everybody getting the point? So now try to understand. Okay, no worry, beta, no worry, fine. So try to understand this, all the things, okay? So these are the our left. Yes, it is giving one branch, that is the our, which artery? Left conus artery. Remember this left conus artery, it anastomose with the our right conus artery. Getting the point? So this anastomosis is making, suppose this is our pulmonary trunk. Yes, sir, it is our pulmonary trunk. So around the pulmonary trunk, right conus and left conus, they are anastomosing together. What I want to tell you, see here, catch this point. This is giving the right conus branch, it is giving the left conus branch. This is our pulmonary trunk. So around the pulmonary trunk, there is the one necklace like structure is formed. This necklace is known as, yes, this is right conus and it is left conus. So it is known as necklace of Vucin. Also you can say annulus Vucin. One update for all of you. Getting the point, beta? Fine. So you have to remember this necklace of Vucin. One update. Yes, he was the he is belonging to Sen family. So just look, Sushmita Sen, brother of the Sushmita Sen, Vucin. You know Tansen, the brother, the family person of the Tansen, yes, Vucin. Anyhow, you have to remember the Vucin is formed by the anastomosis between the right conus and the left conus around the what? Pulmonary trunk. Agree, beta? So this is the one update also for all of you. Every detail is here. Every detail is here. Okay. So now look here, the clinical points which you have to deal. Angina, you have to say MI, ECG, angiography, angioplasty, CABG, MCQ. Now, best artery for the coronary artery bypass grafting, left internal mammillary artery, but also right ulnar and radial artery you can use because the structure, muscles, wall, diameter, they are just like the our coronary arteries. So best answer is left internal mammillary artery which is supplying the breast. And when you are having proper idea for this coronary circulation, you can go properly for this our angiography. Fine. Now try to understand. Yes, Lakshya, we will get the PDF by the Cerebellum Academy. Don't worry for it. Okay. So I think office will be closed right now or whatever. You will get this PDF tomorrow or maybe possible tonight also. Okay. Yes. Now try to understand this. Yes, can you see this image? Yes, sir. This is our internal mammillary artery. Yes, it is coming and it is bypassing. Remember one more additional fact. This entry interventricular artery 40 to 50% MI due to this IVA. Now remember, this IVA is most commonly blocked in the male or female? Sir, male. Why? Because males are not having the estrogen, very less. Females are having the estrogen till the menopause. Your atherosclerosis chapter, risk factor of the atherosclerosis, yes, non-modifiable, modifiable, non-modifiable, age, sex, race, genetic factor family, yes, modifiable factor, major risk factor, minor risk factor. Major risk factor 3H, hypertension, hyperglycemia, hyperlipidemia, and smoking. And minor risk factor, many things are there. Estrogen is the minor risk factor. Yes, estrogen is the preventive factor. So females are having less chances. So who are getting blocked? Sir, males are getting blocked. So when the males are getting blocked, males are getting happy birthday, death. Fine. So females, they becomes widow. So don't forget this question. This entry interventricular artery, which is also known as the LADA. Yes, it is branched from the left coronary artery. It is descending from the entry side. So left entry descending artery. Yes, this left entry descending artery is known as what? Don't forget it. Sir, it is widow's artery. Also is the widowmaker artery. Don't forget it. Okay, fine. So this is the your integration. Now try to understand. We are looking for the our, yes, now I am telling you about the dermatome. Very important, Very important. One question directly or indirectly is will be. Yes, so my respected Dr. Praveen sir is here. Sir, good evening. Okay, sorry that I'm taking so much long session, but I think all the students are enjoying, so I'm also enjoying. So thank you to all the Cerebellum respected faculties, all the my respected teachers. Okay, so we are continuing the dermatome. Try to understand better. Yes, what is a dermatome? See here. Suppose this is skin, and you will see there is our nerve. So this is segment of skin which is known as derma. Getting the point? What is a derma? Derma means skin, and this segment, you know, segment cut section, and cut is known as the tome. So the segment of the skin which is supplied by the single nerve, this is the dermatome. Agree? Fine. What I want to tell you, yes, Judwa movie. Try to understand. You had seen many kind of the movies in which there is the we are giving slap to one brother and the pain is to the another. Same concept. Sure, one question dermatome directly indirectly is going to ask. Try to understand this concept. Suppose this is central canal and this is our spinal cord. Agree, beta? Everybody? Now see here the dorsal root, ventral root making the trunk. Yes, it is giving the dorsal rami and here is the ventral rami. Yes, sir. Now try to understand, this ventral rami is giving the different kind of branches. Yes, it is supplying the skin. And also the few are supplying the our viscera. So it is known as, yes, it is known as, try to catch this point better. This is our, yes, somatic nerve, and the nerve which is supplying the viscera, that will be our simply the visceral nerve. One rule, always remember that somatic nerve, it is painful, very important concept, while the visceral nerve, it is always painless. Agree? Now catch this point. In NEET PG 2019, this question had been asked. Yes, umbilicus is supplied by which nerve? T10. MCQ. Yes, umbilicus is supplied by which nerve? T10. Yes, it is painful. Somatic nerve is painful. But the same nerve, it is giving the visceral branch to the what? Remember, it is giving the branch to the three organs, appendix. Surgery integration. Yes, it is giving the branch to the small intestine. It is giving branch to the gonads. So remember, whenever there is the irritation, whenever there is the disease in this viscera, this nerve root is getting irritation. So these are having the same mother, T10, it is getting irritation, and according to the rule of the projection physiology, this pain is felt at the umbilicus. So the pain of the appendicitis, Crohn's ileitis, and our oophorytis, also you can say orchitis, these are felt at the umbilicus. Dermatome concept. Agree everybody? Fine? Fine? So, yes, thank you everyone. Thank you for your positive words. Yes, Daniel, thank you. So, now we are starting the dermatome. Concentrate. Immediately. Start. Do free your hand. First nerve. Every spinal. You know all the spinal nerves? Yes, sir. There are the C8, T12, L5, S5 and coccyx is in this way. Okay. Fine. So these are the different parts which you can remember. So total 31 pair of the nerves, sir. 8 and 12, this is 20, 5, 5, 10, 20, and this is 1. So total 31 pairs. Fine. So try to understand. C1, no dermatome. Do this one. C1, no dermatome. C2, put the hand at the angle of the mandible. Please concentrate better. Please concentrate. Yes, put the hand at the angle of the mandible. C2, you know, Fraze syndrome, great auricular nerve, auriculotemporal nerve syndrome. Yes. Then C3, put the hand just below the angle of the mandible. C3. Then C4, forefinger below to it. Then C5, yes, above the shoulder. Remember, 3, 4, 5 keeps diaphragm alive. Yes, MCQ, diaphragm nerve supply Phrenic nerve. What you have to remember, sir? Phrenic nerve root value 3, 4, 5 keeps diaphragm alive, just like the jingle, just like the poem. Yes. So where is the dermatome, sir? C3, C4, and C5. Now surgery. This is supraclavicular area. Yes, dermatome is a supraclavicular area. Phrenic nerve is having the same root value. That's why if there is the pain of the gallbladder or the liver, the phrenic nerve is getting irritation, and the phrenic nerve is the visceral nerve, so the pain will not feel here. The pain will be felt at the right tip of shoulder, gallbladder. If you all are getting the point, just give me the thumbs up. Yes, 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 yes. Fine. So what I want to tell you, the pain of the gallbladder, it is felt at the right tip of the shoulder. Why? Because the phrenic nerve and C3, C4, C5, that is supraclavicular nerve, these all are having the same root value. Agree everybody? Now, surgery, Kehr's sign. If there is a splenic rupture, irritation of the diaphragm, the pain will be referred to the left tip of the shoulder. Why? Because the diaphragm is having the root value phrenic nerve. C3, C4, C5, and same root value, 3 finger, 3, 4, and then 5, supraclavicular area. Agree everybody? Fine. This is Kehr's sign. Pain of the spleen is referred to the left tip of the shoulder. Fine, sir. Now, this 5 is coming to the elbow part, C5, then C6. Thumb is C6. C5, C6. Yes, elbow. C5, C6, elbow. So remember the biceps jerk root value C5, C6. हिल्टन लॉ, जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. एग्री एवरीबॉडी? गेटिंग द पॉइंट? फाइन. So try to understand. There is our C5, C6, thumb is C6, then C7, then C8. But remember one rule, dermatome, they are overlapping in nature. There is no Ukraine and Russia border. Here is the Ukraine, here is the Russia. No, these are overlapping. So many textbooks they will say C6, C7, C8. Okay, C7, C8. You know, radial nerve, ulnar nerve, they are having the same root value. Skin is supplied by the same nerve, and the muscles, ulnar nerve, median nerve, they are supplying the muscles. Hilton law. That's why at the beginning of session I told you, keep patience, and the general anatomy, the basic concept will be applicable everywhere. Now, okay, fine. Now, T1, ulnar border of the forearm. T2, ulnar border of the arm. Getting the point? This T2 is supplying the brachium as well as intercostal space. So this is the intercostobrachial nerve. Yes, sir, it is intercostobrachial nerve. MCQ, which nerve is the intercostobrachial nerve? You can observe in this image, this nerve is supplying our intercostal space as well as brachium. So this is our T2. Don't forget it. MCQ. Now, then T3 above the nipple, T4 at the nipple, T5 below the nipple. Getting the point? What I want to tell you, myocardial infarction, angina, pain is referred to the clinical integration. Definitely question is going to ask, am I angina? This is very important. Yes, the pain of the angina, T1, T2, T3 above the nipple, T4 at the nipple, T5 below the nipple. Yes, remember, don't forget it. It is very, very important concept. Agree everybody? Getting the point? Yes, shoulder abduction. When you are doing the shoulder abduction, then there is the root value by the deltoid and supraspinatus. Remember, the deltoid is supplied by the axillary nerve. So C5, C6 is your answer. Getting the point, beta? Fine. Yes. So now try to understand. There is a T5, T6 is Gifford process, T7 inferior angle of the scapula, T7 inferior angle of the scapula. Remember, gallbladder is having the T7 root value. So pain of the gallbladder, gallstone, these all are referred to the right inferior angle of the scapula. Referred pain, anatomy integration with the surgery. Then T7, T8, T9 not important, but T10 is important. Don't forget T10 umbilicus. Umbilicus is supplied by the T10. I told you already. Then there is our T12, yes, L1, L2. Remember, this ilioinguinal region is supplied by the L1. Remember, in inguinal hernia surgery, there is the damage to this part. Ilioinguinal nerve is damaged. Ilioinguinal nerve entrapment syndrome. L1, ilioinguinal nerve is there. Now see L2, L3, L4. What I want to tell you, sir, there is our, yes, L2, L3, and L4. So remember, this is our femoral nerve part. Yes, femoral nerve is having the L2, L3, L4 root value. Yes, we will perform the knee jerk. What is the root value? L2, L3, L4. Yes, this L4 is coming to the medial side. This is the FMG question, na? but it is important. In your exam, there is our which nerve? Yes, the NEET PG and FMG now both are becoming same. Saphenous nerve with the great saphenous vein. And definitely this is our L5. Remember this top part, this is supplied by our deep peroneal nerve. And then there is the number of the S1, definitely sural nerve. Yes, sural nerve is there. S1 root value, MCQ. Agree everybody? Fine. Now turn the person. When you are turning the person, you are looking from the back side. Then you will see the S1 is supplying this skin segment from down to the above. Yes, sir, it is S1. And then can you see S2 is also from down to the above S2. So can you see what is the root value of the ankle jerk? सर एंकल जर्क इज S1 S2 जो नदी जहां रहती है जहां बहती है उस एरिया को सप्लाई करती है एंकल जर्क S1 S2 रूट वैल्यू एग्री एवरीबॉडी फाइन now there is the anal canal yes around it you will see the S3 S4 S5 so there is our anal reflex physiology yes S3 S4 S5 getting the point. So this is the entire dermatome. Okay, we had completed. Yes, you can get this video at my YouTube channel, but this is the bullet train anatomy, so we had done. So this part you can revise from there. Now see here one few question. This is the our part. Deep peroneal nerve is supplying the first wave space. No excuse. Directly question will be asked. Sural nerve is supplying the lateral border of the foot. No excuse. Direct questions are asked. And this is the your NEET PG 2020, 21 and 22. Saphenous nerve is supplying the medial side of the foot. Yes, it is related with which vein? Answer is great saphenous vein. Agree? So dermatome, the question is going to ask. So hope embryology, one thing you have to study, that is our, yes, remember, pharyngeal apparatus. But quick revision of the embryology as well as the histology. So hope you all are ready. Yes, thank you Abhimanyu, thank you beta, thank you so much. Now we are going to look for this our embryology. You all are aware there is the sperm entry, yes, ovulation, so there is the fertilization. Remember at the ampulla, not the ampulo-isthmic junction. Earlier the textbook they were saying the ampulo-isthmic junction, but according to the Larson-Langemann embryology, the best answer is your yes, ampulla. So there is a formation of the zygote, one cell stage, then 2, 4, 8, 16, 32, so on. Okay, so here is the one diagrammatic presentation. Zygote, 1 cell, 2 cell, 4 cell, general embryology 8 cell, and then morula. Morula is the 16 cell stage. M for morula. So which day? Just push the M. When you are pushing the M, then you are getting 3. On the third day it is formed. Now it is sucking the uterine fluid. But one update for all of you, there is a 132 cell stage, but there is the no cavity. So this is advanced morula stage. So there was the one question, advanced, yes, morula is which stage? 8 to 16, 16 to 32. Both are right, but single best answer 16 to 32 according to this new update. Okay, now it is sucking the uterine fluid and it is creating the cyst. So there is the immature cell blast, there is a cavity, so this is the blastocyst. So now try to catch this point. There is the collection of the cell inside. This is our inner cell mass, and outside there are the other cells. Yes, outside cells, so outer cell mass. Remember, the embryo will be formed by this inner cell mass, true embryo, and this our outer cell mass will give nutrition to this embryo. So outer cell mass, it is giving the nutrition. Nutrition means trophy. Hypertrophy, a trophy. Whenever there is a trophy means nutrition to the immature cell trophoblast. In your obs-gyne you will see this trophoblast will convert into the cytotrophoblast and syncytotrophoblast. Okay, come to the our this point. Blastocyst is formed on the next day, after the third day, yes, fourth day. Now look here, sir, there is our outer cell mass, yes sir, there is our inner cell mass, correct sir, yes, inner cell mass, it is becoming columnar and it is making the epiblast. Remember, the first cell of the all the germ cell layer, sabka papa kaun hai? Epiblast. What you have to remember? Yes, sabka papa kaun hai? Epiblast. Every cell, yes, ectoderm, endoderm, mesoderm, all are formed by the epiblast. So remember, so inner cell mass, they are converting into the columnar cell. This is the epiblast. Now it is showing the changes. It is giving one thin plate of the mass. This is hypoblast. Earlier it is squamous, but then it is converted into the cuboidal shape. Yes, it is our endoderm. So what you can say? First germ cell layer, answer is endoderm. There are the certain update. Earlier the answer was the ectoderm, but right now endoderm is answer. Now this endoderm is saying, now I will divide. Yes, epiblast, you had shown 2-minute division. Now I will divide. So you can see this endoderm is creating entire layer inside the our yes cell. So this is our Husser's membrane. Getting the point? The cavity within the Husser's membrane. This is the primitive yolk sac. MCQ. The primitive yolk sac. Yes, remember this primitive yolk sac is creating the cavity of the endoderm. Later, this primitive yolk sac, it forms the GIT. MCQ, GIT is formed by the primitive yolk sac. So remember, the inner epithelial lining of the GIT is coming from the endoderm, and here is our epiblast cell. Getting the point? Now try to understand. epiblast को आया गुस्सा, एंडोडर्म तूने बहुत डिवीजन दिखाया, अब मेरी बारी है. Yes, now this epiblast is showing the division opposite to the endoderm. It is giving one more new cell. This is our amniogenic cell. Yes, it is our amniogenic cell. Remember for your ops gynae that cavity within the amniogenic cell is our amniotic cavity. The cavity of the endoderm is the primitive yolk sac, which will give rise to the GIT. Getting the point? Yes, this amniotic cavity is filled with the amniotic fluid. It will create the first CSF of the body. Amniotic fluid, amniotic cavity. Yes, it will nourish the baby. Now try to understand. We are coming to the our embryology anatomy part. This is the our disc like structure. When you will see the lateral side, you will observe, sir, there is the our epiblast and there is our yes hypoblast. Remember, hypoblast is making the endoderm. Agree. But when you are looking from the upside, then it is looking like the rounded structure. By the side, sir, it is flat. But when you are looking from the upside, sir, it is a rounded structure. This is disc-like. It is having the 2 germ cell layer. So it is our bilaminar disc. Remember, B for bi, stretch it, B, stretch it, 8. So remember, this bilaminar disc is formed on the 8th day. MCQ, okay? So you can remember, okay, morula on the 3rd day, yes, blastocyst on the 4th day, and this bilaminar disc on the 8th day. Anyhow, you can remember. Now, endoderm, this endoderm is getting angry. तो एंडोडर्म को अब आया गुस्सा और वो बनाया एक proliferation of the layer. So try to catch this point. This elevation is plate like structure. Yes, it is the precaudal plate. MCQ, remember, epiblast is making the hypoblast is making the endoderm, and endoderm is making the procaudal plate. MCQ, epiblast is making the procaudal plate. If finally, सबका पापा कौन है? Epiblast, सबका मालिक एक है. Epiblast, remember. Yes, when you are looking the same thing, so due to the procaudal plate, you can see one elevation at one end. MCQ, focus. Yes, what is the importance? Remember, it will divide the head. It will show the head end of the baby. Suppose it is the baby. So it is saying head will develop near to it. Remember, the procaudal plate, it decides the head end of the baby. Yes, opposite to it, there is a development of the lower limb. Now see, yes, this is our procaudal plate. Now there is a turn of the epiblast. Epiblast बोलता है एंडोडर्म बहुत हो गया तेरा डिवीजन, अब मैं डिवीजन दिखाऊंगा. तूने प्रोकाudal plate बनाया. I will make one linear structure. Yes, when you will look this linear structure from above, so it is streak like in appearance. धागे की तरह ये दिखेगा. So you will say, sir, this is our primitive streak. Yes, sir, it is our primitive streak, and here is our procaudal plate. Agree, everybody? So now we are going to cut this portion at this level, XY axis. So when you are cutting, yes, one more question. This is making the midline of the baby. So it is dividing the right and left half of the body. MCQ, right and left side of the body is decided by the primitive streak. It is coming from the epiblast cell. Now we are cutting at the XY axis. Yes, sir. We are cutting at the XY axis. So procaudal plate, it will not be visible. Only this primitive streak will be visible. So you can see there is the our, yes, sir, epiblast. Yes, there is our endoderm. So you can see this all. You can observe the primitive streak at the center, and this is the endoderm. Now there is the turn of the new germ cell layer. From the epiblast, new germ cell layer is arising and it is getting sandwiched. It is getting sandwiched between the endoderm and the epiblast. This is our mesoderm. So MCQ, first germ cell layer, sir, endoderm. Sir, second germ cell layer, sir, mesoderm. Now the remaining germs, yes, epiblast, they are converting into the columnar cell, ectoderm. This is the third germ cell layer. So MCQ, first germ cell layer, endoderm, second germ cell layer, mesoderm, third is the ectoderm. Remember, according to the old editions of the book, the sequence was just opposite, but go with the new edition. Okay, so there is a color coding in the embryology. Blue color means ectoderm, red color means mesoderm, yellow color means endoderm, and in between them there is the many steps, but we are summarizing. There is a one cord like structure is developing. This is our notochord. Yes, remember, in our fully developed part, this notochord disappear except one thing. No excuse. Notochord disappear and it persists only one small structure, nucleus pulposus, which is within the intervertebral disc. Orthopedic integration. Can you see? This is our vertebra. Here is the intervertebral disc. Within this intervertebral disc, there is the one gel-like, one pulp-like structure, nucleus pulposus. It is nothing. It is the remnant of the notochord. It is the remnant of the rotochord. Whenever there is the different disc prolapse, this nucleus pulposus is coming out, compressing the nerve root, and it is causing the radiculopathy. Clinical integration. That's why I forget everything. Why this notochord is asked? Only one thing. It is the remnant of the, yes, it is notochord disappear except nucleus pulposus, which is found within our intervertebral disc. Agree, beta? Fine. Yes, thank you, Vimal, thank you, very nice, Risha. Yes, Ankush. Yes. Remember, I will teach you the cerebellum. I have left the cerebellum. The last topic will be the cerebellum, and that is important. Okay. Now see the CNS development. There is our ectoderm, there is the mesoderm, and there is the endoderm, and here is a notochord. Now try to understand, due to the various cell division activity, this ectoderm is dividing into the plate-like structure and other. This will give rise to our ectoderm will give rise to the CNS. So this is the neuroectoderm. Remaining is our surface ectoderm. Ectoderm is giving the two layers. Now it is making thick structure, neural plate, and then it is showing the depression, neural groove, and then it is showing the tube-like structure, neural tube. Okay, so I am telling you with the one example. What I want to tell you, see here, demo. This is the ectoderm. Agree? This is making the neuroectoderm. Then neural plate. Okay, sir, this is the neural plate. Then neural groove, and then neural tube. Can you see? It is tube-like. But when you will see from the front, yes, exactly, it is tube-like. It is having the anterior neuropore. It is having the posterior neuropore. Again. Yes, beta. Yes. Okay, Alan Soli, we will share, beta. Okay. Yes, there was one my student at the Calicut. Okay, who was always wearing the Alan Soli on his T-shirt. So by looking your name, I am recalling that one. Okay. Yes, we will do it. Okay, so just see here. Yes, this is our what, sir? It is our neural plate, neural groove, neural tube. What you have to remember? CNS development, sir. Ectoderm, neuroectoderm, neural plate, neural groove, neural tube. This neural tube, cranial part will get dilated and it will make the brain. It is here. There is the formation of the brain. And this caudal part is narrow. Getting the point? Yes, it will make our spinal cord. Yes, sir. There is a cranial dilatation brain. Caudal is remaining narrow. Spinal cord. What I want to tell you, there is the opening above, opening below. Anterior neuropore, posterior neuropore. Yes, sir. Neural plate, neural groove, neural tube. Anterior neuropore, posterior neuropore. Remember, anterior neuropore is closed on which day? No excuse, 25th day. Posterior neuropore, 28th day. MCQ. Yes, remember, which vitamin is important? Biochemistry integration, vitamin B9, folic acid. Remember, if B9 is less, then neural tube defect. Pharma integration, medicine integration. Anti-epileptic drug, phenytoin, valproate, carbamazepine, these all are causing the neural tube defect. No excuse. Yes, if you want to prevent this neural tube defect, then what you have to do? You have to give the proper vitamin B9 and the folic acid. And now you have to see in the obs-gynae, what is the dose before the conception, what is the dose after the conception, and what is the dose if there is a previous history of the neural tube defect. Obs-gynae integration. Okay, you have to see. Now look here. This is also the question, neural tube is getting close first at which side? Answer is cervical side. Multiple fusion theory is there, but cervical side is the first answer. Okay, now look here. If anterior neuropore is not fused, then there is the our anencephaly, absence of the cranial vault. And if there is the no posterior, yes, posterior neuropore is not, then you will see the different kind of the defect, like the spina bifida. Try to understand. See here, there is our spinal cord inside, but if not fused, then hair tuft is there, spina bifida. More severity, then you will see spinal cord with the meninges, it is coming out, and it is having the CSF. So it is meninges and it is cavity. So this is the meningocele. Can you see? Next, this is the our different meninges. Spinal cord is coming out with the CSF and nerve. So this is our meninges. This is myelo, and this is the cavity, meningomyelocele. And can you see there is a rupture? So nerve is coming out, CSF is leaking out. So this is the myeloschisis or rachis. Agree? Yes, Anthony, you are right, beta. Fine. Okay, so you have to see the 400 microgram or 4 milligram, and when you have to double the dose, you have to see there. So this is the posterior neuropore defect, no excuse. Okay, now also there are the more things, but right now the question pattern is not asked. That's why just summarizing, the mesoderm, it is dividing into the LIP. Yes, remember your mnemonic is LIP. Yes, LIP. What is this LIP? Mesoderm. Yes, lateral plate mesoderm, I for intermediate mesoderm, and P for paraxial mesoderm. Fine. More things are there, but we are not going there. Okay, just summarizing. Now, one more thing, neural crest cells. Yes, no excuse with this neural crest cell. See here, this is the neural plate. When it is getting depression, yes sir, it is getting depression. Neural plate is getting depression. At that time, the corners are getting elevation. So at this neural plate, there is neural crest cells. Neural, because it is developing from the neural tissue. Crest means elevation, and yes, it is cells. So there is the corner. At the corner, special cells are there, neural crest cells. Getting the point? Yes, sir. These are the neural crest cells. Nowadays, they are considered as the fourth germ cell layer because they are developing very special kind of the structure. What are the different structure? I am giving one list for all of you. But before that, remember, neural crest cells, they are terrorist. जैसे एक आतंकवादी का कोई भरोसा नहीं कि वो कहां जाएगा, कैसे जाएगा. Yes, and he will do his activity at which part, you cannot say. Okay, in the similar way, these neural crest cells, they are migrating in different part of the body and creating very special kind of the structures. Agree? Yes. MCQ had been asked which is helping in the neural crest cell migration. Answer is your yes, hyaluronic acid. Remember the biochemistry integration. Remember this our hyaluronic acid. It is most common mucopolysaccharide. Biochemistry integration. It helps in the neural crest cell migration. So now try to understand, it is migrating within the brain, creating the meninges. It is migrating into the eye, making the sclera and choroid, ophthalmology. It is migrating within the teeth. It is terrorist. Okay? Yes, you cannot explain. Yes, it is making the odontoblast. It is going inside the our skin, making the melanoblast. It is going to the GIT and making the orbic plexus. MCQ, patho, ENT, medicine, surgery. Failure of the neural crest cell migration, it will not create the orbic plexus. So if there is a failure within the colon, Hirschsprung disease, within the esophagus, yes, achalasia cardia, no excuse, very, very important. Now, you will see it is also migrating within the adrenal medulla. Yes, also one update, it is migrating within the pharyngeal apparatus. It is creating the our different connective tissue, thyroid gland, parathyroid, whatever the connective tissue, even the our different all the skull bone, yes, frontal, maxilla, mandible, all are derivative of the neural crest cells. These are the updates. One funny mnemonic, Okay, yes, this is very bad mnemonic, but okay, if it will be helpful, you are able to solve the question, it will be very nice news for me. Yes, this is the BHU University. This is our Madan Mohan Malviya ji, the founder of the BHU. Yes, Mahamana Madan Mohan Malviya ji. So one funny trick, you can remember that our derivative of the neural crest cells, PITs. Yes, bacche, PITs. They are doing disco where in front of the Mahamana Madan Mohan Malvi. I know you will tell me, sir, what is this, what the hell, this kind of the mnemonic, but okay, fine. PITs doing disco in front of the MMM, Mahamana Madan Mohan Malvi. So neural crest cell derivative, all the ganglion, parasympathetic ganglion, yes, anteric plexus, orbic plexus, all the autonomic nerve system ganglion, or the dorsal root ganglion, means ganglion, 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 ganglion means neural crest cell derivative, close the eye and mark the neural crest cell derivative. Also the Schwann cell, D for dentine tissue, odontoblast, S for sclera, C for choroid, and remember the choroid connective tissue of our pharyngeal apparatus, all the glands. Yes, M for melanocyte, M for mesenchymal bone of the head and face, and M for meninges. All are neural crest cell derivative. Agree, everybody? Fine. Now try to understand. We are going to look for our more things. Okay, so we are looking, yes, this see here embryology is two more very much, but don't waste too much time for the embryology and the histology. Just go for the basic points. Fine. We are going to start the hour. Yes. Yes, thank you everybody. I will read your comment tomorrow with the first. You all are writing so beautiful. I'm getting too much emotional. So thank you very much. I will give my 1000% for you all the dear students. Okay, we will do more session. Yes, if you are liking, just give me the positive comment. We will do more and more session at this beautiful platform Cerebellum. Okay, yes, beta. So what I want to tell you, histology, yes, and yes, keep commenting the positive words. I will read everything tomorrow. Okay, but right now my focus is to teach you all. Okay, so just see here histology, see here biochemistry. This is our one cell. Fine, and you can see the nucleus, the basic concept we are looking better. Fine, see here histology, everything is the pink and the blue. Try to understand this pink and blue. Okay, sir, this is the cell. Can you tell me, can you help me? This is your what, sir? This is our nucleus. Can you tell me within the nucleus there is the DNA? Yes or no? DNA is acid or base? Sir, it is acid. So acid will love to base or acid, sir, it will love to the base. So these all are the microscopic structure we cannot observe. We need the, remember, yes sir, we need the stain, coloring agent for the differentiation, and we need the microscope. Agree everybody? So try to understand. There is one our beautiful stain, hematoxylin, which is blue in color, and it is basic stain. So it is binding to the acid. So remember this DNA, this nucleus will appear blue. Agree? So whatever in your histology or the pathology, blue color, close your eye, say, sir, this is the nucleus. Agree? Who is friend in your histology? Remember nucleus. Agree everybody? Fine. If your histology will be strong, your pathology will be easy. Agree? Now try to understand. If you are doing excessive staining, then this blue color can appear black also. So black color, that is nucleus. Now see here, this is, sir, it is cytoplasm. Its pH is near the blood. So what you can remember, its pH is 7.35 near the blood. So yes, it is slightly basic. Fine. Yes, 7.4, slightly basic. So tell me, it will take which kind of the stain? Sir, it will take acidic stain. So remember, there is the one stain, eosin. We show with the E. It is acidic stain. So it will color. Remember, it is red in appearance. So that's why cytoplasm is red. So whatever the pink color you observe, whatever the pink color you observe, that all is your cytoplasm. Agree, beta? Fine. And try to understand. This is our cell membrane. Yes, sir, cell membrane. Yes, yes. So you all are observing that cell membrane is also having the same story. Cell membrane is also made by, yes, you know, PLLP. Biochemistry integration, it is made by the phospholipid bilayer. pH is here. So it is basic. So it will take acidic stain. So simple. So acidic stain, they are red in color. So definitely this cell membrane will also appear pink. Agree everybody? Fine. So now what is the problem? That when you will draw the another cell, sir, this is also pink, and you will see there is another cytoplasm. Yes, it is also pink. So pink color all are getting mixed, but what you can differentiate, sir? You can beautifully differentiate the nucleus. What I want to tell you, whenever you are looking the histology slide, everything will appear pink. You will get too much confusion. But in this pink color, the blue color will highlight. So try to understand. When the nucleus is your friend, when the nucleus is parallel to the basement membrane, you will say flat squamous epithelium. Agree, beta? Now, when the nucleus is very good, beautiful, rounded, then it is our cube-like shell. Agree? But when the nucleus, they are longitudinal, they are making 90 degree to the basement membrane. Close your eyes, say, sir, this is our columnar epithelium. Sometimes there will be the cilia. Can you see? There is a multiple layer, one layer, two layer, but all the cells are attached. Yes, all the cells are attached to the basement membrane. So it is not the stratified, it is not the multiple layer, it is our pseudo stratified layer. Agree? Now you will see there is the multiple layers. Upper layer, if it is showing the nucleus parallel to the basement membrane, then you will say stratified squamous. Who is your friend? Sir, upper layer is your friend. Agree everybody? So now you can see sometimes there is the death of the upper layer and it is showing the pinkish color layer. So this is our keratin. Yes, it is our keratinized stratified squamous epithelium. Yes. So you will see different kind of layer. So let's start now. Confusion starts from, sir, you taught very well, pink, blue, but when the slides will ask in your exam, you will get confusion. Now, apply the knowledge, Yes. Try to understand better. See here, sir, pink color, cytoplasm or cell membrane. Because it is linear, so you can say cell membrane. Can you focus? Yes, black color, blue color, black color, blue color. Don't focus on one nucleus. You have to look everywhere and then you have to decide. See here, the nucleus is parallel to the basement membrane. Few are rounded also. But observe the maximum. These are parallel to the basement membrane. Agree? Sir, this is blank. No color. Blank is our, yes, remember, air or fat. Air will not take any kind of the stain. In fact, when you dip the slide within the acetone or alcohol, yes, it is washed. Yes, fat is washed within the acetone and alcohol, so it is blank. But remember, fat is oil drop, so it will be regular. But you can see here is the margin is irregular. So this is air. It is air, not the fat. Agree, everybody? So what is your concept? Now apply. Where is the flat squamous epithelium? And where is the air? Only one thing in our body, sir, it is lung alveoli. Yes, flat squamous epithelium, they will help in the gaseous exchange. Simple. Okay. Now, here are the difficult kind of the slide. Can you see? Confusion will be created. See here, nucleus. All the cell membrane all are getting merged. But yes, rounded nucleus means your cuboid cells. What is the function? These cells will do synthesis and they will store at the lumen. Yes. Where you will get such kind of the epithelium? You will get in the our secretory cell, thyroid gland. Also in the PCT, DCT, pathology integration, when there is the chronic pyelonephritis, then PCT, DCT, they are having the same appearance. They are secreting the our hyaline-like material inside and thyroid globules are seen. That's why there is a thyroidization. of kidney. This is our patho slide. Remember, your pathology will be strong if your histology anatomy is strong. Anatomy you cannot neglect. Remember the dialogue. Yes, मेरे बच्चों मैंने कहा था ना 18 सब्जेक्ट पढ़ने से पहले एनाटॉमी पढ़ा जाता है. Everywhere you will find the anatomy. Fine. Now try to catch this point. Very bad slide. And yes, remember in exam bad slides will be asked. Okay, so you can see here there is our pink line. Sir, this is our basement membrane. Agree everybody? Yes, it is our basement membrane. Fine. Okay. Yes, beta. Yes, Diksha, don't worry. Siddharth, don't worry. PDF will be available at the Cerebellum platform. Okay. Yes. Now see here, there are our many nucleus. So it is, sir, stratified, but not 8 to 10. Remember, actually all the cells they are joining the our cell membrane, basement membrane. So this is the pseudo stratified. And can you see the beautiful cilia appearance at the top? So this is our ciliated pseudo stratified. Everything is written in the slide. Yes. And you can see the goblet cells which are showing the secretion. Fine. Where it is found? Respiratory tract. When there is a damage to the cilia, yes, that is our Carter-Jenner syndrome, which is found in the bronchiectasis. Yes, State Bank of India. S for situs inversus, B for bronchiectasis, and I for infertility. So this is the clinical integration. Carter-Jenner syndrome, you must remember. Agree, beta? Yes. Now look here, there is the one other confusing side. Sir, long cells, height is more, nucleus is round. So you will say, sir, this is our cuboidal cell. But no, go for the overall. These are the confusing slide. In exam, your confusing slide will be kept. Yes, height is more, so better to go with the columnar epithelium. Agree everybody? Fine. These are secreting and storing. So where all the things are happening? Sir, GIT. So in the GIT you will see the columnar kind of the epithelium. Can you see this one? Yes, look here, there is our basement membrane. Fine. Multiple layer. So definitely it is our stratified layer. And can you see the topmost? Yes, sir, these topmost cells, are having the nucleus, and these nucleus are parallel to the basement membrane. So this is our stratified because multiple layer. Yes, flat nucleus, that's why squamous, stratified squamous epithelium. And nucleus is present means no keratin. Sir, this is the non-keratinized. Yes, sir, this is our non-keratinized stratified squamous epithelium. Agree everybody? Fine. So now where it is found? Remember stratified squamous epithelium, where there is the friction. Yes, it is found at the site of the friction. And remember, these are having the nucleus, living tissue, so these are wet. So whatever the part where there is the wetness and friction, there is the stratified squamous epithelium, non-keratinized. See here, common sense. Friction is there. Yes, conjunctiva, cornea, friction is there. It is wet, secretion is there. So what is your answer? Sir, stratified squamous epithelium. Yes, oral cavity, upper part of the pharynx, esophagus. Sir, there is the friction. Yes, there is the our friction, and there is the our you can remember wetness. So again same answer. Come down. Yes, our tip of the urethra, tip of the vagina, lower part of the vagina, lower part of the anal canal. These all are wet. Here is the friction. So what is your answer? Sir, non-keratinized stratified squamous epithelium. MCQ. But the part which is dry and friction, so there is our keratinized stratified squamous epithelium. Hope you all are getting the point. Fine. Yes, very nice. Now try to understand this special kind of the epithelium. Look with proper observation. Anatomy means cut and observe. So this is our, yes sir, basement membrane. Agree? Yes sir, it is our basement membrane. Can you see the different nucleus, stratified layer? But look at the topmost cell. Yes sir, it is showing the internalization of the cell membrane. Yes sir, it is showing the internalization of the cell membrane, even the binucleated nucleus. Yes, if you will use this stick, then exactly it is looking like the umbrella. Zooby dooby, something like that. A 3-Idiot movie. Yes, the dance umbrella you can remember. So umbrella cells are there. So definitely this is our what, sir? This is our urothelium. Agree beta? Getting the point? Yes, my iPad is getting discharged, its energy is getting down, but your energy and my energy, they are constant. Okay, so that is the stamina. Due to you all the students, I was able to complete this bullet train anatomy. Thank you very much. We are just near to the end. Okay, yes, when there is the urine, it is found in the urinary tract. When urine is filling, there is the stretching, and due to the stretching, it is transiting into the other appearance. That's why transitional epithelium. So this is known as urothelium. Yes, it is also known as the transitional epithelium. Agree everybody? So now we are looking for this one, this slide. We don't know. Okay, what is this? Where is the nucleus? You are not getting the point. But can you see this one? Yes, this color part, yes, it is our melanin hair. And at the hair root, can you see this soap bubble like appearance? Getting the point? Yes, actually it is the fat. During the slide preparation, fat has been washed within the organic solvent. Saman saman ko gholta hai. Chemistry rule. Yes, the organic solvent, they are dissolving the organic content. So it is our sebum fat. Yes, it is our sebaceous gland, and it is very old kind of the question. The our sebaceous gland, they are which kind of the gland? Remember, they are destroying entirely. Whole gland is destroyed. So holocrine gland. Simple. So this slide is important. Can you see this beautiful slide? Yes, dark band, light band, dark band, light band, dark band, light band, and nucleus, they are in a row. So definitely definitely it is our, yes, skeletal muscle. Agree beta? Now can you see there is the same, sir, dark band, light band, dark band, light band, dark band, light band, but here you can see the yes, skeletal disc, which are having the rich amount of the what? Gap junction. The only these slides you have to prepare. Okay, now see here, these are our spindle shaped cells. So these are showing the smooth muscles. Agree beta? Fine. Now look here, leave everything, but don't leave this cartilage and collagen. Don't read anything in your histology, but go with the cartilage, collagen, and maximum the epithelium. Okay, fine. So try to understand cartilage. So if any slide is there, you are looking the blue color nucleus, and around it, yes sir, there is the nucleus, and there is the our lacuna, and such kind of the many cells, different number of the cells. Yes, nucleus, lacuna, number of cells. So definitely it is our chondrocyte. This is the first principle. This is the first principle. And if there is a chondrocyte, so it is cartilage. Now try to understand, in this word only 3 types of the cartilage. Yes sir. Multiple cells, white color, yes sir, nucleus is there, clear space lacuna is there, 2 cell, 5 cell, 1 cell, yes sir, chondrocyte. Now look outside. Any fiber? No fiber. It is very, very clean. Glass like appearance, hyalo appearance. It is having the hyaluronic acid, the most abundant mucopolysaccharide in our body, hyaluronic acid. So definitely it is our hyaline cartilage. Yes, now there will be the option. So one MCQ, one trick, again the very bad kind of the mnemonic, so that you can retain in your brain. High, we are saying high when we are saying, when we are looking the GF car. GF की कार देखते ही हाई तौबा मचाना शुरू कर दिए. Yes, G for growth plate is having the hyaline cartilage. F for fetal cartilage is the hyaline cartilage. Costal cartilage is the hyaline cartilage at the rib. Articular cartilage, when you are eating the biryani, yes, chicken party, then end of the leg piece, they are having the hyaline cartilage. No excuse. Yes, osteoarthritis, this articular cartilage is getting degeneration. Then respiratory tube, yes, our C-shaped cartilage in our trachea, that is hyaline cartilage. Now come to the next. Sir, very bad slide. Can you see? Nucleus. Yes, clear space, lacuna. Now look outside. Yes, 1 cell, 3 cell, 5 cell, chondrocyte. Look outside. Sir, fibers are visible. Can you see? Yes, sir. Single, double, single, double, single, double, single, double. Fibers are visible. Single, double fibers are visible. Or sometimes, yes, such kind of zigzag, 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 zigzag. Snake-like fibers are there. So this is elastin fiber. So this is elastin cartilage. Single, double fiber. Kachada is there. No kachada. No kachada. Hyalo appearance, clear appearance, hyaline cartilage. If there is a single double kachada, then you will say elastin cartilage. Now, question, where it is found? Mnemonic is ETC news. So you will say ETC, E, 3E you have to remember. Yes, E for ear pinna, eustachian tube, epiglottis. Touch it, ear pinna, elastin cartilage, very soft. Yes, epiglottis, eustachian tube, same. Yes, you can touch the tip of the nose, very soft, elasticity is there. Also the tip of the arytenoid cartilage. Also you can remember the corniculate and cuneiform. So these are our different elasticity cartilage. Now see here. Yes. Can you observe this one? Yes, sir. There are the nucleus. Getting the point? Now you can see there is our lacuna also. Little bit. Sir, 1 cell, 2 cell, 4 cell, 5 cell, so on. Sir, definitely it is chondrocyte. Now look outside. Can you see? Outside there is red thick bundle. Yes, remember, red thick red thick bundle is nothing. This is our collagen, and whenever the collagen, then definitely damn sure your fibrocartilage. No excuse. Fine. See here, where this fibrocartilage is found, your mnemonic is Fiat logo. What you can remember, sir? Fiat logo. Yes, F-I-A-T, Fiat logo. F for fibrocartilage, I for intervertebral disc. This fibrocartilage is very strong. Yes, so it is giving very strength. Intervertebral disc, there is the entire body pressure. Yes, it is fibrocartilage. Articular disc in our temporomandibular joint. Yes, knee joint menisci. These are requiring too much strength. Tendon insertion, tendon is attached here, so it is requiring the strength. And glenoid labrum, acetabular labrum, shoulder joint and the hip joint, this requires strength, so fibrocartilage. And last, remember the collagen. There are many types of the collagen, 28 types. Raw histology, we are studying only the important one, you know, 1, 2 and 4. There are the many cartilage. You will see in the clinical also, but right now 1, 3, 4. 1, 2 and 4. Remember, type 1 collagen, this question had been asked. Can you tell me the type 1 collagen? Type 1 collagen, it is found in the BAL, ball. What is the BAL? Yes, not this ball. This type 1 collagen is found in the bone. A for, you can remember, the aponeurosis. What is the aponeurosis? Flat tendon is known as aponeurosis. So tendon is also having the type 1 collagen. And L for ligament. Getting the point? Type 2, only one thing you have to remember, the cartilage. Cartilage is not having, many times this question had been asked, no excuse, na? No excuse, beta. Only this thing you have to revise. I will provide this PDF to all of you. Okay, and only this thing you have to again and again. Bruce Lee sentence, first slide, our first slide. Yes, I don't fear from that person who is having the 10,000 types of the kick. I fear from that person who knows only one kick, but practiced for the 10,000 times. So same thing you have to revise again and again, and you have to make a proper balance between all the 19 subjects. Yes, type 4 collagen, it is found in the our kidney and lung basement membrane. Agree, beta? So if there is a damage due to any kind, like the mutation, type 4 collagen mutation, then kidney will show hematuria and lung will show, yes, there is the rupture of the lung part, the pulmonary basement membrane. So there is the hemoptysis. This is nothing but it is our what? Sir, it is our good posture syndrome, GPS. Your patho, your medicine integration, connective tissue disorder, don't forget it. This is mutation. Type 4 collagen mutation. So that's why you will see more collagen part in your different other points. Okay, yes, one more thing left, So last I'm telling you the cerebellum. Unfortunately, I'm not having the cerebellum slide. So just I'm just telling you magic of cerebellum. What you have to remember? Magic of 1, 2, 3, 4, 5. Okay. Yes. There is the one vermis. There are our two hemisphere. There are three peduncle, three histological layer. There are three anatomical lobe. There are three physiological lobe. Yes, we have to study the 4 nucleus. We have to study the 5 neurons. Complete. This is your cerebellum. Agree? So easy. Fine. So now try to understand. Yes. I'm just making the diagram. I'm not having the images. Sir, this is the vermis and these are our cerebellar hemisphere. Yes. You will see there is the our fissura prima, horizontal fissure and our flocculonodular lobe. Okay, sir. Just one information. Fine. You will see the 3 peduncle. What are the different 3 peduncles? See here. Yes. There is a midbrain, pons and then medulla. Yes, you will see there is our cerebellum. Fine. Yes. You will get there are the 3 peduncles which is attached with the midbrain, which is attaching with the our pons, which is attaching with the our medulla oblongata. So what you can remember? Sir, this is superior cerebellar peduncle. This is our middle cerebellar peduncle. Here is inferior cerebellar peduncle. Yes, it is attached with the our what you can remember midbrain, pons and medulla. Fine. Now, histology is very important. That's why I'm showing you the cerebellum histology and it is very easy. Cerebellum is known as, yes, arbor vitae. Fine. So whenever you are looking the tree, fern tree like branching pattern, so it is our cerebellum. So simple. Fine. Fern tree like branching pattern, then definitely it is cerebellum. Any kind of the slide you can see there is a fern tree like branching pattern, zigzag appearance. I will tell you the sale. Yes, this is the beautiful. This is the most beautiful slide you can say. Fine. So I'm adding this one, the fern tree like branching pattern for your knowledge. What you have to remember? Yes, sir. There is our fern tree like pattern. Remember, this cerebellum is also known as the arbor vitae. Arbor means tree. Vita, I mean vita means life. So it is considered as the life tree, tree of life. Yes. So this is important. This is also known as the little brain. You know, Nana Patekar? अच्छा है. यहाँ पीछे नहीं मारना चाहिए, पीछे छोटा दिमाग होता है. Yes, Nana Patekar knows which is the little brain, this cerebellum. Fine. Now we are looking the our histological more layers. So there are the 3 histological layers we are going to look for them. Adding the slide for all of you. Yes. Can you see? You can remember LPG gas. Just in place of the L, you have to use the M. So when you are looking the cerebellum, you will see the molecules. So you will say molecular layer. You will see the Purkinje cells. Yes, Purkinje layer. And you will see the granules appearance. So granular layer. Okay. So you can see here the molecular layer, this one. Then if very carefully, unfortunately I was unable, I forgotten to include these slides. Better slides we can add here. So at this part, the flask shaped largest cells are located. These are Purkinje cells and inner side granular layer. Fine. So you can remember one more thing, MPG. These are having the 5 types of the neuron. What are the different 5 types of the neuron? Yes. In this way you can remember Bahujan Samaj Party. Okay, you have to give proper respect. Mayavati is there, that's why. Okay, so what you can remember, these are our 5 neurons in the molecular layer. Yes, there is our basket cells, there is star shaped cells, stellate cells. Yes, in Purkinje cell layer only one thing is there, that is our Purkinje cells. In physiology, you will see the very important question from the Purkinje cell. It is the sole efferent. Yes, it is the largest neuron. Yes, you will see the many question. It is inhibitory to the our deep cerebellar nuclei. G for you can remember the Golgi cells. G for you can remember our, yes, granular cells. Complete. Fine. And now we are coming to the clinical. Remember, cerebellum is important. One question sure from the anat or physio, or you can say pharma. Remember, lithium is cerebellar toxic drug. Yes, with the medicine, any kind of the thing. Okay, so try to understand cerebellum. This is our bus. You know, there is the driver. Yes, sir, driving the bus, but at the back side there is the one conductor also. Agree, everybody? So I'm telling you the clinical points of the cerebellum. Yes, see here, you can easily understand, sir, this is our bus. Tell me, if there is the no driver, bus will move? No, sir. Now, if there is a no conductor, bus will move? Yes, sir. Driver will move the bus. Fine. But now try to understand. If there is a no driver, bus will not move. What is the role of the conductor? Yes, conductor give information to the driver. पैसेंजर आ गया है, रोको 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 रोको, हाँ पीछे लो पीछे लो पीछे लो, नाली है नाली है, रुक जा रुक जा रुक जा रुक जा. Yes, he is guiding. He says about the speed, about the passenger. He proper coordinate. He make proper balance. Yes. Now, if there is a no conductor, bus will move. Driver will move the bus, but bus will hit here and there. Passenger, they will get injury. Bus will get injury. Agree? Now apply in our body. This driver is nothing. This is our brain. It is also, you can say, pyramidal tract. This bus is nothing. It is our body. And this conductor is nothing. Sir, it is cerebellum. It is basal nuclei. It is extra pyramidal tract. Now all the things are clear. Try to understand. If cerebellum, basal nuclei, these all are not there, then brain will move the body. But there is the incoordination. We will go here, we will go there, drunk can get. Getting the point? Fine. There will be too much abnormality. Proper, yes, there will be loss of coordination, loss of balance. Loss of coordination is known as the ataxia. So you will see the clinical point NIDRA, निद्रा. निद्रा, रात हो चुकी है, जो अब आपको आ रही है निद्रा. Okay, so you can remember, cerebellum is responsible for the extrapyramidal function, means tone. I am telling you the physiology. Cerebellum is responsible for the tone. Tone is responsible for the proper posture. Posture is responsible for the equilibrium, and equilibrium is responsible for the movement. And if there is the movement, then there is the life. So there is one beautiful shairi by the Javed Akhtar Sahab. Yes, what I want to tell you. Yes, just to see here. Just I will take few more minutes. So thank you very much. Javed Akhtar shairi. So what I want to tell you. Yes, रास्ते हैं, something like that. मंजिलें हैं तो हौसला है, something like that. You will see. Okay, I'm not getting exactly, but that शायरी was रास्ते हैं तो मंजिलें हैं तो हौसला है तो something like that. Okay. Oh, unfortunately, I'm not getting that शायरी. But yes, there is a one शायरी. रास्ते हैं तो मंजिलें, मंजिलें हैं तो हौसले, हौसले हैं तो तकलीफें, तकलीफें हैं, something like that. In the same way, yes. टोन है तो पॉस्चर है, पॉस्चर है तो इक्विलिब्रियम है, इक्विलिब्रियम है तो मूवमेंट है, और मूवमेंट है तो जिंदगी है. Yes, and this all are possible due to the cerebellum. Remember, okay? So what I want to tell you, yes, cerebellum is important for the proper tone. And if tone is there, then you can sit at the chair, posture is maintained. If posture is maintained, then you can do the proper equilibrium, and if the equilibrium is there, then you can do the movement. If there is the no cerebellum, then loss of tone, loss of posture, loss of equilibrium, loss of movement, you can say loss of life. Cerebellum is very important. Agree? Fine. So if there is a damage of this eyeball, medial rectus, lateral rectus, tone is altered, so eyeball will do pendulous jerky movement. This is your nystagmus. Getting the point? Yes, it is maintaining the proper tone. But if there is a damage, yes, the patient will do the intentional tremor. Normally he is right, but when he will hold the glass, there will be the yes tremor. So this is no excuse. Remember, intentional tremor. One question sure from the cerebellum. And D for yes, remember, ability to perform the rapid supination, pronation, flexion, extension. This is your, yes, remember, diadochokinesia. If there is a damage in the cerebellum, there will be the diadochokinesia. Remember, you know Amitabh Bachchan? Yes. Hi. So he is dancing. बड़ी पटाखा दिल चुरा के ले गई सोना सोना दिल मेरा सोना. So this is the Amitabh Bachchan. He is saying that my cerebellum is very okay. Supination, pronation. One funny thing, remember this rapid supination. Tabla bajana. Yes, we are doing the supination, pronation. If your cerebellum is okay, then you can coordinate this all the alternative rapid movement easily. Remember this one. R for you can remember the, yes, Romberg's sign. You can remember the rebound phenomena. Getting the point? What you have to remember? Ability to walk with the closed eye in the straight line. When we are closing the eye, the visual sensation, they are lost. So cerebellum is doing all the proper three-dimensional orientation, and we are not falling. If we are having the damage in the cerebellum, as the person will close the eye, he will fall at any side. This is your positive Romberg sign. Rebound phenomena, yes, in first MBBS we did the practical. We are holding the front and we are suddenly leaving, so body is getting down and then we are holding. This is due to the cerebellum balance. And A for, remember, ataxia. A for A, yes, you can remember asynergia. Definitely one question from the cerebellum. Fine. So ataxia is loss of coordination. Asynergia, there is the rate, range, direction and force. Rate, range and direction, force. This is known as synergia. Try to understand. This is one glass. I am looking to you. My hand is starting from here and exactly without looking to the glass, I am just ending at the glass. Yes, three-dimensional orientation. Who is giving this direction to the brain? Answer is cerebellum. Getting the point? So this cerebellum is giving the proper rate. Neither too much slow, not too much speed. Rate, range. Exactly my hand is starting from here, exactly ending at the side of the glass. Rate, range, direction. My hand is not doing the past pointing, not here and there, exactly at the glass. So this is our direction. And force, appropriate force. Neither too loose that it is getting down, not too much tight, my hand or glass is getting injury. So this is the force. This all are done by our, yes, cerebellum. If there is the damage to this rate, range, direction and force, then it is known as the asynergia. Also you can remember the scanning, speech, yes, slurred speech. Cerebellum is properly making the coordination between the tongue, this all. So this is, there are the many points you will see in respective subject, but I think thank you so much for you all. So last final message for you all, you know, Shri Ritik Roshan Maharaj ji, he is saying, yes, ek pal ka jeena, life is only for the 1 second. But after few days, he is saying, Zindagi do pal ki. So confusion is there. Yes, the life is for the 2 second or for the 1 second. So lots of confusion in the Hollywood, Bollywood and Tollywood. And the great our, yes, Shri Salman Khan Maharaj ji, who is living just on side of the sun. Asaram Bapu ke baju mein ye rehte hain, you know all. He is saying, jeene ke hai 4 din. Okay, so there is too much confusion. Yes, we have to live for the 1 second or 2 seconds or the 4 days. And whenever keep your observation strong. Yes, you are doing the NEET PG exam, and in life you're strong, kind of the observation. He is not the hero. Look at the side hero. Yes, he is more handsome than our Salman boy. What a pant, what a body language, what a curvature, what a smile, and what are the goggle. And yes, you can compare the Golmaal. Tushar Kapoor is also dancing here. Yes, जीने के हैं 4 दिन. So remember, there is a too much confusion. So remember, कौनो फिरकी ले रहा है, e wrong number है, सब मोह माया है. So life is better when you are laughing. All the best. God bless you all. Any kind of the problem, yes, you can ask me at any time at the platform of the Cerebellum Academy. So thank you very much. God bless you all. Any doubt here, beta, please ask. I will modify this PDF, all the things, and we will share. Na? Fine. Yes, any doubt, beta, any doubt? There are the more things, more things, but a bullet train anatomy, I tried. Okay, yes, thank you. Yes, Manjeet. Yes, thank you, Manjeet. Yes, Lamrit. Yes, thank you, Lamrit. Thank you, my all the thanks to all of you students. You supported me, so I was able to take this. I was able to complete this all the session. I can say this is not the complete anatomy, but even in this short time, in this limited time, you can go for more and more revision. Number of the revision. What I want to tell you, the first slide again. Again, I want to inform you, yes, please, this is my humble request to all of you. We all are student, we are learning from our teacher. Yes, creativity is contagious, pass it on. Fine. We learn from our teachers, from our friends, fine. And we are making creativity and we are spreading to you, all of you. I am not knowing all the anatomy. I am not too much intelligent. Just I had learned from my department, from my HOD, from my friends. Right now also, we all the academic teachers, all the institute teachers, we are connected together. We are learning from each other and we are sharing, we are passing this knowledge to you. Now it is your responsibility. You have to pass this knowledge to your friends, your next generation. We have to make the life for better to live. Yes. And again, for your exam, Bruce Lee, I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. You know, Bruce Lee, he was doing the movement. Right now, any Hollywood movie or South Indian movie, we are doing in slow motion. And editing, cameraman, they are making fast. But when the Bruce Lee, he was moving this one, so he was having so fast skill that cameraman during editing, they have to slow. So great person. He told, practice gives perfection. Concise your all the content, either anatomy or the radiology or the medicine or surgery. Concise the content, follow the one notes and study for the multiple times. And you have to do same thing for all 19 subjects. So there is no use of the study too much. Don't study too much. Study the less content, perfect content for the multiple times. Agree? Yes, thank you. The doc IDK. Yes, sir, good evening, sir. So here my respected Dr. Garg sir is here, and I'm blessed that I can join the Cerebellum Academy. I'm very thankful to Dr. Garg sir, Dr. Apur Mehra sir, Dr. Sparsh Gupta sir, Dr. Vivek Jain sir, Praveen Tripathi sir, each and every faculty in the Cerebellum team. Okay, my very good friend Dr. Anand sir, yes, Priyanka ma'am is here, Rana ma'am is here, and many more faculties which you all will be aware. Okay, so my thank to everybody, very special thank to the GRG sir. Yes, thank you Ankit, thank you Himank. Yes, sure, beta, sure, Disha. Yes, I will few modification I have to do. Okay, by asking to the team. Okay, so whatever the process of the I think logo or this all the things I will ask to the team and then we will share. Don't worry, tomorrow you will get. No, you will get tomorrow. Yes, yes, very too much thank to Dr. Jana Vora ma'am also. Sorry, I forgotten the name. Sorry for that. I'm very happy. So I am getting so thank you to all the team members. Jana Vora ma'am also. Every team member. Thank you, GRG sir. Thank you so much. Due to you, only and only you, I am at this Cerebellum team, and this was my dream that I can teach the students under the guidance of you all the great legend teachers. Yes, beta, yes. Okay. Thank you, beta. Thank you. We will share tomorrow. Yes, Pulsya, Devesh, everybody. Yes, yes, definitely. Stay connected with my Instagram, with YouTube channel, everything. Dr. Shrikant Verma classes is this is the ID. At my Insta, you will get the funny reels also. Study also. Fine. So can we end? Can we end the session? Thank you so much. Thank you, Parth. Thank you, Abhineet. Kunal, thank you. Thank you. Best actor, thank you. Okay. Any more doubt? Any doubt, beta? Any doubt? Any doubt? So can we end the session? Okay. Can we end the session? Okay, so just few beautiful lines. These are the so beautiful lines. So always I want to say everybody, every session I say this all the things. So again I am repeating. So remember, सिर्फ हंगामा खड़ा करना, सिर्फ हंगामा खड़ा करना हमारा मकसद नहीं, कोशिश है कि सूरत बदलनी चाहिए, हमारे सीने में नहीं तुम्हारे सीने में ही सही, कहीं भी हो आग लेकिन ये आग जलनी चाहिए, ये आग जलनी चाहिए, ये आग जलनी चाहिए. वी हैव टू मेक द वर्ल्ड बेटर टू लिव. ऑल द बेस्ट. गॉड ब्लेस यू ऑल. गुड नाइट. शब खैर. टेक केयर. आराम से धीरे धीरे करते हुए रिवीजन करते जाइए. डेफिनेटली यू विल क्रैक. आवर बेस्ट विशेस टू ऑल ऑफ यू. ओके. So thank you very much. Ending the session.